program on knee problems, which we've been holding for many years now, but for 2 years it was curtailed due to the COVID epidemic. Um, this is something which really is the initiative of Dr. Arvind Gupta, and he does all the hard work for it and organizes it, and it's a pleasure to have all of you here. We will have a number of cases that we're going to discuss, and it's going to mainly focus on arthroscopic techniques, salvage of the knee in early degenerative arthritis, and on patella instability. So this is going to be the main focus of the meeting. And uh, I welcome all the faculty who've come. I think Arvind will go through the list of people who are there. And we will start with a brief lamp lighting and then get on with the actual program. So welcome everybody. I hope you find this useful. I think there's going to be a lot of useful material presented during the meeting, which is an area where there's a lot of confusion for. So without much ado, I think we should get on with the lamp lighting and request Arvind to come up and invite the dignitaries for it.
Good morning, everybody. I am requesting Dr. Anil sir, Dr. Ashish sir, Dr. S.S. Jha sir, Dr. Rakesh Chaudhary sir, Dr. Manish sir, Dr. Suhas sir, Dr. Deepak Joshi sir, Dr. Bhushan Sabni sir, Dr. Rajiv Raman, Dr. Pankaj, Dr. Binay Pandey from Varanasi, Dr. Soumyadeep, Dr. Manish. Kindly come on the stage for the lamp lighting, please.
So brief word, I think Dr. Suhas Aradhya is the facility director of Paras Hospital, and they have done a lot to help with organizing the meeting. So certainly welcome Dr. Suhas.
Dr. Rajiv Anand sir, please.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
चढ़ायो अच्छा गजमुख को दिल लाल विराजे सुत गौरी हर को हाथ लिए गुड़ लड्डू साई सुरवर को महिमा कहे न जाए लागत हूँ पद को जय देव जय देव जय जय जी गणराज विद्या सुखदाता धन्य तुम्हारो दर्शन मेरा मन जमता जय देव जय देव
Thank you, everyone. We'll start with the session 1, that is meniscus session, and the moderator is Dr. Manish Ranjan. Dr. Manish Ranjan, please.
Good morning, everybody. Myself, Dr. Manish Ranjan from PMCH. Welcome you all to the first session of the day, that is the meniscus session. Not long ago, the treatment for most meniscal ailment was meniscectomy. But of late, we orthopods have realized the significance of meniscus preservation. To chair the session, I invite Dr. Prabhat Prakash sir, Dr. Rakesh Chaudhary sir, Dr. Alok sir, and Dr. Bhushan Sabnis sir. Please, sir, please honor the. Thanks, sir. Dr. Alok, sir. Yeah. And the first talk is on meniscal tear by Dr. Ravi Yadav. Ravi Yadav, sir. Thanks, sir.
विनय ये स्लाइड यहाँ से खुल जाएगा वही लगा स्लाइड ओपन यहाँ से है ना
Good morning. A very important session. I think in arthroscopy, meniscus are really in vogue. We are really into it. Preserving the meniscus or balancing it has been a difficult choice to make, but certainly the pendulum has gone towards meniscus repair. And I will, as soon as you are ready, you're ready. Sure. Great. We start with the first talk.
Good morning all the senior persons and good morning on warm welcome to all. I will be presenting a case on the meniscus tear, sir. A 32 years old male with alleged history of bifall. 3 weeks ago, he came to our Paras hospital with the pain and instability over the left knee. And he was having difficulty in walking since 3 weeks. So we have done the local examination and the tenderness was present all around the knee joint. The range of movement was painful all around and it was 0 to 70 degrees, sir. On clinical examination, the anterior dot test was positive, latchment test was positive, pivot shift could not be done because of the pain, and Mac-Morris test was positive for the lateral meniscus. There was tenderness along the joint line, sir. This is the pre-op advice for the X-ray and your advice for the MRI. This is the plain X-ray we are seeing. This is displayed here. We can see there is no bony fragment. Those we have also advised for the MRI. This is the MRI picture we can see here. We can see the ACL tear along with the meniscus tear because there is some hyperdensity there seen in along the. This is the second picture. So coming to a conclusion along with the MRI and in the clinical examination, we can see that there is a lateral meniscus tear along with the ACL tear. But I am going to concentrate on the meniscus part because I have got a topic for the meniscus part, sir. So what can be done, sir, after seeing the MRI and seeing the clinical examination, what can we do for the further, sir? What is the planning for the further surgery and all, sir? Can you suggest? Seeing the, sir, MRI, there is meniscus tear and there is ACL tear, but we are concentrating mainly on the meniscus tear, sir, and on the clinical examination too.
Looking at the MRI that the trauma is quite recent.
Yes, sir.
Certainly, ACL reconstruction or whatever, repair, whatever you are comfortable you will be doing, and a meniscus repair, after seeing really doing a diagnostic arthroscopy, what is the condition of these and how much tear it is, we would certainly attempt to do a meniscal repair.
So finally, we have decided for the arthroscopic repair for the lateral meniscus and the ACL tear. So coming to the diagnostic, we have done, first diagnostic has been done, and this is the intra-op. This is the picture, this is the video I'm playing, in which we can see a longitudinal tear along the lateral meniscus parts, the posterior horn, we can see there, sir. Around 2 centimeters, this is a longitudinal tear. We can see the ACL part also, ACL tear is there. This is the ACL part, medial meniscus is okay, sir. This is the lateral meniscus, we can see the tear there. This is the tear we can see, sir. Sir, so we can see there is tear in the lateral meniscus part and there is also tear in the ACL part. So what comes to the mind? What are you all are following, sir? Inside out, outside in, all in technique, in your clinical practices, sir, please.
I think this is the dangerous area of the lateral meniscus, very close to the neurovascular bundle. So an all-inside device would be ideal. If you are a brave surgeon and if you have the resources, you can of course do a posterolateral incision and window and do inside out also with a Henning spoon. But a simple all-inside device, if the patient is affording, will be quite ideal. I think that's what you would have done as well.
Yes, sir, fine, sir.
I knew you were going to ask that, Arvind. So this is one of the most common lateral meniscus tears that you see with ACL reconstruction. So acute ACL, so these areas are well supplied with blood supply. So it is good blood supply because it's a posterior half of the lateral meniscus. Unless it's extending into the popliteal hiatus or it's unstable on probing, theoretically you can leave it, but most of us have now got access and ability to repair this. So, and as surgeons we sort of repair it. But yes, about 5 years back we were leaving this just as it is without much of a problem to the patient. Only thing, the rehabilitation was a bit slow.
So are we going for a, sir, horizontal, vertical, on which type of? Okay, sir.
Yeah.
Sorry, sir.
This is a small tear about less than 10 mm, suppose.
Around
So
1.5.
you may leave it as such. Theoretically, you repair the ACL and leave the peripheral tear longitudinal, a small 10 mm tear, it heals itself. Because your patient is young, there is a good healing capacity. So you may leave it as such.
So which will be better options, sir, leaving or doing it?
So-
Better for the patient. If you have got all the facilities, what is the better option, sir?
So I suppose it is a small tear, you leave it as such.
Leave for this one.
Dr. Ravi,
Yes.
did you calculate the length of the tear?
Yes,
Yes,
around
2 centimeter.
2 centimeters.
He said that it is 2
2
centimeter.
centimeters.
2 centimeters.
He said
So
2
it's-
centimeters.
so
So
it's-
2 centimeter.
So it's more than 10 mm.
More than
So
10
you need to repair it, I think so.
Yes, sir.
I think this is the one of the meniscal tear which we are confident that it will heal. Fresh fracture with ACL at a zone almost 1/3, 2/3 junction. So we are almost very much sure that it will heal unless we are in a deep trouble. Then only it will. So still, we will all prefer to fix it.
Okay, sir. Thank you. Keep in the mind the patient is the young. We proceeded with the repair of the meniscus, sir. This is the video I am going to play of the meniscus. This is the video, sir. All inside technique 360 we have used, sir, for this horizontal and one vertical which has been taken. This is the knot cutting, sir. Again, second. So the closure was very stable, sir. So coming to the, this was the post-op X-ray done for the patient, sir. This is the AP view and this is the lateral view. Coming to the, sir, post-operative rehabilitation program. Any comments on the rehabilitation program, sir, for both lateral meniscus tear and ACL tear?
Okay, so is the weight bearing and deep knee flexion which are the culprits for causing damage to the meniscus. As dictum states, we normally say non-weight bearing for 3 to 4 weeks and avoid deep flexion more than 90 degrees for 4 weeks. But it has been proven that the patient can weight bear in full extension with a brace on. It doesn't cause damage to the meniscus. But we are all very anal about our patients and we are very careful to avoid any injuries. So I think that's what we follow. So 3 to 4 weeks non-weight bearing, avoid bending beyond 90 degrees for first 4 weeks and then gradually start movement as possible. I think the easiest way to remember is 30, 60, 90, 02 to 04, 4 to 6 weeks as range of motion.
Yeah, but per operative, I would say really important how you deal with the meniscus tear per operatively because it was a fresh fracture, but the resurfacing, you do the thing. That is really important, which has to be stressed upon before doing any meniscal repair. Just going in fresh tear, okay, but still, if it had been a bit old or you have taken 3 weeks, 4 weeks to go down there, you should have, you could have done that. You should have stressed onto that. That's post-operative rehabilitation. True, I keep for 6 weeks, non-weight bearing. It gives 4 weeks, but that is the protocol and we follow it.
Ravi, do you want to augment your repair?
Yes, sir. What can be other methods to augment the repair, sir?
Yeah. So you may use the PRP or the blood clots or drilling near the macrofractures. So what your way to do it?
No, we have done the microfractures are there, but other people are using. So, what are the other things we can add to that?
But with ACL tear, recent ACL tear, you really do not need to do. If it hasn't been just an isolated meniscus tear with ACL, this is really a thing, blessing in disguise for you for meniscal repair. It really helps you to
And
go
sir,
tight.
any change in the protocol if it was medial meniscus rather than the lateral meniscus along with the ACL?
I don't think so. No, we don't. I
Okay,
don't
we have
think-
followed the same protocol, sir.
Almost. It is a. We don't try to make things complicated. Each and every third, we are making a different protocol. A simple protocol so that you can follow your physiotherapy. Even if he changes, he can follow. You have a physiotherapy now, 3 days somebody else and 3 days somebody else, and everybody giving his own protocol. So it's plain and simple protocols are good enough.
So a meniscus repair with ACL. Since you are already doing tunnel for ACL reconstruction, lot of PRP, bone marrow product already inside the joint. So no need for any augmentation. But in case you are doing isolated meniscus repair, then the puncture in the condyle of the femur is necessary. Joshi sir, your comment on isolated meniscus repair, anything for augmentation?
I think we do microfractures in the notch and around the meniscus. That is what we are doing for, basically for creating some biology to heal.
Okay. Should we?
Is there any evidence-based guidelines as to whether a tear like that should be repaired or not when you're doing an ACL? What if you didn't do anything and as opposed to if you repaired it?
There is a guideline that a small tear you should leave as such if it is in the peripheral part. So it is about 10 mm in length, you should leave it as such.
So, I mean, what I mean is, have they compared the effect of doing it and not doing it in a particular tear like this? If it's...
Must be somewhere, but not in my mind straight away. Right. Thank you, Ravi.
Okay, sir.
Yeah, thank you very much. Should we call Dr. Arvind for his talk on bucket handle tear?
This is 24-year male, 10 days old injury, and came to OPD with around 20 degree of knee flexion with X-ray. That was absolutely normal. So, Rakesh sir, what comes in your mind? X-ray normal, 10 days old injury, 20 to 30 degree of knee flexion deformity. After that, 30 to 90 degree is fine.
Free.
But more than 90 problem, there is no knee is in 20 degree of knee flexion.
Mostly true, being arthroscopic surgeon, I will definitely think of a meniscus bucket handle tear locked into the intercondyle notch, and which is not allowing the full extension. So that would be my first provisional diagnosis, and then we can go ahead.
So, Bhushan sir, locked meniscus, locked knee, what is your approach for any type of locked knee?
So that's the one of the rare conditions where I advise immediate surgery. I don't like to wait with locked knees. I've had my hands burnt with delaying ACL reconstruction. Just just wanted to delay ACL reconstruction in acute knee. So I left the meniscus as it is in a locked position long back when I still had good hair. And to my disdain, when I went back in the joint, the meniscus was almost half shredded with secondary tears. So this is the only condition where I would go immediately. I'll ask the patient to get an urgent MRI, confirm the diagnosis and surgery the next day.
So, message is any locked knee, urgent MRI to confirm your diagnosis. It should not be delayed in case of locked knee.
Dr. Arvind, what is your opinion about the immediate try for the reduce the locked knee under the anesthesia in your emergency room if patient comes immediately after the locking the knee?
Many a time knee is lock in 20-30 degree of flexion, maybe because of patella dislocation. So you can confirm your diagnosis with X-ray or any osteochondral fracture, that you can confirm it with your X-ray. If X-ray is normal, my approach is, if X-ray is normal, urgent MRI should be asked without doing anything to the patient.
So, so
No,
in this
same thing I am saying. So I don't touch the patient because it is very painful most of the time. Just gentle range of motion, whether it's coming or not. If it's not coming, I don't do. I don't ask for the deduction under general anesthesia.
So, Dr. Arvind, you were talking about the scenario where there is MRI always available. So most of the people are coming from the districts. So they have not the MRI in their hands. So what they follow, you have to tell about that.
So locked knee have many differential diagnoses. So without confirming the diagnosis, taking the patient to the OT, I think maybe Joshi sir, what is your approach in such type of cases? X-ray is normal, 30 degree of knee flexion, knee is low.
Earlier, I have tried reducing, we have tried, I think, reducing the locked knee. Sometimes it may unlock. The meniscus can go inside if we do the maneuvers. But I think most of the times it doesn't. And since we have now most of the facilities available, patient can travel. If we see the scenario where nothing is available and the surgeon is not confident of putting the scope inside, we can take the patient to the emergency OT and put the scope inside. Everything is, I think, visible. I think we can do whatever we want. We want to repair, we want to remove. We have all the options available with us. So I think these days we should confirm the diagnosis and do a diagnostic arthroscopy as early as possible.
Yeah, blindly if you do it, there are high chances that you can complete the tear. You complete the bucket handle, this thing. So it's not a good idea, I feel.
Regarding particular bucket handle tear, many of the time patient itself tells the story. So many patient coming from the periphery, he told like that कि सर मेरा पैर इस पोजीशन में फ्लेक्स हो गया था, ना तो हम आगे कर पा रहे थे ना पीछे कर पा रहे थे, हम पैर पकड़ के थोड़ा सा आगे किए, मेरे को आराम मिला, मैं ठीक हो गया. But 10 दिन या 15 दिन के बाद again he had the same story. So particular bucket handle tear, patient is itself told the story about how to reduce the flex knee.
Even in UK, not in the districts, but in UK, you do not get MRI straight away. So our protocol was, if the patient comes with a locked knee, we get an X-ray and take the patient is in emergency, infiltrate the knee with lidocaine or bupivacaine, completely relax the patient and then see if you can straighten the knee. So confirm whether it is locking or pseudo-locking. If it is locking, then patient goes to theatre on an emergency list, which is like, or urgent list, which is 2 to 3 days time. MRI will not be done in NHS during that time. So he will go to theatre for a diagnostic arthroscopy plus minus meniscus repair or meniscectomy as the situation demands. In India, the scenario is different. We can get urgent MRIs, so probably doing an MRI would be a better option. And I don't think leaving a locked knee as it is would be advisable. But we should confirm whether it is a true locking or pseudo locking prior to proceeding for surgery.
स्लाइड नहीं मूव कर रहा.
Important thing is that wherever you are, even if you don't have the facility of doing an MRI, just doing something into anesthesia, because you should have some idea what I am going to do, what I am planning to do. And even a state like Bihar, almost now, every district has got a MRI, I do believe. सब जगह आता है, नया पुराना सब जगह अवेलेबल है. और नहीं तो उसको एम्बुलेंस पर दौड़ा देना है, करवा के ले आओ.
I think if MRI is not available, at least this MSK ultrasound can help you out.
Yeah, it is true. It is. Yeah, I think musculoskeletal ultrasound is more difficult to get than MRI. MRI certainly you can get and you can at least read it. But ultrasound is very difficult to even follow for you.
So the final thing is that before you proceed with the patient doing anything manipulation, I think better to confirm the diagnosis and then do it. Otherwise, you'll end up more in trouble.
So since we are waiting for Arvind to get the images on, something different. There's a new portable MRI scanner that have been introduced in UK now. These are 0.5 Tesla and they can be connected to a normal electrical socket. They are that a drum size MRI. It can be transported from anywhere to anywhere. And that's sort of the next big thing. They can transport, they can put it in an ambulance and it can go anywhere you want for MRI. I think that's something which will be fantastic. So it's useful for limb MRI and brain MRI, not for torso or chest or abdomen, because that's too deep penetration required. So we need to think of out of the box something like this. But if we don't get an access to MRI, how many of you would try and reduce the meniscus or just leave it as it is and take the patient to theater the next day and diagnose on table and decide on table? So anyone with, you leave it? Okay. So leave it. I think manipulating a knee is more damaging to the meniscus because you do not know whether it's a partial bucket, if it's a double bucket, or if it's just a root tear which is shifted. So before thinking of manipulation, I think you should have some diagnosis to confirm what you're going to do. And lastly, I think one of the things that you said about injecting lidocaine in the joint, I think we should be slightly careful. Lidocaine and bupivacaine both are quite chondrotoxic. So there's a big hula about this about 3-4 years back when the paper came out about chondrotoxicity of local anesthesia, and that has changed practice in a lot of areas in Western world, including India. So we rarely now fill the knee with lidocaine, as you say. It's better just do little amount of local, and if it's a must, you can take the patient to theater under short GA, do an arthroscopy and confirm the diagnosis. And you can reduce it physically and put the knee in extension in a brace and then come back later. I know it's overkill, but if you don't have facility for anything, this is an option in my opinion.
Yes, please. Coming to the last case, we have now few devices which are like not blind devices like knee scorpion kind of device, managing the posterior horns. So what is your choice, doing a blind all inside devices that used to come earlier, or these new devices which have come for taking the posterior horn stitching?
Posterior horn, if it has been a horn, certainly root tear. I would have
posterior horn. So
horn may because getting into even the mini scorpion is sometimes a bit harsh, difficult proposition. This comes in a very handy thing and very smooth. In and out is not really a problem. Mini scorpion I use for the root tear to get 2 or 3 suture onto it and then pull it down. For me personally, I use mini scorpion for the roots, not for the posterior horn or posterior part.
Dr. Bibik, I used to do this meniscus tear, lot of these with circumferential stitch using this mini scorpion. That stitch is very strong. In fact, I will say one of the strongest stitch, very less likely to fail. Only problem with that, you have to take the knot in the posterior part of your meniscus toward the capsule. Otherwise, many a times it's remain over the meniscus body that may rub to the cartilage of your femur or tibia. So only that tips you should do if you are using that miniature. That is very strong stitch, very less likely to fail. And this is very good if it is the horizontal tear in the meniscus. So you can close this, and also very cheap also. You need hardly this anything suture form, and that can be used without paying a lot of money.
Thank you.
Thank you. So this was the MRI of this patient. Urgently MRI was asked, and this was the MRI. So we can see the double PCL sign is here. So it was, and in the posterior horn of the medial meniscus, you can see the complete meniscus is not there. So this was the case of bucket handle medial meniscus tear with ACL tear. And this was the coronal images of MRI. That was again confirmed with this bucket handle medial meniscus tear. And this was the intra-op picture. The ACL was torn, and this was the इसको छोटा करो जरा. This was torn ACL, and this was the meniscus which was torn. That was locked. Because of this, the knee was locked. So this was reduced with the help of probe. This was getting reduced, and this was staying at the place. Bhushan sir, suppose this was not getting reduced.
If it's a chronic tear, if it's already got adhesions to the ACL remnant or to the PCL or just scarred to the tibia, it sometimes is unreducible, and that is one of the conditions where I try and release as much tissue as possible from the adhesions using your scissors or small biters and try and reduce it. But yes, a couple of instances I have not been able to reduce it, and I just excised it completely.
So in chronic bucket handle locked meniscus, many a time it is very difficult to reduce it. So in that case, you may need to do the meniscectomy. Or if many a times it get reduced, but again dislocated back.
Yes, two things are really important. It should be reducible and it should be stable reduced.
Yeah.
If either of them is not there, you don't repair at that time.
Repair chances having high failure rate. So this was a stable there. You can see after living with this. So this was the most unstable part of that meniscus. So first stitch was placed there. The same approach you do also, Bhushan sir? You start from the posterior horn or the most unstable part?
It's the corner. So if that's the meniscus, the posteromedial corner is the ideal part to take a hitching stitch, as it's called. I normally do inside out for this to save some money. I just do a couple of all inside in the posterior horn. Everything else is all inside out for a medial meniscus.
Perfect. Same thing was done here also. So this was the first stitch to keep the meniscus at its place. So it was all inside, but many a time I do also by inside out. So first stitch there, and once meniscus was stable, then I shifted to the posterior horn. Here there is a problem with the space. So all the time you have to do the pie crusting. That was done here also. Once the adequate space was there. So here now it's adequate space. So after that it was planned for the all inside meniscus here also. So again all inside meniscus, it was the horizontal stitch. And after this is the position. So I shifted the working portal to the opposite portal, so that from that position it comes directly in that field. So another all inside stitch. and now it is inside out. That is, this is the zone navigator by the arthrex. So this is the tape, meniscal needle with tape it is. So first is there, and after that this is the second one. So the here viewing portal is the anteromedial portal and the working portal is anterolateral portal. From here directly it comes directly over the meniscus, placing the this zone navigator cannula is easy. So 2 inside out and 3. So this big area was there left. So another stitch in the posterior horn. So Bhushan sir, how much is the distance between your stitches for this bucket handle type of meniscus?
So I think every 5 to 7 millimeters you should have one stitch. Otherwise you are getting a area of meniscus which won't heal to the capsule, and there will be a re-tear of the meniscus. I like that those horizontal sutures, though biomechanically vertical sutures are superior, but for the posterior horn you can get a much better area of meniscus without the suture cheese wiring through with a horizontal suture on the posterior part. So exactly the same technique I also follow, 2 posterior horn all inside and then vertical for inside out.
So this was done, and
Dr. Arvind?
Yes, sir.
You were told about the pie crusting. So how do you do the pie crusting of the MCL?
So usually I do on the femoral side of the MCL because the chances of healing is high there. But I want to know all the expert here also, Dr. Bhushan sir, where do you do this pie crusting?
So I do it at the joint level. I know about the theory of healing, but I think the MCL is weakest at the joint level. Of course, TBL side we don't too far down, and it's easy to decide how much you want to release when you're doing valgus stress. When you're doing pie casting, you can see the opening happening and you can stop it. Femoral side, I'm slightly averse to doing it because I feel you can damage the medial epicondyle and attachment of MPFL as well. Haven't had any issues, but it's just personal preference.
Rakesh sir.
We use 18 gauge needle or the 18 gauge needle?
I also do at the joint level because viewing and understanding, you put some force, view how much of space you are getting, then increase, again do some, becomes more easier for me at the level I'm not doing too much of damage, what point to stretch, all this gives me a bit of confidence because it is under vision of mine. So that would be my view.
Joshi sir, pie crusting at which level? Any time you have sudden giving away sensation of this? So mostly does at the joint level, Prabhat sir. But I do above the joint level, below the medial epicondyle, at the femur level.
You never had that pain issues after that if you do at
There is no pain. I stopped doing at the level of joint because once I have this almost complete tear of the meniscus, this MCL. When I taken all the stitch all inside, and there was 3 stitch from inside out, and at the time of taking the knot from outside, I saw just there is hardly any connection of the
A chance factor.
MCL.
Wrong patient on your hand that day.
So I kept that patient for almost 6 weeks in knee immobilizer without any movement. Luckily, everything get healed.
Sometimes it happens.
It was almost 2 years back, and after that I shifted from joint level to just above the joint level over this. And this was the final picture. This was the ACL with remnant preservation, and
Chalo.
and this was the final. This is the X-ray of this patient, ACL with bucket tunnel. Thank you.
Thank you very much. I think we are having a good discussion in between also. So we'll see if we have discussion in the second part also. So requesting Dr. Manish Kumar to give us talk on infected meniscus.
I want to know how many PGs or SRs are there in the hall? Okay, good. I think this discussion was for the postgraduate students and senior residents, and of course everyone can participate in it. So I'm going to talk upon a scenario which is a nightmare for all the arthroscopic surgeons. So just to start with a case, now this is a young girl, around 22 years, weight as you can see 57 kg, height so much. She had the symptoms of frequent locking and pain for 6 months. Now this is quite obvious. She had a history of twist, injury to her knee, the right knee, around 6 months back. And the McMurray's was positive for the middle meniscus. So the diagnosis, I think it's quite obvious to everyone, it's a tear in the meniscus. Now, in the postgraduates, someone say what kind of tear could it have been? So that we can proceed first. Anyone? The type of tear? Okay, no problem. Now before I show you the gait, try to focus on the gait of the patient. It will be a very short video, and before seeing the gait, try to look at the MRI if it is, you can get some inference about that. Now I'm trying to show you the gait of the patient. Just see if you can assume or you can get some inference. Okay. What's the right lower limb? Any assumption what it can be? The type of gait? Do you want to see it once again? Just walk at the foot of the patient. Anyone want to say any comment? I don't think it's a varus thirst. I think the patient is trying to drag the foot on the floor and she is not allowing her affected knee to flex. That is the type of gait what the patient has accustomed so that she does not undergo a locking again. Because the movement of the knee joint, flexion extension, that leads to locking. So she is dragging her foot and not trying to, see, she's trying to drag the foot on the ground. She's not trying to flex the affected knee joint. Okay. So that's it. The next video, next picture, the MRI. By seeing the MRI, any diagnosis, what kind of tear it is? Maybe it's not clear. Anyone? Okay. Quite right. It's the bucket handle tear. Now let's proceed further. Now we would go for a diagnostic and see what's the thing. Now see, this is a clear cut. It's a bucket handle tear, I think so. It's getting reduced. Yes, it is reducible. I was very skeptical, 6 months old case, whether it will reduce or not. But luckily it was reducible, so we could think what to do. Now the therapeutic part of it. This is thing we are trying to do inside out repair, and as you can see the meniscus which was lying here, a bucket handle tear that has been stabilized and it is reduced now and it is in position. Now next, what happens? Now this is the scenario, the nightmare. 3 inside out stitches 6 weeks after repair. All of them oozing. What next? The house, please. That's a different
That
question.
is-
Infection can always happen.
How can anybody
The incidence of
say
infection-
100% that white got infested? It is not possible.
In spite of all sterilization, it gets infected. That's the
And
in
it
the
is in
literature.
a medical college hospital. can
0.5 to
happen.
1% of cases of arthroscopy that can get infected. The reasons can be varied. So it got infected, now what to do?
But Manish, what I think that first, it appears to be, it is infected, the foreign body should be removed, go inside, lavage from inside also. First, all the three sutures which you have put should be removed because it is foreign body lying there. Go inside, look into it, what is the kind of condition of the joint, what is the amount of fibrosis in there, debride it, and if you still feel, remove the, if it is still not healed, the infected part, because it's hardly been much time there. Even if you need to remove those meniscus, dead meniscus, you can just remove it. Complete debridement, keep him under continuous irrigation and wait for some time.
Deepak sir, want to remove the implants?
Complete lavage and everything should be removed in this thing.
Right, sir. Yeah.
12 year back, we had first post ACL reconstruction infection almost 12, 13 year back at Sports Injury Center. That was the first case, very VIP patient from the Purpurganj. And we taken to the OT immediately at the 5 days only. We don't wait for any type of
Right.
IV antibiotic or any short type of debridement, nothing. And there was a lot of pus and everything. And that patient almost, I think thrice he needs debridement.
Quite right.
So any pus in the joint is like septic.
Yes.
And you have
yes.
to be very aggressive.
The moment you see a scenario like this, anything oozing out, that's very badly infected. You need to proceed further. Now, patient was taken into the OT, examination under anesthesia. Let's see what happens. Look at this. The oozing is there, and the second thing what we found, or what we had seen pre-operative before taking the patient OT, the knee was stiff. Because the moment the patient has got any problem, he starts keeping his knees immobilized. And that was the range of motion what the girl was having after the infection. So the first thing what we did was, that was the manipulation of anesthesia, MUA. We tried to regain the range of motion. So the motion was regained. And after this, next thing, look at the joint inside. How does it look like? Anyone, can they imagine the type of joint it look like in infected case?
Every synovium is highly vascularized, maybe proliferated. Maybe there is a layer of infected tissue over the cartilage also. And ACL, PCL is definitely red and very angry looking.
Very right.
Bhusan sir.
And that was what it was looking like. Yes. Look at the ACL, that is very angry looking. The entire synovium, reddish, very bad. And regarding the sutures, you'll just see, we cut it and it came off easily. So that was suggestive that the tissue had become so friable. We had to remove all the sutures, and then this is after 2 months of surgery, this debridement. I think the things has settled down a bit. It was all gone. Huh. You want to save the knee first, next to the joint. And this was the range of motion because she had become very stiff. So our dictum or our thought was to save the joint first, prevent it from a septic lesion. So what can be the take-home message? The house, the experts. Yes, right, sir.
Why you did manipulation before entering the joint?
Sir, it could be done later on also.
This is what the.
Yes, it could be done later on also after seeing inside the joint.
Just go inside, do something,
Yes, sir.
and then flex it.
I fully agree,
That
sir.
will be
It can be
safer.
done at the time when you have put the scope inside, you have seen everything, and after that also you can do the MUA. So the sir, take home message, sir, from the experts. Sabni, sir.
Be cautious. Don't hesitate in going in and debriding it. Anything that you are cautious, you think that my case, how can I get infected? I don't get in anything, arthroscopy getting infected. So don't be that. Go in, debride it, and do whatever you can.
Okay.
That should be it.
Thank you, sir. I think the take home message to all the persons should be, if you see anything of this sort, you should act immediately and act vigorously. Do not wait. Thank you.
I think the important message is the knee joint comes before the meniscus.
Right, sir. Right.
So save the joint, not the meniscus first.
Absolutely right, sir.
I think Ashish's observation is quite valid.
So may I invite Dr. B.K. Pandey for his talk on root tear.
So I think manipulation should not be done before putting up the scope inside, because unless you do the adhesion lysis and all, it would be a dangerous maneuver to do. You might even fracture.
The thing is that knee was straight. So getting into the intercondyle notch and other thing would be difficult with a knee, straight knee, isn't it? You can do a suprapatellar or other thing, but going into the really into the joint with a straight knee would be difficult. So, okay, you can go on either way.
Yes,
either way.
That was the reason. Trying to put a scope inside the knee was
So I understand. We arthroscopic understand those problems.
Okay. So this is the case, and it is a 21-year-old student, a recreational football player, plays a little bit of football here and there, met with an road traffic injury. The sagittal plane stress was positive, Lachman was positive, suggestive of ACL injury. Coronal plane stress was normal limits, and rotational stress was normal. So going by this clinical examination and history, maybe an ACL injury. Then this was the X-ray, which was supposedly normal. Then that's the MRI scan. Bhushan sir, what's your take on this MRI scan? What do you see on this?
Can't make anything yet.
So it's an axial cut. There's some meniscal pathology on the lateral meniscus side. Some tear is there, which is more or less like a radial kind of pattern. So going by this, Prabhat sir, what's your take on this? On the coronal section, what do you see?
Coronal section, there is a root, there is meniscus injury left side, that is
Lateral sided,
lateral
correct.
side.
So that's a lateral sided meniscal injury, more or less again reiterating the radial pattern.
Radial pattern, yeah.
And that's the injury. Now comes the sagittal section, which is the most well-versed section with us because of ACL injury. So what do you say, sir?
Yes, sir. ACL injury is there.
So that's an ACL injury. So we have a meniscal tear, radial kind of pattern, and an ACL injury. So that's again a short video of the MRI. Anyone could make anything out of this apart from a radial tear of lateral meniscus and an ACL injury. So we have a lateral meniscus radial injury and an ACL injury. Anything else one can make out by this? Ashish sir says bone edema. So Arvind has got it right because he has allotted topics to everybody. So he knows. So anyway, so I know. So that's the area. So for a lot of us who is doing arthroscope, it's very difficult to pick up this much signal change on an MRI scan. So these are the changes which suggest you about ramp lesion. So ramp lesion has come up off late, a lot of talk has been happening about ramp lesion with ACL injuries. So one has to look for it, really look for it, then only one can find it out. So going by arthroscopic picture, this was the meniscal tear, lateral side, and that's how the ACL tear looked like. So it is only to highlight that sometimes these ramp lesions are hiding behind the meniscus. It's very, very far posterior or posteromedial kind of lesion. One has to look for it to find it out. So that was how it was not visible on anterior scoping. So you're putting a scope from anterolateral portal and you are looking at the posteromedial compartment, but you're not able to visualize it. This is the classical hidden lesion told by B.S. Quartet. It's far posteromedial. So even though you're going through the notch in the posteromedial compartment, you will not visualize it. So that was the surgery which was done. ACL reconstruction was done, and radial tear was repaired on the lateral side. Two side-to-side stitches were done. And that's how a short video of how you do a ramp repair. There's very many techniques described. So that's Arthrex ramp lasso, which is a lasso which is shorter curve which comes especially for ramp lesions. So you take a bite from the posteromedial portal, and rest of the steps are straightforward. You pass an Etlon wire, take a 2-0 fiber wire, pull it out, put a cannula, and from the cannula you start tying the knots. So that's how you do it. You put a scope on the posteromedial compartment, look for the stability of the meniscus. And somebody talked about the bleeding in the joint after doing meniscus surgery. If you're doing an ACL injury, the scope was put in, a lot of bleeding was there, a lot of these pluripotent cells were there, so one doesn't need to microfracture or micropuncture the femoral condyle for this. So this 2 months post-op, it is 2 months, so still patient is guarded, weight bearing is there. So some take-home slides about literature. So this is the B.S. Quartet literature. Themselves in their series, the incidence was 9%, then went to 16%, and now out of every 4 patients, 1 you will see with a ramp lesion. So that's an article which suggests that out of 4 ACL tears, if you have to look for 1 ramp lesion because it is about 24-25%. So one has to understand this. And again, this is an important article to find out because they did scopy, starting from anterior compartment scopy to posteromedial scopy, from the anterior compartment and then posteromedial scopy. From then, it is about 17% of the lesions which are on the far posteromedial side, which you will not be able to see by angioscopy. So you do an angioscopy, you will find 60%, 70% of the lesions. But some lesions are there which are far posteromedial, so one has to go through the posteromedial compartment and look for these hidden lesions. So they call these ramp lesions as hidden lesions. This article highlights the importance of ramp lesions. So what they did is a biomechanical study, cadaveric study, where they reconstruct the ACL and left the ramp. And in one series, they reconstructed the ACL and repaired the ramp. The anterior translation was better with the reconstructed ACL with the ramp repair. So when they left ramp, the translation was still there. This classification, one has to understand type 3, 4 and 5 are highly unstable pattern of injury. So one has to be very careful about type 3, 4, 5 which are unstable pattern, one needs to fix it. 1, 2 and 3 are ABC are stable pattern, one can just get away with it. Now this is important, as I discussed, MRI doesn't show too many things. So increased signal at meniscocapsular junction on the medial side and posteromedial bone bruise as picked by Ashish sir are the 2 factors one has to look for these MRI scans to get a report of ramp lesion. Very many techniques has been described, and the only thing important to understand is one has to go to the posteromedial compartment to repair these lesions. Very good success rates, 7% failure rates of meniscus, more than 2 years follow-up. And this is an article from Japan where they say when the length of the lesion is less than 1.5 and there is absence of excessive translation means you can pull the meniscus into the notch. If you're not able to pull the meniscus into the notch and the length of the lesion is less than 1.5, you can leave the meniscus, do some trephination, it heals well in a stable knee, not in an unstable knee. So take home MRI is important. One has to look for posteromedial bone bruises. Then one should do a needle test. If you are able to delineate the ramp lesion by doing a needle test, one can find it out and proceed. But sometimes you have to do a posteromedial scopy to see these lesions. So that is how you put a needle from the posteromedial port. Just push back on the capsule and you will be able to see a tear there. If at all it is there, it is not here. So you will be seeing that lesion there, somewhere there. Posteromedial scopy, another part which is very important.
So that's the posterior aspect. It's far posteromedial that you can see this tear happening. So this is the take-home MCL release. We discussed about this. Dr. Bancha has a wonderful technique where he says it's a magic point. It is 1.2 centimeter above the joint line following the posteromedial border of the tibia. So follow the posteromedial border of the tibia, joint line, and 1.2 centimeter above. Give a small nick and just some wriggle motion, and you will open up the joint space. So there's the joint. And sudden pop will come and the joint will open up. And I, as Arvind said, I do it on the femoral side, not on the joint line. So that's how you open up the joint, and thank you so much.
Thank you.
For the discussion.
Yeah, basically, I don't know how many of you are now, because these are such a lesion, and many of time you do miss it on the MRI even sometimes. So should it be, I don't know how many of you is now practicing that, doing a diagnostic arthroscopic, adding another posteromedial incision, going down and see regularly as we do it in anterior scopy, or it is just if we find it, we go and do it. Is there any way, all of you, where we are doing anterior scopy, we find out by confirmation that there is a ramp lesion, we pull it and see it front or down out? Any on this panel can, or anywhere?
There is a very good classification by Straubel about types of ramps. I'm talking pre-sonary corte era. So he's described the acute ramp, the stretch ramp, the scarred ramp, and a chronic ramp. So if you are able to go in the window between the medial femoral condyle and PCL and see a pristine looking ramp area, I think you can be more or less certain there's nothing wrong, because there are hidden lesions, I agree. But if there is any sign of scarring in that region with excess vascularity or a sudden dip in the capsule, then it's a sign of a partially healed or scarred ramp. That's when we normally put a needle in and see if it's easily retractable or if it's displacing. That means it's superficial scarring and the ramp is unstable inside. So I think anytime you're doing ACL, you just have to put the scope in the posterior compartment and see the ramp area. If it's bad, you can put a needle. If it's perfectly normal looking meniscocapsular junction, you can leave it.
For the purpose of the house, can this anterior drawer test give you some inference regarding a ramp lesion? Because is it a hidden lesion? Every time you don't go for a posteromedial arthroscopy, you MRI, you miss it. So anything can you get by anterior drawer test?
Maybe high-grade fiber anterior drawer test, very high chances of association of this type.
Right.
Correct.
By doing 30 degree, if you have any doubt, just take a 70 degree SO without going through the posteromedial portal. You will have complete view of the posteromedial side from the anterior side also.
Right. So you should have a high index of suspicion, and if you find an anterior drawer test which is very almost grade 3 and a pivot shift test also, so you should think of it. Ramp, you should not try to miss it.
Dr. Pandey, what are the sequence of fixation in the case you have presented?
So first is meniscus. So I'll do the meniscus first, and then both the meniscus first, and then go to the ACL.
Regarding bucket handle tear, question for the Dr. Arvind and the chairperson. What is the maximum time duration where you decide to preserve it or to excise it? Many of the times there is very young adolescent boy having ACL tear along with bucket handle tear for more than a year or 6 months. During the scopy, we find out that there is a very good, healthy, scarred bucket handle inside the knee joint. So, should I excise it or try to reduce it and fix it?
So,
for me, I told you that two important things. It should be reducible and it should be stable. And the tissue, the amount of meniscus tissue is quite good. It is not very lacerated, all torn off, degenerative type of thing. If these 3 points are there and young adolescent, I will certainly try to preserve it, giving all my fingers crossed, giving all explanation to the patient and keeping all precautions. with the post-operative rehabilitation. Whatever late, if possible, I will try if these three conditions are fulfilled.
So important thing is it should be in the vascular zone. Tissue should be good. It should not be friable. It should not be synovalized. The chronic bucket handle very high chances of very early get synovalized. That synovial tissue should not be there. It should be stable. So timing hardly matter in younger patient if all these things are there. If you think about the timing, it usually 4 to 6 weeks. So there is rule of 4 if you keep remember in case of isolated meniscus. 4 week, it should be 4 if you are doing the 4 mm apart, 4 micropuncture in the lateral condyle of the femur. It should be 4 millimeter from the capsule. So think about the ideal thing. Otherwise, issue is perfect. Timing hardly matter. Joshi sir.
So it's only that blunting of the meniscal margins. If I find so blunting of the meniscal margins. So when I have to repair, I would see an old tear. If there's a blunting of the meniscal margin where the union has to happen, I think this is not going to unite.
Sir, what are the process and what are the technique to say about that, clean out that scarred meniscus so that it can be perfectly reduced and stable?
And you can use shaver, and there are diamond burrs which come by which you can just raw in the surface. And I also do the needling of the capsule. So where I have to repair, I will just put needles initially before doing the repair. Put needle in the capsule so that the bleeding comes from there, and that helps in healing. But for me, if it is too blunted a margin, then I would not like to do it.
Gurudev, 6 months old, you have to take chances. That is for sure. 6 months, you do all the things. You shave it, you put a rasp, you do refining, you do all the thing, and still keep your finger crossed, isn't it?
Thank you.
Thank you very much. Thank you, everybody. It was a quite useful and good discussions of all the lectures. May I request Dr. Ashutosh Agarwal for his expert lecture, please.
So meanwhile, can I ask one question?
Yes, sure.
What do you mean by stability?
Morning. The today's lecture is meniscal repair, the need of the hour. Meniscus was usually considered vestigial. It was easier to resect than repair. It was sought bias. Recent past trend shows that importance of meniscus is evaluated and understood. Following removal, cartilage overloading aggravate degeneration. The ratio is 2.5:1 in male to female ratio. High-risk activities like cutting sports like tennis or soccer or impact sports like running and skiing lead to more meniscus injury. Now, what are the implication of tear? The lateral meniscus junction knee is doomed to develop of osteoarthritis, pain, and reduced knee function. In case of middle meniscus junction knee, it varies. Then, big question, why to repair? To restore function, to maintain load transmission, to minimize contact stress, to contribute to stability, and contour protection. It reduces articular cartilage wear. But then big question, but then should every meniscus be repaired? No. Appropriate informed decision is required, and only 20-30% of the meniscus is repairable. The section of middle meniscus, middle posterior horn increases tibial force up to 68%. The lateral meniscus covers around 84% of lateral tibial plateau versus 64% for medial. Lateral meniscus is more circular than medial, is more uniform in width, and meniscal excursion, lateral meniscus motion occurs after 5 to 10 degree of flexion. In case of middle meniscus displacement after 17-20 degree of flexion. And the middle meniscus has limited displacement and rotation due to its posterior oblique ligament. Zone everyone knows by Miller, 3 zones, red, white, and white zone. Is a red is a vascular, red white zone is avascular portion is junction, and white zone is avascular zone. The further out the lesion, more likely the meniscus will heal. Now the type. O'Connor has classified the paternal meniscal tear into following categories: longitudinal tear, horizontal tears, oblique tears, radial tears, variations like complex tear, flap tears, and degenerative meniscus tear. Now, what is the principle of repair? First is stimulation of healing potential, and second is stabilization of the defect. Stimulation is complete by perimeniscal sanual abrasion and or by fibrin clot placement. Stability can be present inherently on the basis of incompleteness of tear, short tear length, and also can be augmented by sutures, approximation, immobilization, and post-operative non-weight bearing. Then when to repair? Acute, traumatic, symptomatic tear. Any peripheral non-degenerative tear, longitudinal tear less than 3 centimeter, mobile, vertical, single longitudinal tear of the meniscus limited to vascular outer third of the meniscal substance. Young patients less than 40, stable knee, associated with ACLR or chondral procedures. When to repair, when to resect? This criteria say according to location from the capsule, according to age of the patients, size of the tear, tissue qualities, and some qualifiers like knees unstable, a malign chondromalacia grade 3, radial tears, or axial reconstruction or fibrin clot. If a score is less than 4, it is repairable. When to avoid repair? Chronic, complex, degenerative tear, more than 4 cm long tear, transverse tear is repair free. Do not repair flap tears, radial tears, cleavage tear, or vertical tear with secondary lesions that extend into the avascular inner two-thirds of the meniscus, except in young teens. Irreducible tear, unstable knee, older non-compliant patients is with grade 4 osteochondral defect. How to approach meniscal tear? For the preparation of tear, go for debridement, abradement, trifling, clot placement, reduction of tear accurately and maintain reduction, accessory portals to improve access and fixation configuration, particular placement of implant every 5 millimeter ensures that implants are not proud. Rehabilitation is individualized. Technique, there are 3 techniques: inside out, outside in, all inside, according to surgeon's preference. Inside out technique is gold standard for meniscal repair. It allows more constant suture placement, easy to learn and reproduce, highly recommendable with long-term data. Tear posture and middle third of the meniscus are suitable for this technique. Advantages: highest mechanical strength. Disadvantage: meniscal injuries. They say incision, you have to put incision. Outside in repair, sutures are passed through the meniscus from outside. Outside in technique are more suitable for repair of the anterior and middle third of the meniscus. Suture retrieved and not tied outside the capsule. Advantage: there is a less risk of meniscal injury and less arteriocartilage damage. But disadvantage: you have put in some incision. Then comes the all inside. All inside repair devices were developed to reduce surgical time and prevent complication from external approach and allow access to the tear of posterior horn. This is the most prevalent these days. Now the clinical results. Success rate of all technique is around 70 to 90% reportedly. 5-year survival rate of isolated meniscal repair was 60 to 70%. Factors which affect outcome include tear complexity, rim width less than 3 millimeter, ligament laxity decreases success rate to 30 to 70%. 90% success rate was reported in conjunction with ACL repair. Now come the rehab. Day 1 to 7, full passive extension, flexion 0 to 45 degree, walking on a walker, not weight bearing for 3 weeks. First 2 weeks, range of motion is increased to 0 to 90 degree. 3 to 6 weeks, range of motion is to 120 degree. Walk in, walk up, partial to full weight bearing. After 6 weeks, long knee brace for 4 to 5 weeks, hinge knee brace for 5 to 6 weeks. 6 to 8 weeks, full painless range of motion, normal gait, walking without support. By 6 months, patient returned to all activities. Thank you.
Thank you very much. It was an excellent overall view of what we should do in a meniscal tear, when and how to repair. Thank you very much. Is there any As we ramp up this meniscus session before going for the live surgery, any questions from the audience to any of the speakers? Thank you very much, sir. It seems that everything looks good and fine. Is the OT ready? Over to Dr. Deepak Joshi and Dr. Ravi Kumar to continue with the live surgery now on. Is it ready?
No, sir.
Manish, take over. What is the surgery going on to there?
Anesthesia to the patient that was given already. So draping and preparation part will take around 10-20 minutes. Meanwhile, we will start the ACL session, and the moderator of ACL session is Dr. Rajiv Bhatt. Dr. Rajiv Bhatt, please come here.
So, may I request our chairpersons, Dr. Subhash Chandra, Dr. S.N. Sarraf sir, Dr. V.K. Pandey and Dr. Rajiv Raman to chair this session of the ACL session. Achha, as Dr. S.N. Sarraf is not available here, so I may ask Dr. Divyendu Chaudhary to chair in his place. So, chairpersons, please. And this is the ACL session, and I think this is the bread and butter of every arthroscopic surgeon. So this is going to be a very good session. So I hand over to the chairpersons. Thank you.
Session. The first speaker is Dr. Bharat Bare. He will be talking on ACL in pediatrics. I think a very pertinent topic. Dr. Bharat.
All. Good morning, chairpersons and all my delegates. Thank you very much, Dr. John and Dr. Arvind, for giving me this opportunity. So, this is the place where I work in Akash Healthcare Super Specialty Hospital, Dwarka, New Delhi. And today I am presenting a case of ACL tear management in pediatric age group. So the patient was 14-year-old young boy, presented with a history of fall while playing football. He presented to our OPD 3 days after the injury with the hemarthrosis of the knee. The Lachman test was positive. There was a valgus stress test positive grade 3 and varus stress grade 1. So, Dr. Vinay, this is the history. How should I proceed? Any comment on that?
Valgus is grade 3 and Lachman is positive. So he has got hemarthrosis, ACL tear most likely, and along with that MCL injury. So that would be my take on this.
Yeah. So same from our side as well. So we have gone for the primary X-rays. So the X-ray was showing that there was no
In the meantime, one question, Dr. Bhade.
Yeah.
You said the valgus stress test was grade 3 positive.
Yeah.
So that positive was in what angle? It was in 30 degrees or 180 degrees?
No, it was on 30 degree.
30 degrees. Okay.
So this was the X-ray. There was no bony injuries. There was no avulsion fracture. So the diagnosis is that the soft tissue ACL tear. So next we would have gone for the MRI. Anything as from your side like
So what was the valgus resin extension, full extension of the knee?
valgus in full extension.
Yes.
It was like grade 1.
Okay.
So
So that means it's not a complete ACL tear. If there is full extension, valgus which is not positive, then in 30° it is opening, but in full extension it is not opening. It is grade 2 for me, not for grade 3 exactly. Grade 3 is when it is opening in full extension as well as 30° flexion of the knee.
yeah. So the patient was in pain also. So like
Okay.
in the
Yeah,
OPD
that-
setup, we cannot elicit completely. So gone for the next step of the investigation, that is MRI. So these are the MRI picture in the SAG view. So showing the complete ACL tear along with the edema around the lateral compartment near to the popliteus. So, Dr. Pandey, what would you say? Is this the ramp lesion kind of thing? Because so many times this kind of the picture is there in the MRI.
Yes, that's what I wanted to highlight, that ramp lesion on MRI is very difficult for orthopedic surgeons to pick up because we are still evolving, I think. Some few new features may come, maybe some new findings will come, which we will maybe able to appreciate more. Currently, to diagnose ramp lesion for an orthopedic surgeon, it's a tough diagnosis. But if you see, there is posteromedial, there is no harm putting a scope there and just trying to see, have a short look, put a needle, just feel the capsule. So whenever you find some posteromedial bone bruise, there is no harm going in the posterior medial compartment.
So
That's the point.
So
I
Dr.
also
Bharat,
yeah.
it is on the lateral side, and most of the time that signal intensity in the posterior horn of lateral meniscus is there. So ramp you will find on the medial side. Anything type of picture that you are seeing in the second image and the second row, if it is on the medial side, very high suspicion of the ramp lesion. But it is on the lateral side. On the lateral side, it's normal.
So
I think in acute MRI, it's very difficult to say whether the ramp lesion is there or not. Most of the time, you will get edema in the meniscocapsular junction.
because of
Regarding
the
your
fluid
grading, I think the most important criteria now we follow is the laparoscopic stress view. You go for a 30° flexion valgus stress view and see for the opening of the medial joint space. If it is more than 3.7, I think it's grade 3. Rather than, because in acute setting, it's very difficult to put these patients on valgus stress. So I think under C-arm guidance, just see whether you have opening of more than 3.7 on the medial joint line and it's grade 3, and then you have to plan accordingly for MCL repair also.
So going forward, these are the coronal views. So on coronal views, there was a complete tear of the MCL.
Femoral side here.
On the femoral side tear of the MCL, along with the like ACL injury, and there was a edema around the posterior lateral corner near to the popliteus as well. These are the axial views. So any comment from the axial views, like in this case?
I think the MPFL seems to be okay. We can't see any chondral loose body.
Yeah.
These are the two things we want to see on the axial view. And third important point is, most important point is that because you were addressing on the age, whether the physis has, whether the physis has fused or not, at 14 years of age.
Yeah.
You can see the tibial physis and the femoral physis are still open. So
Yeah.
I think decision-making lines on that, because it's a clear-cut case of ACL with an MCL tear. So your treatment plan will be the same. But whether you will go as per ACL reconstruction, MCL reconstruction in adult, or you will do something different.
Yeah. So this was the skeletal maturity assessment for this. So we have taken this PA view. So chronological age is 14, bone age is 13 to 14, Tanner stage 4 or 5, and he is in the peak velocity age group of the. So what should be the plan of treatment from now? Dr. Rajiv, what would you suggest?
So normally, see, normally what we do at 14 years, the second growth spurt has already occurred.
Yeah.
So up to 12 to 14 is the gray area where we think whether we'll go for physial sparing or extra-articular tenodesis or something like that. But I think at 40 years, I usually, if it's second growth spurt is already has happened, I can plan for a normal ACL reconstruction as I do in adult.
So
Not a facial sparing.
not a facial. Dr. Pandey,
Yeah, I would
what
go
and
with-
when?
Yeah.
What and when?
So I would go with Pfizer sparing still because bone age is 13 to 14. So Pfizer sparing ACL as with MCL repair on the femoral side. So that
MCL
repair.
repair?
Yeah, repair. That might take.
Can you give chance of MCL to get healed and the ACL later on?
So Arvind, grade 1, 2, yes, always we go for conservative. I think grade 3, and it's a femoral side avulsion. So I think chances of getting it, because what happened, as if you see the Laplace study also, whatever assessment is pre-operatively, that is your final assessment. So if pre-operatively or it's ACL and MCL, it should be an ACL MCL tier and you should treat them accordingly. So grade 3 MCL and ACL, I think we can go for MCL repair in this case.
I think 13 to 14, whether it's a male or female, makes a huge difference.
Definitely, sir.
Okay, by 14, most females have finished their growth, but boys haven't, okay? They're still growing till 17 sometimes. So I think you really need...
I think isolated MCL grade 3, isolated, that can be left as such. But if you have it in a combination with other ligamentous injury, you should go for a reconstruction.
As told by John sir, I think second growth spurt in male is around 14 to 15 and for
16.
15.
So it is 14 to 16
but
when the
a
second
gray
growth
area is the 12 to 14 because 12 to 14, yes. Less than 12, always facial is present. 12 to 14, it's a gray area. And 14 and plus, I think normally we plan for normal ACL construction. See, physis, you will see physis in MRI up to 17. The physial line will be there up to 17 or 18 year of the age. Physial scar, you can see up to 19 year of the age
There's a
also.
grading of the facial
Yes.
growth on the MRI, whether it is closed, whether it is
Yes.
narrow, or whether it is widely open. Yes. Yes, sir. Yes. So, this is the video in which the examination under anesthesia was done. So, the Lechman test was positive and the drawer test was also positive. So, trying to pivot shift, but because of the MCL deficiency, was not able to assess.
It's grade 3. You can see the opening. It's
Yeah,
grade 3
there's
MCL
grade
almost. Gross opening on the medial side.
Yeah.
And normally if MCL tier is there, you can't do pivot because your pivoting axis is MCL only.
Definitely.
So, yeah, so you can't do pivot.
Could not elicit it. So these were the stress views taken under anesthesia. So showing the picture that there was, in the neutral there was no opening and slight opening on the varus stress and complete opening of the joint in the valgus stress. So there was a hyperlexicity as well in this. Yeah. So the height of that patient was around 5 feet 8 inch, and there was a hyperlexicity as well.
So one small comment, whenever we check this stress view, it is always comparable to the other knee. So we have to compare with the other knee, check the other knee, and then only you quantify how much is the difference. It is about the difference, not the absolute opening.
Yeah. So I haven't kept the pictures, but we have compared it as well. So now the graph choice, like what is your take, like apart from hamstring, any other
Always
choice?
soft tissue graft, as Ashish sir told, and usually whenever you have a concern of physis, whether the physis is fused or not, there is no option other than soft tissue graft. Whether it's a hamstring or a peroneus, anything, or a quadriceps, but it's a soft tissue graft for me.
So we have decided and gone for the SEMIT. Luckily we got a good graft. Only SEMIT was more than 32 centimeters, so required was much lesser than this, and gone for the facial sparing all inside. This is a video how we proceed. So the diagnostic, the ACL found complete injury. It is the femoral area. The PCL was intact. medial meniscus probed and found stable. Yes, because of the MCL injury. On the lateral side, there was slight mobility on the lateral meniscus, and the popliteus was found partially injured on the lateral sides. So, with this much of the information, we have decided to go with the all inside fascial sparing. So, as usual, I have gone for the cleaning of the femoral notch before. So, for the all inside, there is a good jig available with the Arthrex, from which you can make an outside in tunnel. So, while making an outside in tunnel, one can put a jig and then confirm it on the CM image and see that whether we are in the epiphyseal region. So, it is very useful for the all epiphyseal femoral side. Rest all comes. So this is the Siam picture in which we have confirmed that we are well below the physis, and then with the flip cutter, use of the flip cutter, we make a femoral tunnel in the epiphyseal zone. And so another advantage of using this flip cutter is that the tunnel which we made from outside, and only the amount of the length of the tunnel in which we are going to put the graft is bigger, and the rest of the tunnel will remain smaller in the size. So one has to be very careful while coming back. The flip cutter should get closed properly, otherwise the tunnel size will become bigger. So one has to be very careful while using this flip cutter. The only take home point is that we have to close that flip cutter properly, otherwise we can damage the tunnel. After that, cleaning of the tunnel, cleaning of the mouth is very important, because the graft passage in all inside is one of the major thing. So after this, I have gone for the probing of the lateral meniscus again. So I usually do my femoral tunnel before doing anything to the lateral meniscus. So there was a lateral meniscus tear for which I have used a all inside device and a single all inside meniscal repairs for the lateral meniscus tear. Sorry. Just a minute.
So it seems that you have done your ACL reconstruction,
Yeah.
fascial sparing as well as meniscal repair.
Yes, sir.
So do you brace your repair also? Whenever you're doing femoral repair, do you put some internal brace, fiber tape kind of thing, or it is always a repair only?
For
I think, I think he has gone for
No, for
reconstruction.
MCL repair.
So MCL repair.
Do you brace your MCL repair, or you don't brace your MCL repair?
So
MCL repair.
So I have done
Only repair.
Repair with the anchor.
But no bracing.
No bracing.
Okay.
Okay, in the meantime, the video plays.
Yeah.
One question to them. We are going for a fascial sparing reconstruction or tunnel creation. If the area of our physis is considered to be 100%, what amount of physis needs to be damaged to lead to a growth disturbance?
मिडवे से वीडियो चलाना है चल तो रहा नहीं मिडवे से चलाना नहीं आधा चल चुका है
Right, sir. Can you go down a bit?
So the area of physis that you have to damage really varies because even with K wires in the distal radius, there are reports of growth arrest. So I think it's not just area, it's the amount of damage, the level of trauma, etc. that matters rather than just what it passes through. So in the
So some of the
radius,
pages it was saying around if 5% of the area is damaged, so not much of chances of the damage.
true, but like I said, even with a K wire or distal radius, growth arrest has
We
been
can have a damage.
And also it's the age, at which age you are damaging the physis. That is more important. So literature says at the age of 13, 14 year onward, if your tunnel is central, as sir has said, there is hardly any problem with the angular deformity.
So it is the physial plate through which we are going, they may damage the growth. If you are going in the physis, there is no question of damage to growth plate. So this is the physis, physial plate, growth plate, then the epiphysis, growth plate, and the metaphysial area. So if you are going through the physial plate, you may damage. If you are going through the physis or epiphysis, you are not going to damage the growth plate.
No, the question was that
You are going through the growth plate, then
Okay.
it was the question.
You're creating internal through the physis.
Physial plate.
So what is important, try to be central and perpendicular. So, and at 14 years of age you are very safe. But Arvind was telling when you are dealing such patients and sometimes gymnastic player comes 9 years or 10 years of age. In those cases actually it's a really issue because the tibial physis is very small and in tibial physis is wavy also. If you see the femoral physis, it's very straight line, but tibial physis is wavy. So chances of one of the width pin, if you think in one of the view it's not crossing the physis, other view you see it's crossing the physis. And there the chances of physical damage is more. You should be more cautious when you are dealing the pediatric case group ACL reconstruction under 10 years of age, especially in gymnastic player or something, because you have to do ACL reconstruction in those patients.
And coming back to the video, now after doing the not working.
Be any tenderness, angry looking knee should not be touched. If range of motion is full, even at day 5 you can go. There is no swelling, range of motion is full, you can go for a surgery. John sir.
So what about in sportsmen? I think we hear about them getting scoped immediately or operated on immediately for ACL reconstructions, etc. They have the injury, they are in surgery the next day or the same evening.
Yeah, rightly said, sir. We are also doing a lot of multi-ligament surgery in acute setting at 5 days, 7 days, 10 days. And if your fixation is strong and you have mobilized early, the chances of arthroplasmosis is not much.
I think a professional sportsman is a different breed altogether, okay? So they are motivated, they'll mobilize, they'll do the physiotherapy. And so for them, time becomes the most important thing. So they are a different group of people than when you're dealing with an average person who's just leading a sedentary lifestyle or is a sort of plays sports as a recreational thing. I think professional sportsmen have to be treated differently.
So this is the post-op X-ray in which showing the epiphyseal fixation of the all inside repair. This is 1 month post-op, and these are the videos which the patient has sent. He's doing all the exercises, like he's 4 to 5 weeks post-op, so still partial weight bearing with the knee brace, and patient is doing well at present. So a brief review of literature. So ACL tears are very common injuries. Still we don't know the exact amount of the incidence of the skeletally immature patients, but day by day, as the number of the kids are more involved in this sports, the incidence is increases. There's a very good paper presented by the Olympic Committee consensus statement, and they have given a very detailed description of how to manage all these ACL injuries. And a very recent paper in which the review was done by the Dr. Dillon and all, which shows that the ACL incidence is increasing day by day. The type of ACL tears can be cartilaginous avulsion, or it can be bony avulsion or the tibial eminence fracture. It can be a mid-substance complete tear or a complete or a partial tear. So in pediatric age group, partial tears are much more common, which can be handled with a conservative way. The mode of trauma is low velocity deceleration injuries. Patient presented with usually with the hemarthrosis, sometimes with the instability giving way sensation, and the locked knee when the meniscus is also involved. So basic Lachman test and the pivot shift is the most important clinical examination, which gives us the idea whether should go ahead with the investigation. So standard X-rays are AP lateral and notch views. MRI is important to rule out the physeal injuries and the associated ligaments and the chondral injuries, which is very important to address early. Skeletal maturity assessment should be done whenever the patient comes, because that decides that whether we should go with the surgery early or we should wait, and what kind of treatment should be planned. So management always, the decision remains dicey, whether to go with the non-operative
Dr.
or...
Bharat, one announcement. OT is ready, so we will be stopping this. So please conclude it.
Yeah. So take-home message is that early surgical reconstruction is recommended in children with physeal sparing ACL reconstruction technique, favorable clinical outcome, and less growth disturbance is achievable. Hamstring is still the most preferred graft. Specific pattern of bone bruise and lateral meniscus is the most common associated injury. Complications like graft rupture and contralateral ACL injuries are the 2 to 3-fold higher than the adult ACL reconstruction, and early return to the sports is the most common reason for the complication. So thank you very much.
Thank you.
ठीक है ना
मॉडरेटर दीपक जोशी
है तो दो और फ्लो करने के लिए है तो दो
Dr. Ravi Kumar, Dr. Deepak Joshi. I think you are going to moderate the meniscus repair session. Ravi? Yes, yes. Hello, Rajkumar sir. Yeah, Dr. Rajiv here.
Good morning. Rajiv sir, good morning.
Good morning, sir.
You are able to hear.
Yes, sir. Nice to see you after landing from airport. You came directly to OTA and you are live now. Sir, Dr. Ravi is there.
Yes, I think you can just take on to the history of the patient in the meanwhile and have some discussion. We have just, entered the joint. Okay?
Okay, sir.
My charge for today is to show you the meniscus.
Sir, what are the clinical findings, and can you show the MRI, sir, in between?
So history is young chap, 25-30-year male boy, having injury 1 year back, and that time he was managed conservatively. Again, similar incidents 15 days back in which his knee was locked. That get reduced spontaneously by himself, and after that he has continuously pain around the medial side of the knee joint. The joint line tenderness was there, range of motion was full, anterior door test was positive, McMurray test was positive. MRI shows the very classical picture of meniscus tear. ACL tear is there. That can be focused on view box.
Arvind, can they improve the quality of the arthroscopic picture? Too much glare, I don't know what's happening.
Rajiv, did you get the history of the patient?
Yes, sir, we got it. Sir, we got brief history of the patient. So we can see the inside and outside both view.
Yes.
Yes, sir.
We are just, trying to get the things sorted out here. And once we are in little comfortable zone, probably we'll try to connect with you in the theater. Is that okay?
All right, sir.
Sorry, a very good morning to everyone. Today, the topic of my talk is ACL tear, to repair or to reconstruct. But this topic is better suited for a debate rather than a talk. So we will just see, we will go through quickly the conventional, what is commonly used classification, the Sherman classification for this ACL tear. There are 4 types. The type 1 is the truly soft tissue avulsion with minimal ligament tissue left on the femur. And the type 2 had up to 20% of the tissues left on the femur, whereas the type 3 is up to 33%, and the type 4 is the true missed substance tear up to the 50% of the ligament tissue left on the femur. So this is a case of a 30-year-old male with 3 weeks old injury, which shows the Sherman type 1 tear, which is evident in this, where is the mouse? Is evident in this third slide. This is the another type, T1 wedge image, which also shows the same finding. The coronal one also shows the same. So this is the intraoperative finding. So we'll just go through this. The scope is on the anterolateral side and the probe is inserted from the anteromedial portal. We can see there is a minimal soft tissue attached on the femoral stump. The other structures are intact, the PCL is intact, and the ACL is still not attached to the PCL in this case. The menisci were intact. So, what shall be the plan of treatment in this case? To repair or to reconstruct, all the things are there, the MRI findings are there. Clinically, patient was definitely having the laxity and the symptoms. On the scopy, we can clearly see that it's type 1 Sherman. So, how many would like to repair or how many would go for the reconstruction? Sir? Repair. So definitely, if you go by literature-wise, then definitely we should go for the repair. But till now, there are very few long-term follow-up of this repair, ACL repair. What we had 2 papers, one was in the 99 and one was of the 2004, which were showing around 20 to 23 years old follow-up study. All of them showed the poor results, less than 33% survival. And very few studies which are having 3 to 4 year follow-ups, which were showing the good results with the primary repair, basically insisting on the deciding on the proper candidate for the repair rather than the technique which decides. But in this case, this was operated by Dr. Arvind. In this case, we decided to go for the reconstruction.
So, Bhusan sir, you are with Dr. Anand Joshi sir, who is doing this repair or reconstruction for very long time. So, what is your opinion regarding this very hot topic nowadays of this repair or reconstruction?
Will be to have a good vascular stump. So if you are able to see some vasculature at the base of the ACL going all the way up, with a complete femoral avulsion or very small stump left on the femoral side, it's a good one to repair. The most important criteria is young age and the chronicity of the event. So if you are intervening within first 3 weeks, I would be more than happy to repair that ACL.
Sir, young, considering the age, majority of the literature are showing that this type of one injury is most commonly seen in the 30-35 age group. And another chronicity. Chronicity is also not defined well in the literature. It's varying paper-wise. Someone is saying less than 2 weeks is good. Someone is saying less than 3 weeks. And even someone is repairing at the 3 months. So results are also varying. So there is there any consensus regarding this on basis of which we decide it's more than
No,
3 weeks,
so
just go for the
this is
reconstruction?
a fairly controversial and hot topic with various companies taking various stances for this. So as we all know, internal bracing is a big thing for a few of the surgeons who follow one company. It's frowned upon by surgeons who are following other companies. So it's become a slightly political issue. If you look at it from a surgical point of view, there are no RCTs you can compare.
Yes.
But in young athletes, I think there is a paper by Sonori Kote about repair of ACL. There are a couple of papers from US, from I think Shelburne's group, which have talked about ACL repairs, which have showed decent result, but the failure rate is around 20-25% as compared to 10% in a standard ACL reconstruction group. So if you are discuss with the patient that we are giving a chance for repair, there's no harm trying it. We are not burning any bridges by trying to repair it.
Definitely.
So, if you see the history of ACL repair or reconstruction, till 1980, all the ACL were used to get repair.
Yeah, mostly was open also.
Yeah,
some of them.
open and orthoscopic also. So the paper comes around in between 80 and 90. It says almost 33% of 33 to 40% of the repair ACL is having very good result. Remain 60 to 70% are worse. And at the same time, ACL reconstruction was gaining popularity with almost 85 to 90% of the success rate. So ACL repair almost stopped, and the ACL reconstruction were take the advantage of that success rate. But if you see, the same paper says almost 33 to 40% having good to moderate result. So they selected which type of patient they were, because even with the ACL repair, your 33 patients are doing very good. So they found that such type of lesion, those who have a type 1 type of lesion, they did very well in the follow-up. So they advocate for repair of such type of tear.
Yeah, they have also decided some the quality of the tissues should be good and some other criteria they have mentioned. Yes, sir, please.
What I say that in 1980s, what you are talking, that was a separate era, rather, very
Yes.
primitive thing. Now we are talking about all the time stump preservation, stump saving, stump doing that. So if you have this kind of tear, then it has to be preserved as far as possible.
Yes.
Now people are doing, they are making graft passage also, and you are suturing the stump to the graft, matlab something which is beyond the only the internal bracing.
Yes.
So nowadays, just saying that I will just remove it and will do a reconstruction, that may not be very feasible if we say in present scenario. This is what I have to say. Maybe it fails, you tell the patient it may fail, I will reconstruct it afterwards. So that's the thing, my opinion.
Definitely we have to take the consent for reconstruction also. If intraoperatively we'll decide whether we can go for the repair or not. So in this case, any other opinion, any other suggestion, please? Yes.
Operatively shows it's a grade 2 sprain kind of thing rather than complete mid-substance or complete avulsion. In those cases, I always keep at the back of my mind that repair is one option.
Definitely. In this case, we may go for the repair, but we all have our reservations, and still we are not the results, what we have done, the repairs so far independently, I have also done, Dr. Arvind has also done several cases. But the results were not so promising, so we are on the back foot so far. But we are also gradually tending towards that repair side. If we get that such properly selected cases, then we should definitely go for the repair. What we did in this case was a reconstruction with the remnant preservation. Sorry, it's not moving. Yeah, pre-operatively we have to plan that in this case we yeah, definitely. On the basis of MRI, we can see that on the basis we can judge that it's sorry, it's type 1. So in type 1 only there are, and definitely the duration of the from the injury. In type 1 only definitely we have a chance that we may go for the repair. In such cases we have to counsel the patient regarding that, that if possible, if the things are in favor, then we may go for the repair, otherwise reconstruction is the option which we are already having. No. Pre-operatively, on the basis of MRI and considering the duration of the injury, we counsel the patient that if there is a possibility, we may go for the repair. Otherwise, reconstruction is always there. The chances are always there. Anything?
So, purpose of putting this case for the discussion was, if you see the MRI in acute setting, less than 4 weeks, if MRI can predict it's the type 1 Sherman type of ACL tear, avulsion, just avulsion from the femoral side. So you can counsel the patient about the repair, and you should be ready with the repair material in OT. Anchor and this knotless fiber lock nowadays, with maybe if you want to augment with fiber tape. So all these things would be available. We did 6 cases previously also. In this case, the patient was not concerned about the repair. So reconstruction was done with all the remnant of ACL, whatever it was, to be preserved. You can see in the video also, the remnant was not touched at all. Remnant was as it is, and this ACL reconstruction was done. You can see the reconstructed ACL.
So one concern is joint is getting overstuffed with this much of remnant. So to just take care of that, we have checked for the notching in the full extension. It was not notching, so we are assured that it's not going to hamper the extension.
Generally, when in this case of preservation,
here we can see that in full extension we have checked.
So it is damaged usually by the reaming or
So in this case, we are using that anchors, swivel lock anchors if you are going for the repair. And in this case also, we try to protect as much as possible.
It is damaged, no?
Yes, definitely it's damaged. That's why we have not done the repair.
Reconstructions have been done for a long time. It is more like a double bundle where the PL bundle is kind of the remnant and
So
you can go through, you can build the tunnel, visualize everything, make sure that the drill that is passed through the gate doesn't, you are going to the same attachment.
yeah, definitely. So if you see the complete ACL footprint on the tibia, it's almost 14 to 15 millimeter in the anterior posterior part. And this graft was, I think, 8. So you can take this graft in the anterior part just at the anatomical level. So even that anterior part of this remnant ACL will be there. My one question to Bhushan sir, lot of people have started doing this remnant preservation ACL reconstruction. Do you have any chance of second look into the joint and what is happening to this remnant preservation? Because I have once, that remnant was as it is, it was not healed to the reconstructed graft, it was as it is there. Bhushan sir.
So the main problem of remnant preservation or a big stump preservation like this is a cyclops lesion with a resultant FFD in post-op period for most patients. Now, a quick comment on this, beautifully done surgery, I agree, but if the remnant is sitting on the graft, the chances of not forming a cyclops lesion are quite good, not forming, so it's a good result I'm seeing. Now, most important thing about what you were saying, is that the periphery of the ACL is where the blood supply comes from. So even if you go in the center of the ACL and take out the central part of the footprint, you're still preserving the peripheral synovial part of the graft where the blood supply is coming in. So when you're doing a remnant preserving ACL, your aim is to come through the center of the ACL footprint, the so-called Samba technique. So when you put your guide wire and a drill in, you should just see the ACL stump moving about like that, and you're sure that the blood supply is going to be preserved. Central part can be easily taken off. An important thing is not to take a thick graft. So quite a few times we just take gracilis when you have a really good stump. So that becomes a bib technique or biological internal bracing technique. So you are internally bracing the present ACL with biological tissue, and in addition you can take a stitch on the stump and fix it with a small anchor or with a stitch or suture which goes in your endo button, tritro button or whatever button you use.
Yes, I agree with you, sir. When I was a fellow with Professor Frederick Fu in University of Pittsburgh Medical Center, USA, and he is very keen to preserve all the remnant while doing the ACL reconstruction. And I observed him for 6 months of his technique. He did just to separate both the AL and PL bundle and pass this guide wire, and while you have mentioned that there is rotating the reamer, that is his technique. And another thing, how much tissue should be kept there. The tissue which is attached, the remnant which is attached falling down over the ACL, it should be kept as like that. And the tissue which is falling down, it should be removed. Otherwise, it will later on lead to the cyclose formation.
Any stump which is anterior to the ACL, I think footprint, don't keep it there because chances of cyclo formation is more on the anterior part. So I think in these cases you can keep that part because the whole of the footprint, whole of the ACL was falling on the ACL graft, reconstruction graft. What was the diameter of your graft here? 8.
So the question is how thick is good? How and graft thickness? How is optimum? How much is optimum?
Again, it depends upon the patient. Normally, you should cover 80% of the footprint. So, minimum 8 millimeter graft is mandatory. But that is not true for, I think, an athletic population or a basketball player. There you can go up to 9.5. So it should not be overstuffing. You should not have any impingement with the wall, with the roof, or with the PCL. And minimum graft diameter, I think 80 millimeter. I think all of the whole, there is a consensus that it should not be less than 8.
How difficult is to pass through the substance of the original ACL, the graft?
If you have drilled the bony tunnels of the right diameter, that soft tissue stretches out nicely.
And normally when you try to pass it, you take your probe, try to push your remnant of the ACL towards the lateral side, and you can see you can fire a bead pin, then put your scoop over the bead pin so that you are not damaging the remnant there. So by these are the two, I think, simple techniques by which you can preserve the remnant. Yes, Rajiv, next.
Technique is passing the graft in the tibia or in the femur if you have kept the remnant there. So for passing it should be completely clean. So very less chances of Bhusan sir.
When you're doing a roll inside, normally we bottom out the graft on the femoral side and put it on the tibial side. If you've got a good stump, you have to reverse it. You have to bottom it on the tibial side and put it on the femoral side. So your the cigar graft, it goes inside the tibia, and then when it comes out to the femoral side, it pulls out all the remnant nicely within, like a sleeve. So it works really well. What you have to do is put a 3.5 shaver in your prepared socket to clean up the central part of the ACL remnant. So you just are left with a nice sleeve, and then you can pass the graft in. Sometimes you take your arthroscopic scissors or small biter and make a vertical cut on your remnant for allowing the graft to go in easily, and you can even stitch it later if you want. That's a bit of an overkill in my opinion, but you just reverse the step of all inside when you're doing a remnant preserving.
So, going through the literatures, one of the paper by Gregory et al., which was published in 2015, it was a retrospective review of 11 consecutive cases. They had included the proximal avulsion tear having the excellent tissue quality confirmed just before going for the repair. Patients were excluded if these criteria were not met or the patient had a multiligamentous injury pattern or significant arthrosis or grade 3 corneal changes. The ACLs were reinforced with the 2 fiber wires, and it was anchored with the 4.75 mm swivel lock anchors. The 10 of the patients had good subjective and clinical outcomes at an average of 3.5 years follow-up. So they concluded that the preservation of the native ACL using the described this primary repair technique can achieve the short-term clinical success. They also didn't have that long-term one follow-up in the carefully selected subset of patients with proximal avulsion type tears having the excellent tissue quality of the remnant. This was the photograph provided in the paper. This was the anchor they have used, and this was after a final repair of the graft. They also said that the torn ACLs are resolved and nearly 3/4 of disrupted ACLs showed some intra-articular attachment. This reattachment is indeed a noteworthy finding because it was described that the healing properties of proximal ACL tears are just like that of MCL, in which in acute cases we go for the repair instead of the reconstruction. So the patients having the excellent ACL tissue quality, which was defined by a broad stump with mild interstitial tearing and the ability of the tissues to hold the sutures properly at arthroscopy. This is the criteria for going for the repair. Another technique by the Nishit Shah et al. Was the suture pull-out technique. In this paper, they have mentioned they have gone for the repair in the cases which were only less than 2 weeks old. And they have also mentioned that the selection of the tear pattern rather than the technique of the surgery were responsible for the failure rate or the success rate in these cases. They have done that around 7 mm rimming from the, they passed the guide wire from the intra-articular side, but they have drilled from the femoral extra-articular side, and they have, their logic was that if they are having that 7 mm tunnel, then some of that tissue will be inside the tunnel, so it will promote the healing better rather than only the surface healing. So that's why they have drilled it, and to preserve the remnant so that during reaming the remnant is not damaged, they have drilled from the outside. And they have used that suture disc on outside, and they have repaired it with the pull-through technique. Another, this journal has, this paper has tried to classify these tears in a different way, just to have a better predictions for the survival of that, or better prediction for having a decision making for this repair. And
So,
they have, pardon?
excuse me. So operation is, the theater is ready now, so please
So we can
conclude
just,
it. Yeah,
hold
just
it.
finish it off. Okay. Thank you. So Rajiv Rahman sir.
So we are live now
Rajiv.
with the surgery.
Yes, sir. Ravi is there, sir. Ravi is moderating this. Dr. Ravi Kumar.
Ravi, this was a 1-year-old injury. How many times he had locked episode, we never know. But you can see the ACL is not there. The lateral wall is empty here. Okay?
Yes, sir.
I just prepared a bit for you. The lateral compartment is fine for all practical purpose.
Okay.
We have visualized that. This is the anterior of the lateral meniscus. That is your PCL, medial tibial spine, and this is your bucket handle tear which was locked and very resistant to go in.
Okay.
Okay? Can you see that?
Yes, sir.
Yeah?
Yes, sir.
I can barely hear you, doctor. Okay, we have to reduce this in this fashion.
All right, sir.
Okay? Right?
Yes.
We had a little struggle to reduce this because it was not going in, budging in inside, okay? We had to do a lot of pike resting on the medial side. And if you can see this, a bit of shaving is done to promote some vascularity. We also have poked with the needle to, stimulate healing here.
Yes.
You can see this point. Yeah?
Yes, sir.
Okay? But the good thing about this cartilage or this patient is you can see the cartilage is great. Okay?
Yes, sir.
The tibial condyle is great, the femoral condyle is great, and he is a young bloke. So in all possibility, you should try to reduce this and try to save this meniscus as far as possible.
Okay.
And then get one first reduction stitch here in the center here in this fashion.
Okay.
Okay, then you can work on it because there is also tear going close to the root here.
Yes,
you
sir.
can see?
Yes,
Yeah?
yes, sir.
Yeah?
Absolutely, sir.
So this is important. This cartilage structure is important, how it is when you do a repair, age of the patient, and of course the collateral, whatever injuries he has. He
Yes, sir.
has an ACL also here. So ACL for young bloke with bucket handle, it will also go in favor of doing an LET. But for the time constraints here, we are trying to do only the meniscus. Is that okay?
Yes, sir.
Okay, slotted cannula, please. इधर से आ रही तू.
So Rajkumar sir, if it was a acute tear, what was your sequence of repair? What could have been your sequence of
What is
repair?
the sequence of repair? Good question. It's a locked joint. Then you need to first of all give a traction in the ward, try to get it unlocked. If not, then probably post him for a unlocking of the meniscus and repair in the acute setting. But having said that, acute setting scenario, the challenge would be for you to handle the life of the knee. The life of the knee and the oxygen supply of the knee comes from the infrapatellar pad of fat. If you are able to handle the infrapatellar pad of fat well, the stiffness in the joint can be reduced. And also you can very well use a good post-operative rehab protocol for the patient in the form of game ready and those kind of things, and then that will take away the fear that you have of an arthrofibrosis of acute setting reconstruction. Is that okay? Then we'll see how best we can do. Okay? Yeah. Hmm. 20.
Rajkumar sir.
Yes, sir.
Vinay here. So,
Yes, Vinay, namaskar.
some words about the trajectory that you think you should approaching to the posterior horn, middle or anterior. There's some difference in trajectory. Same portal, the other portal you use for this.
For the middle third and all, I like to come from the opposite side. Same side I generally go with for the posterior horn. Anterior horn you can go whichever way you want with the flex needles now, or you can come from outside in this fashion. Okay?
Yes, sir.
Inside out here, from here to there. Okay?
Yes,
from
sir.
middle third, inside out. Posterior third you can keep it as all inside. Outside in or inside, all inside with the flex device on the anterior side. Okay?
Yes, sir.
But remember, the fourth zone that is there in the meniscus as described by Smegleski doesn't have a meniscocapsular attachment. But we all of us will fix this to the meniscocapsular junction. Is that correct, Vinay?
Yes, sir.
Yeah, we still fix it because anatomically it is not fixed. If you read this Smegleski's paper. But we all wanted to fix it in this fashion here. Okay?
Yes, sir.
I'll also just show you one more trick. Can I have a spinal needle which is long one? You can see this needle coming in.
Yeah, we can appreciate that.
Yeah, but it is going at a tangent. Okay, so I need to come in a direction wherein it is useful for Can you see it now?
Yes.
Okay, the length of this needle is very small. Okay, it is hardly is able to reach, and I am already on the skin there. You generally can hold it in reduced position in this fashion by poking the meniscus. Okay, that
Yes,
also
sir.
you can try if you want a reduction. Okay,
Yes, sir.
clear? Yeah, in this fashion. Yeah, okay.
Yes, sir.
Yeah, चलो. बराबर. Okay. इसको ऐसे रख. Okay, also the trajectory I will always check. Trocar देना भाई जरा. Trocar देना. You always have to be perpendicular. निकाल इसको. Your line of action should be perpendicular. Always check with the trocar if you are in doubt whether you will be able to reach that zone, and you will be able to fire the meniscus and fix it. Okay?
Yes,
This
sir.
is how
So
it
you
has to be one,
you are
two.
you like this all inside thing for the reduction stitch, or you use inside out device?
Both can be done, but in this case, for demonstration purpose, I am using the all inside here in this fashion here. Okay? Yeah. चल भाई. Okay, this is a slotted cannula coming in. You can use it both for reduction and passage of your device. पकड़ ऐसे पकड़. बाहर. You have to be careful while you're passing it through the slotted cannula, because your assistants are very keen to, help you as much as they can, but they also can, poke themselves. Okay, out. Yeah. Okay. Yeah. Okay, this is the first one that I am going to use here. I'll drag it a bit in this fashion. Okay, this is only for getting the length of the meniscus there. See that? Okay?
Yes, sir.
Fire. For the beginner, this device will give them some challenges. So they have to work with guys who are used with this kind of a device, because you can see I am not that, very smooth in exiting, correct? Okay, why that happens is you are seeing this knot here.
Yes, sir.
It is because of that your exit through the meniscus is not smooth. All right?
Yes, sir.
ये क्या है भाई? अभी जाएगा? नहीं जाएगा? जाएगा कि नहीं जाएगा? Valgus, 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 valgus. Okay. Okay.
Bhushan, sir. So you said,
Yes.
Dr. Bhushan, you said you use inside out for this reduction stage. So did you shift it to inside out, or you originally using inside out and shifted from all inside to inside out?
कहाँ है भाई? Top light लगाओ. Top light देना.
Till the root, you can do inside out switch.
With this zone specific cannula system which has come up.
Absolutely.
It's a wonderful system.
And you do a small incision posteromedially.
Yes.
You can put a small spoon, ice cream spoon, or Henning spoon, or even a normal tablespoon in the back of the knee, and that
Correct.
saves your needle.
So
from
medial
damaging.
meniscus more or less is all inside.
Yeah, middle meniscus, everything is
All inside.
out.
Inside out, sorry,
Yeah.
yeah.
Okay? So this is their device to, just to get the sutures little taut onto the meniscus. Yeah?
Yes, sir.
Okay, pull a bit. Yeah. Okay. There it is. बस. हाँ, चल. Cut. बस. Cut. So that is your first stitch holding the meniscus there. Reasonable reduction, I can say. We need to get the top part of the meniscus there. This one has to go down. Well, yeah?
Yes, sir.
So we'll go in for a vertical suture there from the top. This was a horizontal one, just to show that we have to keep it there. From here you can come inside out or outside in. Both can be done. We'll get one vertical suture here for you. Please. Slotted cannula. Yeah. Okay. Yeah. Yeah. What's that? Nikal spoon.
Dr. Rajiv, any chance of neurovascular injury you think in this place?
So medial meniscus you are more safe, but when you are dealing with the posterior horn, try to avoid putting your mid needle towards the midline. So what I do, I always with either any of the device, these are angulated device. So you just try to put it towards away from the midline. You are on the safer side. So don't try to put it toward the midline. Because your neurovascular structure is just lateral to midline. So you are more safe on the medial meniscus. And lateral meniscus again try to put your needle away from the midline. So all these needles are curved needle. You can just make it zone specific.
Okay.
And also on the capsular side, you can reduce the length of the needle. You can make it around 8 mm or 10 mm. That required hardly for the capsular side. Again, if you are on the substance of meniscus, then you can increase the length to 12 to 14 or something like that.
Great, my God. Okay, if you think your knot is not great, you can just put your probe under the suture here in this fashion and ask your assistant to pull that. Yeah. Pull. Till you can see the knot. Yeah. That's okay. Some more. No. वो इससे पुश करेंगे बस.
So normally this cheese cutting phenomena occurs whenever you are dealing with a poor meniscal tissue in old tear.
Yes.
So this is the best technique. Put your probe there and ask your assistant to push and then pull your knot so that your anchor will also not come out and there will be less or minimal cutting effect over the meniscal tissue. So when you are dealing with this chronic tear repair of this chronic tear, I think this is a very important technique what Rajkumar sir has shown. And you can see the knot is now perfectly sitting there without cutting the meniscal tissue.
Pull. Yeah, stop. Yeah. Cut. Yeah, cut. Okay, it should be just right. You can see the meniscus is little lifting, but that is fine for me. I need to do a bit of gardening here so that I can get this flat. Can we go for the inside out? Yeah. Any other burning question that you have, Rajiv, that you want to know?
So that is your routine practice. So bucket handle tear, posterior horn, all inside. The body and the anterior horn, you can go for inside out or outside in. Yeah.
Correct.
Yeah.
But in all practicality, try to preserve the meniscus, as everybody is discussing. And that is the way when an youngster like this, for me, the health of the joint which is there like this decides what I do for this meniscus. Okay, if it
Rajkumar
is
sir.
too bad and all,
Would you like
then
to
yes.
prefer some suture on the undersurface of the meniscus to prevent the lifting of?
I will be doing
Yeah.
that. I will be doing that. Yeah. No, I think
Rajkumar.
there are time constraints for this. Whether we'll be able to show everything, I am not sure. They are organizing all inside for us here, so we'll see. Inside out, sorry.
Rajkumar sir, Arvind here.
हाँ अरविंद बोलो.
Sir, in such type of unstable meniscus, that bucket tunnel, quite long tear it is. Do you want to? It's better to take one stitch that is inside out in the middle part of the meniscus, so that this will keep your meniscus stable. With one guy
Correct.
outside taking that tractional stitch outside the knee, so that your meniscus will be in place, and then it's better to put all inside meniscus suture in the posterior horn, then you come to the body and anterior
Correct,
part.
correct. That is what Rajiv was also mentioning. I
Centralization
said
anchor
for
first.
demonstration here, I am doing that. Otherwise, I would have done exactly as what we all know to do. You know, the reduction stitch first, and then probably they go ahead and do all the work either from posterior to anterior or anterior to posterior, but preferably posterior one first. Okay?
Yes. Ashish sir, just to wake you up, you have been doing ACLs for like years together, so many years of experience. You would have been doing a lot of meniscectomies early days. So have you seen any meniscectomy along with ACL reconstruction coming back to you after 10, 15 years of follow-up that, okay, my knee is osteoarthritic and I want to get done? So what's your experience of doing meniscectomies like 20 years back, 25 years back when you have been doing this?
To be very truthful on that, our patients, generally don't come regularly for your follow-up unless they are from the same town. We do handle patients from all across the country, number one. Number two, the very few who come back to us for a re-surgery or re-look is the ones who have a re-injury. And in those individuals, if the meniscus has been, as you said, meniscectomized or removed, then they will have some amount of early OA that can be seen. The duration that can, the time duration or the time frame which the joint needs to develop a OA is around 10 years. So if you have a career spanning more than that and you have patients coming to you at that time, we will see some amount of early OA with a mild virus in that knee associated with your instability, which is secondary to a failed ACL or whatever it is. Yes?
Yeah, Rajkumar sir, we will
Also,
shift to lecture again, and at the end of, I think we will see your repair, whole of the repair. By that time, you can complete your repair. We will come back
yes,
to
sir.
you. Yeah.
Yeah, that will be fine.
Yes, sir. So I think next talk.
Inside out there. Yeah.
And after that, we will call Dr. Ashish Kumar. Yeah.
एक मिनट हाँ
अच्छा
चलो फटाफट किधर है
ACL and LT बीच में
This was a paper published combinedly by the radiologist and the orthopedic surgeon, where they try to classify this ACL tears again, so that the decision making for going for the repair becomes easy. In the type 1, it's almost like the Sherman type 1, in which the remnant length is on the tibial side is more than 90% of the total ligament type. Only in this case they have recommended for the repair. And also they have quantified the incidence of the different types of tear, in which they have said that type 1 tear is 16%, and they have also emphasized the number is significant, so we should also try to go for the remnant, try to go for the repair if possible, because this is a significant number of total number of ACL tears. And they have also mentioned that its associated advantages of the repair is the maintaining the proprioception, preserving the biology, minimizing the morbidity, surgical morbidities, allowing for the faster recovery, as well as in some of the experimental findings, they have observed that if we are repairing the meniscus, then there are chances of restoring the native kinematics, and that's why preventing the long-term sequelae of the development of the osteoarthritis in the case which we also see in the cases of the reconstruction. This was the long-term study which we have already discussed about, which have mentioned around only the 33% survival at the 15 to 20 years, which also raised an interest in this, that even after the repair, 33% has survived for so long. So we should try to go for the repair. So one paper by Dr. Tapaswi in 2017, they have mentioned few of the, in which he has used that augmentation with the fiber tape augmentation to give the initial protection of the repair. He has mentioned some of the pearls which is very necessary if you are going for the repair, in which the assessment of the ACL for suitability of the repair, quality of the tissue which we have already seen, and in case of doubt, if slightest of the doubt, always go for the standard anatomical reconstruction. And one thing which is technically helps a lot, that we should use that the central portal, the transpatellar, the medial third portal which we use, in which that case through that portal it's very easy to visualize the medial aspect of the lateral femoral condyle. And in these cases it should be avoided if the tissue quality is not good. And these are the various nuggets we have already discussed. So with all this, thanks a lot for your patience hearing.
Thank you, Rajiv. And now I would like to invite Dr. Gurudev Kumar. He will be talking on ACL and LT.
Respected Chairperson, my topic of presentation is ACL reconstruction along with lateral extraarticular tenodesis. It is a procedure on the anterolateral side of the knee to just augment the reconstructed ACL to prevent its graft failure. This is a 20 male hammer throw player having right knee twisted injury. This is the X-ray. It looks normal, and this is his clinical examination. Anterior drawer test grade 3, pivot shift. It's grade 3, grossly moving, and the Lachman test, which is also grade 3. So we have planned to do a standard ACL reconstruction along with lateral extraarticular tenodesis. This is the MRI to confirm the status of the meniscus, ligament, cartilage. There is a classical buckling of the PCL, and rest of the structure is normal. So coming to the anatomy of this on the lateral side of the knee, it is the anterolateral capsule attached from the lateral epicondyle to the Gerdy tubercle. It is nothing other than the anterolateral ligament, which prevents the pivoting mechanism central from the knee. So the purpose and the goal of this lateral extraarticular tenodesis is to increase the soft tissue restraint on the lateral side of the knee, a distance away from the central pivot, that is the ACL. So there are certain indications, so in which cases we have to go for the lateral extraarticular tenodesis. In the setting of revision ACL reconstruction, pivot shift grade 2 or the grade 3, this is the itself patient is doing the pivoting mechanism of his knee. There is grossly subluxating of the leg on the knee. Sports with pivot mechanism like the football player. Ligament laxity, see here there is a grossly laxity of the multiple ligament. Lachman test, more than 7 millimeter of the angulation, and the contralateral ACL rupture. Usually the lateral side of the knee is too much tight. Here we can see there is drive-through sign in the lateral side of the knee joint. The completely the joint is going to open. Other indication when there is the chronic ACL tear, young individual which is highly involved in the high demanding sports activity, and the radiological sign of the lateral femoral condyle depression is more than 1.5 millimeter. And the last, there is second fracture, where we can go for the LET. So coming to the quick procedure, how it can be performed. So before going to procedure for the lateral extraarticular tendinosis, we do the standard anatomical ACL tunnel both on the femur and on the tibial side. So for the LET, we mark all the bony prominence, lateral epicondyle, guardi tubercle, fibular head, then make a skin incision along the line of the IT band more towards the posterior side, approximately 6 to 8 millimeter proximal to the guardi tubercle. Then dissect the skin and subcutaneous tissue with the help of fine scissor to indicate the border, both anterior and the posterior side, to expose whole of the IT band. Then with the help of 11 number knife, delineate both anterior and posterior side of the IT band, then pass the artery forceps underneath this IT band as a whole, then mark the central 1/3 of the tendon or the 1 millimeter, 10 millimeter of the central tendon width, and 8 centimeter in length. Mark with the marker pen, then detach it proximally, and then fascinating the under surface and from the vastus lateralis, keeping the attachment, keep the attachment intact at the distal segment at the level of guardi tubercle. Then whip stitching the free end of the detached IT band, then measure it, it is approximately 8 centimeter. Then identify the fibular collateral ligament. Sometimes it is difficult. In that situation, we do the figure 4 maneuver to identify it. Then mark both anterior and the posterior side with the help of 11 number knife. Then pass the mixture underneath the fibular collateral ligament and dilate it to smoothly passing of this IT band, which is kept it in the extraarticular, extracapsular. Then pass this IT band underneath this fibular collateral ligament. Then identify the attachment of the elite on the lateral epicondyle, which is proximal and lateral. Then pass this the guide wire towards the anterior, and keep in mind you are not passing through this the reconstructed tunnel on the femur for the ACL. It is just touching. So before doing the ACL, we keep the thread inside this femoral tunnel. Then drill according to the size of this graft, then pass this ACL, finish the ACL surgery, then pass this graft through this tunnel and fix with the 7 mm bio screw in 60 degree of flexion and neutral rotation. Don't overrest tensioning over this graft, and this is the immediate intra-op stability. The knee is quite stable and there is no pivoting. Then closure of this wound with the interrupted stitch. Don't to close it through and through, otherwise it leads to the over stiffness and over constant the lateral side of the knee joint. And this is the post-operative X-ray. It is a location of the tunnel and the button and the suture disc. And this is the picture I got from him today. He is under the rehab program. This is the around 9 months of the post-surgery. He is in Punjab doing this, doing his training. So thank you for all your patience.
Hello. So wonderful result. So your decision to do LET is pre-operatively or intraoperatively? How do you decide you have to perform an LET?
No, not on the intraoperative. It's decided preoperatively because he is the, in particular this case, I have seen his activity and he is involved in that game. So I decided to do the LET along with this ACL.
And any chance of restriction of internal rotation? So in the sports which involves pivoting, you won't need to pivot. So any restriction of rotations which happens with this LET procedure that you have seen?
Any restriction of movement?
Yes, restriction of rotations because it is going to inhibit the internal rotation.
Yes.
So any restriction, how do you manage the tension that you're going to give because it is going to restrict?
Yes, it is written in the literature. You have to apply the 20 Newton of the tension while tensioning the graft. Before coming this procedure, there is in the literature, there is overstuffing of the lateral side of the knee and the osteoarthritis. So in the original lamellary, there is a fixation of this graft in the external rotation. So that leads to the type of complication and the over stiffness. Nowadays, it is just in 60 degree of flexion in neutral rotation with not too much amount of tension over the graft.
Sir, how do we ensure there is no tunnel overlap between both the
yes, it's very close to the, while you are doing the, passing this graft over the femoral site, you are very close to your ACL tunnel. So for myself, I do the tunnel both on the femur and on the tibia, not passing the graft, just pass the loop thread, and then for the LET, pass the guide wire and check after all the steps. Guide wire, then put the scope, check the tunnel whether your guide wire is through this tunnel, then remove it with the 4 mm of the reamer for the indovert, for the passing of the bead pin, again check, and then finally 15 mm of the femoral drilling for the graft passage.
Two more tips in this case, Ravi. One, you can keep the 4 mm reamer through and through that you have made initially in the femur.
Yes.
That keep there, and then you do the LET part. Okay. Another thing, once you have passed the bead pin for the LET tunnel on the femur, and you have removed the 4 mm, you can check the bead pin again inside with the help of a scope from the anteromedial portal, and you check in the tunnel whether this bead pin is not in your ACL tunnel. So these two tips, that is very confirmatory that you are not collision with your tunnel is not going to collide with the ACL tunnel. And third one, you can keep the thread there. But when you left the thread in the tunnel, and once you are with the 4 mm for LET, then there may chance, if your reamer is through that tunnel, then your thread may get entangled with reamer. So this is little bit dangerous. You can put the 4 mm reamer of ACL tunnel, left it is as in the tunnel.
And then
Bhushan sir, your expert opinion on that, LET with ACL.
So we normally just leave the thread as you rightly did. So if you leave the thread in the ACL tunnel and then you do the LET, and after that you put a scope in the joint and have a look in the ACL tunnel. And you, if you are able to see the guide wire going through, that means your tunnel is not right. And you can play with the position of the LET tunnel. You can increase the trajectory, you can change the trajectory going superiorly or inferiorly based on, well done Rajiv. So you can either go anteriorly or posteriorly based on your trajectory. But it's very possible that your LET will go through your ACL if you already passed the graft. So always be certain that it's not, that there's no tunnel coalition before you pass the final graft.
But recent nowadays there are so many techniques. You can use the swivel locker also and the stapler to prevent that type of complication during your LET procedure.
Thank you, Gurudev. Nice demonstration.
Thank you, sir.
So we have our next talk by Dr. Ashish Kumar. He will be talking on ACL tibial spine avulsion fixation. And also he will be requesting everyone to register for ISCON 2023.
थैंक यू वेरी मच. मैंने क्या म्यूज़िक वालों को स्टेज को सलाम करते देखा था. राजीव इतना ज़्यादा स्टेज पर रहते हैं कि इनको भी ये ठीक है जो कर क्या है. So actually this is not exactly the case, but I have just modified it for the purpose, and this will serve the purpose, I think so. So a 24 history of fall from bicycle 1 month back with a knee pain, swelling difficulty in walking that was immediately there, that reduced over the time. He can walk but with feeling of insecurity, and on examination the anterior laxity is there, rest of the things were normal. So if such a case comes, we go for the X-ray, we see an insignificant type of injury by the patient, but we all know it is not that insignificant and one has to go for the MRI. And once you see this kind of case, this was a case given to Rajiv while he was in Lucknow. Same case, he did it. So you see this kind of bony chunk, it's a big one, you are happy, you have many options to do it. If it's a smaller one, then it's a trouble. So these are the views you see, and you understand that this is the situation where the tibial avulsion, this was the topic given to me. The tibial avulsion, a bony piece of varied size that is avulsed along with the ACL. So this is something which is common in children, which is contemporary to our ACL tears in the adults, leads to anterior instability, and malunion is a common problem with this, where there is an extension block into the notch. So this has to be taken care. This is the basic crux of this talk. This is the classification one should know, type 1, 2 and 3, and type 4 is also there. So type 2 is something which is the most common one, where you have a posterior hinge which is attached to the tibial eminence posteriorly, and anteriorly it is elevated, and of course this is highly likely to get malunited with your conservative treatment and will lead to the extension block. This is the major issue. Of course, if there is a combination, then it's a different story. You have to be more cautious. When it's floating high up, then it has to be taken care in a better manner. And the type 1 where it is undisplaced one, there you can go for the conservative. This is the basic thinking. Old tested techniques, old tested thing, we all know it, we all do it, and anterior part of the knee is always easy to play with, and everybody is comfortable with his own experiences. Another classification the MRI people have proposed, but I think that one, the first one that we have seen, that is good enough to understand. If you go for the further understanding and make things more clear and happy for you, go for a CT scan where you can get the size of the chunk, whether it's a just wafer-like or if there is any combination. So this is what you can go ahead with this CT scan. Now, what should be the treatment option? Of course, the simple algorithm, if it's an undisplaced one, just wait in extension, full extension, and confirm that it is reduced to its crater. Once it is reduced in its crater, no problem, you can achieve full extension, just leave it as such over there for a few weeks and then go ahead with the rehabilitation. Type 2 is again always plus minus either way. If you can do it, better to do it. This is what we are doing so that we can start with the physiotherapy and prevent other complications like stiffness. So this is, and the type 3 definitely you have to go for the different techniques of reduction and fixation. And the timing of surgery, earlier the better. We all know it. Once we are going to repair anything, earlier is the better. Delay leads to difficult reduction, and if it's a very old one, then crater has got a lot of fibrosis that you have to clear out. And hypertrophy of the Evans fragment is reported also. So it's not sitting into its crater easily. Contracture in ACL is also is a problem. So whenever there's a chronic one, always tell the patient, I may go for a repair or I may have to go for a reconstruction. Of course, taking out that bigger part is always a problem. You create a mini arthrotomy when they are big chunks and you think about the reconstruction. So, we have done up to many years old also. If it's a big chunk, then one should try, and we can do it by doing some special things, and we can go ahead with the repair also. So, open reduction, older time, we are not here to discuss that. Arthroscopic reduction and fixation with the sutures, with the mini tight rope that Rajiv did there. Screw fixation, we all have done it, we know that it has got its own problems at times, but definitely a time-tested procedure. Screw fixation with a 4 mm screw is good enough many times. Other options like K-wire, bent K-wires, staples, I don't have experience of them, but people have done it. This is something given in the AO manual with a circulage wire people are doing, but I have never done it, not any experience, but must be a very cheap procedure. It appears like that. So one can do that. These screws are time tested, we have done it, but controlling their direction, you can create more comminution. These are the problems. So, and hardware removal may be a trouble later on, but many times you need not to do it. It works very well. So it's a big chunk like this. We have seen in this MRI, you can go very well with this screw fixation and it works. As you keep tightening it, it compresses the fragment very well and there is not a problem. These staples I have never used, but people do it. I have seen few videos like that. This is one thing very important, one should understand that underneath your fragment there can be menisci which can go inside, and of course this transverse meniscal ligament is something which definitely hampers your reduction many times, and you can very well remove it. You can pull it anteriorly through another portal and can go ahead with the fixation, or you can simply remove it. It is not doing anything, which is very important. So just a small video I had for the intermeniscal ligament, that you can see it is lying like this underneath the chunk and it is hindering your reduction. So you can very well remove it, but it's a known thing. Then this was the mini tightrope fixation that was done. It is proposed by the Arthrex. So you can very well do it. It's a big chunk. You can reduce it, press it upon with the simply your ACL jig, drill it with a less than 4 millimeter. Its drill is provided with that, and you can either just flip it, try it can flip by itself, or you can ensure with your hook, because in a lot of space where you can work, you can make a flipping, and then you can pull it, and like any other tight rope, you are tightening the thing. So this is one of the way of managing these things. But position of this tight rope can many times lead to malreduction also. So that's one thing you have to be quite careful. So you do it, but and this endo button can sink inside also over the time. So these are the little bit of problems with this procedure, but definitely it's one of the. Chalo bhai. People have used the threads used for pulling this tight rope. They have used it with the swivel lock anchors. You can just press it upon, put some swivel lock anchor either side, but that will exponentially increases the cost. That's the other thing. Then this is something very important. We all are doing with the sutures nowadays. The suture lever technique is definitely a very well established and very good technique that we all are doing. People started with using a single thread around the ACL, then people use two. Now it is proposing the 3 threads fiber wire that you are using. So the central one is going to reduce your fragment to its crater. That's important. You take this first bite and then go in the posterior part of the crater and pull through tunnel. That will lead to reduction. Instead of putting a K wire either from outside or from downwards, instead of putting a K wire and theoretically increasing the chance of combination, you can use this thread which is not disturbing at all. Even if a small wafer, a small bone, then you can do with this technique very well. So this is the concept. See this video, spend a little bit of time. It's a good one and it shows that you are separating the ACL and PCL between the septum. So this is, you can see, this is the chunk, and as you clean it up, you will see that's again the most common one. The type 2 has got a posterior hinge, and you are cleaning the crater, the blood clot, the bone pieces, and the fibrosis that can be there. Just clean it reasonably. It's a cancellous bone. You can remove as much as you wish. So be careful. Just the
पीछे ज़्यादा
minimal.
टाइट नहीं करना है.
So just take this first bite from the central part and make a noose around it. Whenever he is sitting here, he is against this noose. So you can make it, you cannot make it. I will show his one slide afterwards, as I always do. So this is in the posterior part of the crater that you just come out to shuttle this suture through that tunnel. So this is how you just shuttle the first one that you had taken, and as you just pull it down through the pull through tunnel, you will see that the fragment is going and sit in its central part. So this is, instead of wire or anything, this is the suture lever. This is the lever that is pulling down. So you are not disturbing anything with the bone. Now you are free with the reduced fragment, one from right side, one from the left side. Take 2 more sutures, make 2 more drills, 4 millimeter, and just pull through. So 3-point fixation of the fragment, you tight it over a suture disc or something like that, and then you can start with your rehabilitation on the very next day. This is something, the biggest advantage of this technique. Once you have secured everything fixed inside, and don't worry about the vascularity of the ACL. There are long-term studies which show nothing happens to the vascularity, but on the rare occasion they have said that ACL may fail above this bony fragment. This can happen, but most of the time people are very happy and there is no trouble. So the last suture that is being pulled out, and you just see that you have a 3-point fixation of your ACL. Then, so this is what I was talking about. Vinay has posted these movies. I just copied them, but I always say that I show because of him. Most of the places he is with me. And this is how he is saying, instead of making that noose around the ACL, you pass the loops like this. That will be more happy patient here. So in epiphyseal time, you can use simply an anchor. You can do with this kind of repair simply, instead of piercing through the epiphysis. This is what you can do. Rehabilitation depends on the quality of fixation you have created, and there is nothing very specific about this. So just gradual, you have to resume till the bone unites, and you can leave the person happily. Complications, of course, knee laxity may still there be persistent. You did a good job, or it didn't taken over by the nature. So failure of ACL proximal to the bony avulsion can at times happen, and you have to do later on ACL reconstruction. Quadriceps weakness and wasting is an integral part of any ACL injury. We all have seen arthrofibrosis if you don't start early exercises, and malunion may lead to extension block. These are the problems. Literature is full of articles, if you talk about, it's a old techniques and people have minor changes, and the important thing that ultimately it says everything works well. So there's nothing like that this one is better or that one is better. Whatever you can practice, you can do. Putting a screw, its direction, creating more combination, these are the ever-present complications. Sutures are a safer option. So this is what I can summarize at the end. It's not an uncommon injury. Meniscus, transverse meniscal ligament and bone pieces are obstacles to reduction. Be careful for them. Identifying, removing blocks and reduction may be critical for good outcome. Suture screw fixation technique can provide good outcome for displaced fractures. Strong fixation permits early rehab and predictable results. So at the end, for what I am standing here, this is the ISCon upcoming. I request everybody to please register for it. Everybody has to register, whether he is faculty or he is the delegate. And for those who are heading their institutes, I request please promote all your residents to go for it. Early bird is up to 15th of April, and we are not planning to extend it any further. It's very clear. So please promote them, and we are having the cadaveric workshop also on the 31st. That is a pre-conference workshop. It is all there, as you see, and abstracts is also open. Although there is a reasonable time till 31st July, but still those who are willing, they can send it. This is what you can search on the Google. It is IASCon. You have to write full IASCon 2023. Then it will be there, and you can see everything, all details which are updating continuously. So welcome you all to Lucknow, and that's it. Thank you very much. Any questions? Anybody?
Rajiv sir.
Yeah. Acha,
Rajiv
Rajkumar sir.
sir.
Yeah, Rajkumar sir. You are live now, please.
Just, waiting for half an hour now. Huh? You can imagine my condition. Huh? Anyway, Rajiv.
Yes, sir. Please, sir.
Can you see what I am trying to show you? This is
Yeah,
the
please,
last
sir.
of the
You are showing
inside
here.
out suture that I am going to show you.
Yes.
You can see this. I just kept this for you to see. This is how the needle will go through that. Okay, it is a curved device. Kindly pull that. Kindly pull that. Yeah, pull. Yeah. Okay. So there are a lot of vertical sutures going in here in this fashion.
Yes.
Yeah.
So it's a continuous vertical mattress suture you are putting from
Continuous
center.
vertical from anterior to posterior. You can see this.
And I think that has a best cinching effect.
Yeah. Okay, one is here. The second one is there. Third one is here. Some of them are fiber tapes. Okay, you can see that.
Yeah.
This is a suture tape. Sorry, here.
So
Can
you
see
are
that?
using Zone Navigator, sir?
Yes, Zone Navigator, yes.
Yes.
And
then this is the undersurface meniscal suture that I have put. Can you just pull that tape, brother?
yeah, pulling that will reduce the meniscus flap, uplifting of the
Aram
flap,
se,
yes.
Aram se, bas hai.
And you can
Bas
see,
hai.
yes, it's getting reduced.
Okay.
Yes.
So you can see the sutures on the top here. Okay. You can argue whether this is good or bad. Earlier when we were doing meniscal repair, they used to say that the meniscus should be, a good meniscal repair will have a everted meniscus like this. Okay. But later on we started putting the top surface as well as the under surface to make it flat on the tibia. Okay.
Yes, sir.
So any questions? Otherwise I will be signing off after tightening all this here.
Yes, sir. So I think it's, sir, the whole of the meniscus has reduced well. There is no uplifting also. And you have shown all inside technique, inside out technique, and all this technique. And I think in 2023, we should come with the note, save the meniscus whenever it is possible.
Yep.
And Ashish sir is also requesting that you should show this procedure in ISCon 2023 in Lucknow.
Sure. Thank you so
Yes,
much, sir.
Thank you, sir. All right.
You can also augment this with the fibrin clot. It is arguable because already when we debride this, there will be some amount of blood clot coming. But if you want to add an extra blood clot here, it is feasible. And
by anyhow, you are
PRP
making
and other
ACL
things
tunnels,
are
sir.
possible.
If you go for ACL reconstruction, you will get enough blood from those tunnels,
Yes,
and they will
yes,
sit down
yes.
over the raw area.
Yes,
Yeah.
yes.
Thank you, sir. Thank you so much, sir. And big clap
Arvind
for
sir.
Rajkumar, sir.
Raji sir,
Yes.
Sapnesh,
Yeah.
thank you so much. Chalo.
Ligament is not disturbed, but you have to make a little bit of release. Rarely it can be contracted enough that you are not able to bring it down. So you have to tell the patient, I may not be able to do the repair, but if you make a gentle separation upwards releases, then you can make it. It's not a big trouble.
Quality remains same.
Quality
The
remains the
strength
same.
of
Quality is not that bad.
long-term
No, no
follow-up
way.
is good for that.
No way, no way. Quality is okay. Anybody has other experiences for the older ones? Any compromise with the quality? I don't think.
There was a study in Japan where they said that when there is immediate fast disruption of ACL complex, it is the bone which comes up. It's a gradual deformation, the ligament like snaps. But it is never absolute this way or that way. It is somewhere in the middle, gray zone. So there is deformation of ligament as well as the bone that comes out. Whatever happens earlier, bigger, it is intrasubstance or avulsion. Based on that, the Japanese people, they recommended that taking bite through the ACL would not be a very good idea. So taking the circumferential bite and doing something and knotting. So it's never that the ACL ligament is, there is 50% patients who had intrasubstance changes in the ACL as well. So that is it.
So now scorpion has come, otherwise we used to do with the lasso and or rarely with the only right angle only.
Yes.
That works. So normally we are doing that.
I think that regarding the question of Dr. Rajiv, he was asking about the position of the, about the quality of the ACL. And I think that doesn't changes much, but because of the presence of the elastic fibers in the ACL, there can be chances that it might retract a bit more over time. My question to the house is that how many of us are using antegrade devices and how many of us are using retrograde devices for the suture technique, suture pull-out technique? Antegrated, hands up.
No, what do you mean by antegrade and retrograde? Oh, lasso and, all right. So I think lasso is the standard. If you are comfortable with lasso, we have started doing with.
But you can take a big bite that goes almost from the posterior part. So it is something like circumferential only. You are not going into in between.
So I think if you are comfortable with any one of them, either the antegrade or retrograde, you can just, because you want a cinching suture, cinching loop there, and there should be a 3-point fixation, one central and one on the medial side of the gutter and another on the lateral side of the gutter, so that you can mobilize this knee early. That is the main issue. Yeah. Yes.
So about the chronicity of ACL spine avulsion. If it is chronic one more than 2 months or 3 months, so repair depend upon the chunk of the bone. I have seen sir has fixed almost 3.5 month or 4-month older injury. John sir has fixed in 2014, and that patient did very well in the post-op period. So it's depend on bony chunk. If it is a small or very small bone is there, and if it is chronic ACL, it's not the bone to bone healing, it's the ligament to bone healing. So in that case, the chances of failure is high if you do repair with the chronic ACL. If fragment is bigger, bone is bigger, then you can go to 3, 4. At the same time, definitely the vascularity of this ligaments.
The only issue is when you are dealing with this neglected ACL avulsion, there is synovalization of the fragment, and you have to make the crater, you have to debride the crater also, and sometimes you have to debride the undersurface of the bony fragment so that it sits well. But anyhow, if you can repair this ACL avulsion, that is the best way to. That.
Regarding the chronicity of this avulsed fragment, question to the Ashish sir. Sir, most of the time in the chronic cases or old cases where there is a scarring of the tissue and filling of the fat defects with the new bone. In that situation, when we are going to fix that fragment, during the releasing procedure or the debriding procedure, there is a chance of avulsion of the anterolateral ligament from that piece. Because most of the time that ligament is attached to this.
On anatomical ACL reconstruction with radiological evaluation.
thank you for inviting me for this talk. I think I have given this talk 2-3 occasions on different platforms, even in Patna. So what we do is that we started using SIAM and our indigenously designed grid for doing ACL, making the tunnels for ACL reconstruction. And we'll show you the results at the end of the day, where we are right now in that and what we are doing. So the whole idea is to reconstruct the anatomy as it is, as close to the native anatomy as possible. Okay, there are a lot of common mistakes that people can do in ACL reconstruction, and the commonest of all across all the literatures, if you talk to the surgeons, if they evaluate it correctly, it's the tunnel position. Okay, the most common problem with all the ACL reconstruction is the malposition of the tunnel, though there are many causes of failure. Okay, so how to correct that tunnel position is very important. You want to preserve the remnant because remnant has something. Remnant does have something. It has proprioceptions, it has neurological implication in a longer run, because we know that at the end of 10 years, 12 years probably, patients are losing the effect of what you have done the reconstruction for. So it is very important, as long as possible, as much as possible, to, and if you have the remnant, to preserve it. But then there are many literatures about preserving the remnant, many literatures about the tibial tunnel and femoral tunnel position affecting the outcome of your ACL reconstruction. Okay, so there have been many theories in the past. Lot of the time anatomy has been redefined, defined. Lot of lines and ridges have been told. Okay, but then how to recreate it? Because the ACL never changed. The ACL anatomy in the human body has never changed, but we have kept our, how to make the tunnel, how to position the patient, we have been keep on changing. We have taken the clock into the theater, and we have taken clock as 2 o'clock position or 4 o'clock or 10 o'clock, whatever. But then again, ACL anatomy has not changed. Okay, so there are papers where when you're doing a single bundle ACL reconstruction, how you are going to use it. So intraoperative navigation is one, you can do it. Okay, there are methods to use fluoroscopy in the past, that if you're using fluoroscopy, the outcome improves. These are older papers in the past. Okay, so and then what people have done is that they have done it without doing fluoroscopy. They have revisited their tunnel and they have found the ways to improve. If they think that they are too much behind, too much front, too much up, they have come back and improved it. But our idea was to how to improve it real time. So we took Bernard and Hertel grid. These are the papers in the past where they have inbuilt Bernard and Hertel grids inside the SIAM. So they proposed to use this grid, and this is how they were doing it. And there are many studies which has told us where exactly in a single bundle reconstruction the tunnel should be or the bundle should be placed. So what we did is that we designed a grid which was printed on a transparency sheet, and we took a SIAM image before making the tunnel by just putting the guide pin, and we just measured where it is and where we want it to be, and we changed it accordingly before we started drilling. So initially it used to take 10 minutes for us to overall extra 10 minutes. Now it is just 3 to 4 minutes. This is in the femur, and then this is in the tibia. Okay, so this is a small video. Okay, so what we do is that SIAM is positioned from top or bottom. So SIAM is positioned, we don't use a leg holder, it's just that patient knees flexed on the table. Okay, and we take a shot. So we put our guide pin there, and we take a shot, and then we measure it. We measure it, and we want to, and if it is not where we want to, then we change the position of the guide pin. So we measure, because these are equidistant boxes, and it is showing that it is at the 18% from front to back. We don't want 18%. Okay, so we'll change the position, and then we'll take a shot again, and we want to change it, and then if it is according to where we want, we'll go ahead and drill it. So we have changed the position. You can see that it is like 5 boxes from behind, and it is overall 18 boxes. So equidistance boxes, so 5 by 18, it will be roughly around 27, 5 by 18, roughly around 27. So this is where we want to be actually. In your femur, and top to bottom also, we want to be at 33%, which is exactly 37%, which is exactly where we are. And this is a very small step, very small device, with which you can actually make a difference. Same is in the tibial tunnel. You'll place it, you place it where you want with your seeing the anterior horn of lateral meniscus, but then taking a C-arm shot, it does improve little bit here and there, it does improve. Okay, so what we did is that of course there are pearls and pitfalls of all these methods. Pearls is that you want to preserve the remnant, which you easily can, and it's non-expensive to start with, and it is very easy to master. C-arm is there in every theater. Pitfalls, of course, if you are using a transtibial femoral tunnel technique, we have not done using that, and it may be difficult. There is definitely a risk of radiation exposure, but then, and one value may not suit all the patients, okay? But then most of us are doing a single bundle tunnel placement, so this actually does not come into place. Then we evaluated all our C-arm tunnel with 3D CT scan, and we took measurements. So we went ahead and we published this grid in 2017 in Journal of Arthroscopy Technique. And recently what we did is that after taking this 3D measurement, we followed our patients for 4 years. So those which we did from 2014 to 2017 and from 2017 to 2021 mid and 22. So we followed them functionally. Their tunnels were seen by 3D CT. Both the group tunnels were seen, and we published our results in just now in Arthroscopy Journal, and we found that our femoral tunnel placements have drastically improved. Okay, we have not changed anything in the past, only the C-arm and the grid was changed. And our femoral tunnel placement, you can see, have drastically improved. Not so much as the tibial tunnel position, because tibial tunnel, there is a less chance of you going too much wrong, okay? Does it really improve when it comes to patient function at the end of the day? Yes, it definitely does, and at the 4 years, all these parameters at the end of 4 years, they showed up good with statistically significant definite improvement in patient functional outcome. So, and of course we are making this as a more user-friendly device. We have patented this. We have filed a temporary patent. We are improving our device so that it can be used for everyone, and at the same time has to be very, very cheap. Okay, so of course this improves our tunnel position, and we have shown that over a period of time, 4 years is not a small period. Okay, of course we don't have too many patients who play sports. We don't have too many patients who play sports, so that could be a different ball game altogether. But then 4 years time for the average patients that we operate, for at least I do operate, they have shown a significant improvement in 4 years with this method, C-arm, grid, and follow up all these patients. So thank you very much. Utilizing C-arm is definitely not difficult and can be easily be done. Thank you.
Nice study, Sudeep. Sudeep, so what is your position of the knee when you are taking the C-arm image? 90-degree flexion or hyperflexion?
Hyperflexion, definitely.
Hyperflexion.
We start with 90. So when we start with 90 and we hyperflex it.
And you don't use the offset jig also?
No, I don't use offset jig, not now.
Good.
No.
So just one question. In post-op X-ray.
Ash Kumar.
Your voice is not coming that great here, Dr. Ashish.
Hello.
So I think if we have a short history.
हाँ भैया
हाँ जी.
बताइए.
So is this patient? हाँ. आवाज आ रहा है हमारा?
हाँ अच्छे से आ रही है.
So this patient had a short history. 18th March he had an injury. In the RTA he is in late 20s, young lad. So this is what I got. Clinically, the drawer was positive, the lashman was positive. It was very painful knee on the medial side. I couldn't elicit that much of opening, but it reported MCL, I think grade 2 in an MRI. On scopy, this is what I found. Under anesthesia, it was opening in in 30 degrees on medial side valgus, but not on extension. It was not opening, so it's more of a superficial MCL. You can see that's a drive-through sign is positive. I can see the MCL injury there in this patient. Okay, So that was an ACL tear. I have done little bit of cleaning here, and I also have some radial tear of the lateral meniscus here. Okay, quite friable here.
Inner picture is not seen. Just.
अभी दिख रहा है?
हाँ अब ठीक है.
So this is what I have on the meniscal side. So I'm going to repair this with an horizontal stitches. Quite a big tear it is. So I think posteriorly it is continuous, but this is how the flap, it's a big, we can say sort of a radial tear only. Okay. So what I have taken is, I have taken the peroneus longus in this because he has an MCL injury. I have taken a hamstring tendon with an open stripper attached onto the tibial side. The graft is lying here. Outside picture bhi ja rahi hai na? So I have taken a peroneus longus. I have tripled the peroneus longus. The graft is 9 millimeter. I have tripled it with a fiber wire. So the graft is 9 millimeter. So I am going to drill my tunnels because I still have some. Oh, the spoon is there.
So you will
So I am going to.
you will use peroneus for ACL.
I use peroneus for ACL and the semitendinous is attached on the tibial side
For
for
MCL.
the MCL. So that is my plan. So you can see, can I have the tibial jig? So let me show you the stump. I have looking from the standard anterolateral portal. So that's the stump of the ACL. So for the residents, this is the anterior horn of the lateral meniscus. So that is what is in talk now these days. So this is the level where we drill all our tunnels. So my jig drill bit has to come out somewhere from here. That is center of the stump of the ACL and on the highest point in parallel to the posterior border of the anterior horn of the ACL. So that's the plan for it to come. And if you look at the stump on the femoral side, so this is the ridge here, and that is the entire stump of the ACL. That is the over the top position. So since this is a fresh case, it's very easy to identify. We have to make everything behind and below the intercondylar ridge or the resident ridge. So the ACL lies in the lower 50% of the nose. So we are not talking these days of the clock position. So we have to make the tunnel somewhere here in the center of the stump of the ACL. So I take a jig. So you can see this is a meniscus referencing jig, but the mark is not that great. So I am parallel, and so this is where my drill bit come out in the center.
Joshi sir, can you check the white balancing of your camera please once?
Okay, I'll do it once more. White balance करना, मैं यहाँ से कर रहा हूँ. White balance दबा दो उधर से. Somebody press the white balance. Yeah.
Yeah, now it's
Now
perfect.
it's okay?
Yeah, it's perfect now.
चलिए. So, am I okay with my tibial footprint? You can see the entire tibial footprint and the anterior horn of lateral meniscus, and I am totally parallel to that, okay?
Yeah, looks perfect, sir.
So I will go towards the midline on the tibia. It is basically between the posterior border and the shin, so I don't injure the MCL. I am good. धीरे धीरे जाना है ना, रेजिस्टेंस आ रही है मेरे हाथ पे. So I think everybody agrees that we have to do MCL in this case.
Yes, sir.
थोड़ा उठा के करो. You leave this. You leave the foot. Let it hang. Yeah. ना गो थोड़ा ऊपर उठा के करो, टेढ़ी जा रही है. हाँ चलो, नहीं नहीं तुम मत उठाओ.
Dr. Deepak,
Yeah.
why are you making tibial tunnel first?
Uh, that's everyone asks me. It is just that this is how we are trained. So we never change, but definitely you can make a femoral tunnel first so that we have less of an extravasation. So it's just that this is how I was trained by my boss and I have continued to it. But it doesn't matter. You can make a femoral tunnel first and put a thread there and do the repair and you can come back again for the tibial tunnel. So that is also can be done and it is better to do that way, some people say, because there is less fluid extravasation. Sorry, the pressure is maintained. क्या चीज नहीं है अभी? दिल फंस गई? So I'll just wait.
So even if you made the first tibial tunnel and you want to prevent the extravasation of fluid, so there
Yeah.
is plug comes, cannula
You
plug
can,
comes.
yeah. We have lots of tibial plugs, commercial plugs also come. If you don't have the plug, you can use the cap of your T or sac. Okay.
Yeah.
So that is what we used to do, and that is what I would be doing. Yeah. चलो ठीक. हाँ. So I protect. You can happy with the tibial tunnel?
Yeah, looks perfect, sir. Just one question. Suppose it is little bit posterior or little bit anterior. So
Yeah.
do you change it or you do with a smaller reamer and then?
Yeah. If it is little bit, then it's okay. Then I change it. Do a smaller reamer. So I am here. I use the 9. So use a smaller reamer, 6 millimeter, and you can make it posterior or anterior. Because if you drill it once or twice, I think after that it is very difficult to find a track. So that is the best way to do that. Okay. Now, yes. क्या चीज रह गया? आवाज नहीं है.
Deepak sir, we have lot of our PG students and senior resident also here. They wanted to know the exact placement of bead pin over the femur, about the resident race, and about the anatomical position of ACL footprint on the femur.
Yeah, let me put my scope on the medial portal. Leave it, let it. So you can see how the ACL looks like. Okay, so that's a fresh case. It is very good to see in the fresh case. If the ACL is chronic, sometimes these landmarks are not visible. So this is the ridge. Okay. This is the ridge and ACL, entire ACL is behind and below. You can see the entire stump. That's the posterior or the top position. The ACL starts from here. I'm looking from the medial portal. So this is where there is an anteromedial bundle. It is very near to this ridge. Okay. And the posterolateral bundle comes here, which almost touches the cartilage. Okay. It is below and anterior, the posterolateral bundle. So this is how the entire oblong ACL. Now, what is the exact point, the G point, Dr. Joshi used to say? It is very difficult to find where exactly it is the exact. So we take it in the center of the stump. So if we are not, there is stuff. If there is a chronic ACL, sometimes the ridge is also not visible. Okay? Sometimes this ridge is also not visible. So if I look from the anterior portal, so when I think, Arvind, you also must be knowing, we used to do lots of transcerebral. This is how we used to look. So ridge used to be anterior. So people mistake it for the over the top position and make the tunnel here. So which is anterior. Okay. So ridge is here. So now with an anteromedial way, we look like this. So the ridge is, now this is the ridge and the entire footprint is below and behind. So in nutshell, if this ridge is not visible, intercondylar ridge or the resident ridge is not visible in chronic cases, try to make the tunnel, use an offset and make a tunnel somewhere in the posterior half of the notch and in the lower 50% of the notch. Okay?
Yeah, thank you, sir.
So I need an offset of, so you can use a freehand technique and an offset. Offset is easy. So I do little bit of cleaning just to place my offset, whether my offset is reaching fine or whether I have to make an accessory endomedial portal.
You are using 7 millimeter offset all the time or sometimes switching to others?
6 and 7, depends on the size or the diameter of the graph. So I am trying to look at the posterior most point, the over the top position. So that's the over the top. So here the graph is 9. So I use a 7 millimeter offset.
Yeah.
And you give me that thing. Oh, wire dalo. Spade wire. So 7 millimeter, it is basically we ream it 4.5 in front, 4.5 in behind. So I expect a 2.5 wall. So that's a spade wire. Spade wire is there with Arthrex.
The position of your knee while
Yeah,
putting
it's
this jig and other things.
yeah, while the position of knee is 90 degree, so I go behind and behind and behind. I reach the posterior most part, and when I reach here, I just flex it. I ask my person to flex it more than 90 degree, and और flex ये हटा लो, पिल्लो हटा लो बेटे. नहीं ऐसे नहीं करो, फिर सीधा करो, है ना? थाई को पहले बाहर निकालना है और फिर फ्लेक्स करना है. So EB duct and flex, 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 more flex. So I just do a little bit of hyperflexion around 100 degree. You can see I am in the center of the stump and below the ridge. So when I flex it, the posterior part of the condyle comes in front. थोड़ी बाहर निकाल दो ताकि easy हो इसको drill करना ना. हाँ, very good. बस ऐसे ही रखता. छोड़ना नहीं अब है ना flexion. So the spade wire is good to measure the distance from the far cortex. आगे? नहीं बाहर नहीं निकालना. बाहर निकालो थोड़ा. अंदर करो. अंदर करो. तो बस ठीक. नहीं फोरम की ड्यूटी नहीं है इसमें. ये हो गया फोरम हो गया. So that's the size of my tunnel. Standard, it always come like big, Dr. Ashish. In our patients, is always in this position. Now, I will rather put 7 out of 10 time it comes like this in the male patients. 35. So it's okay. So I am pulling it. So this is for the residents. So my distance from the far cortex is 35. So I'm going to read now. So as per the literature, we should have minimum 15 millimeter graph inside. So I'll read 20. These karo. So 15 is what the literature say. Now the another Japanese literature is saying, they say even the 10 millimeter graph can incorporate. But we go by the standard 15 millimeter. So plus 5 millimeter for, so that I don't have any, I am clear that I am more than 15 millimeter. So if we have a fixed loop or anything, or we have a smaller tunnel, we can still use variable. So around 20 millimeter has gone inside.
Dr. Joshi, please adjust your mic. It is not sounding well.
आवाज नहीं आ रही है देखना.
बहुत धीमे धीमे आ रही है.
किसकी मशीन चल रही है? अभी आ रही है डॉक्टर आशीष?
हाँ कुछ ज्यादा ही आ रही है.
अब ज्यादा आ रही है देखना.
ठीक है,
थोड़ी
ठीक है.
कम, थोड़ी कम करो. So I have I have drilled. ना आगे से हटना. So I have drilled, reamed around 20 to 23 millimeter. I wanted 20 millimeter, so it has gone up by I think 2 millimeter. So my graph, now this is a variable loop. I am using a tight rope RT here.
At 35 millimeter, I can also use a fixed loop. So fixed loop have different way of measuring. In a variable loop, it's very easy. You have to just ream, and the amount the distance you are reaming it is actually the grad going inside. So since I have reamed around 20 to 23 millimeter, my grad will go 22 millimeter inside the tunnel. हाँ, छोड़ दो बेटा इसको, सीधा छोड़ दो, सीधा छोड़.
Your predilection for which fixed loop or variable loop?
No, since other arthritic people are there, but I always, these days, I'm more inclined towards fixed loop.
Towards the fixed loop.
Yeah, the only variable loop I believe is that works, that doesn't loosen, is probably the tightrope, and one more that I won't tell here. So arthritis, so whenever I use a variable loop, I always use an Arthrex device because it has lots of studies which shows that it doesn't loosen. वो wash कैनूला दे दो कुछ दिखाएं कैनूल.
So, Joshi sir, you have did ACL reconstruction with variable loop for many years. Any reason behind shifting from variable loop to fixed loop?
So most of the, I feel that there is, even if there is a 2 millimeter of loosening of the loop, that is good enough for patient to have a post-op laxity. So when we examine, the patient has some post-op laxity. So that is the reason most of the type the loops are not that very good. They do lengthen a little bit. So that is the thing that I have, even if you can see the studies. You can see the tunnel here.
Yes, sir.
Yeah, we can see.
It's 2 millimeter. It's in the center. Okay.
Yeah.
So that's how the tunnel looks like. So we have a cortex and we have a socket.
And how much distance you want from the articular side?
So it's almost near to the articular side. Okay. The PL bundle comes somewhere near the articular side here. So maybe I'll say 2-3 millimeter up. So the idea is to put in the center of the two bundles. So we'll be around 3 millimeter up the articular side. Okay. So the idea is to make the entire tunnel in the lower 50%, and this is the ridge here. So basically the ACL sleeps. It's not doesn't make a perfect triangle. Picho, daga निकल गया. Yes sir. Picho. So that's how the title. So idea is that the ACL basically sleeps in front of PCL and not the perfect triangle. That's how the tightrope button is going inside. Okay, lead करो कुछ. एक मिनट करो, ऊपर करो. हाँ, हाँ. तो टॉकर ले लो, उसको घुमाना है. टॉकर ले लो. ऐसे ले लो सबको. What are you doing? That's it. Don't. So the variable loop, the issue with the variable loop is that.
At times you can pull through the facial lata.
Yeah. चलो घुमाओ. ग्राफ ठीक था. जी सर. टॉकर ले लो. ये लो मैं करता हूँ. न मत करो, ये ऐसे मत करो. ऐसे पकड़ो इसको. ये पकड़ो. तुम करोगे? सर. So we have to have an assistant who is, so we have to rotate. So that's how, if you can look at the outer picture, he is rotating on the hemostat. And put a retractor here. Take a retractor low.
Sir, Ashish sir.
Yeah.
So would you like to see the button flipping in the variable loop
Yes,
device?
we should see through the tunnel inside. Tunnel in tunnel view from the medial portal. You must see it. Dr. Joshi?
I'll show you like that.
Yeah. That's a fancy, good looking.
So you can see it going up. So that's the mark here.
Yeah.
Okay. So the rotational pull, don't pull it horizontally with your force. So we are rotating so that the button doesn't go into the soft tissue. Now leave it.
Yes.
Hold do, chhod do. So I pull it back. It's not coming. So we have a RT device where we can also check the flipping. देखो blue और उसमें देखो flip हो रहा है कि नहीं. So we have a blue and tiger here. So we'll check the flipping also. So that's the interior. So you can see the ACL is in posterior and lying in the.
The mark at the mouth of tunnel is also confirming that.
Yeah, it's confirming that it is in the. Yeah, so he has he had tested also because sometimes the button may flip obliquely. So this is why the Arthrex has come up with this Ultrock device where we have another additional fiber wire to check the flipping. Karo, shorten karo. So now we have the white threads. So this is a variable loop. So it shortens, it takes the graft inside. So it has a Chinese trap mechanism at the edge of the button. So there is only one unidirectional shortening. Yeah. ये पहले एक खींचो. So that's, you can see the graft going inside.
Yes, we can see.
So, चलो. So very slowly, the variable loop can break. Very costly device. So one thread at a time. The graft has to be very. बैंडे ले लेते ना. हाँ, it's gone. मार्क 20 पे था. चलो थोड़ा सा और. ये देखना स्पीड इसकी शेवर की तेज नहीं है. कितने पे है ये? Can you see?
Do you pull it completely or leave some space for the final tightening at the end?
I generally do it completely at here. Right now only. So that's what is not going further, and I can feel the flip again now on the button. So that's how it has gone inside around 20 millimeter. Okay.
Okay.
So if I look from the anterolateral portal, this is how it looks like. Can you see?
Yes, we can see that.
So I have the entire stump you can see in front of me. So I will just debride it a bit so that there is no scope of impingement. Try to do minimal thing so that this will provide some proprioception. If I extend it, you can see how it looks like. It goes away from the notch and everything is in the notch. Okay,
Perfect.
extension. So this is how it's going to be the ACL.
Very good.
नहीं अभी मैंने इसको रिपेयर करना है.
Meniscus repair.
हाँ. So I am putting the scope in the.
Okay.
To the bow.
Dr. Joshi.
Yeah.
So felicitation and other things are to be done. So
Okay.
your video is on, but
Yeah,
we
what
stop
I am
here
going to
talking.
do is I am going to do a meniscus repair here, the same fiber stitch that Dr. Amravati used, and I am going to do an MCL, make an MCL tunnel. Okay, I will make a basically, since it's a superficial MCL, I am used to use this free end as a graft. I am going to make a tunnel behind the epicondyle of the femur. Okay, and then I am going to put a screw there. So and the double loop will come back. Since there is no opening in the extension, so I am not going to make a POL. I am just going to make a superficial MCL. I am going to stitch it, bring it back, and I am going to stitch it. So this is what I am going to do.
Fine.
So how will you take care on the tibial side, the direction of MCL, while you are using the insertion?
On the tibial side, basically, I am not, either you can make a tunnel. The anatomical way is that you make a tunnel behind, okay? So I am not going to make any tunnel, but when I am doing the POL and I make a tunnel, the direction of the, either I'll use a swivel lock ankle to fix it, the graft, or
Okay.
so that I don't meet the two tunnels, okay?
Okay, so you
So
will
now
use the
if I
insertion of semi-T
semitendinosus,
and
yeah,
change the direction by using a swivel lock.
develop, yeah,
Okay, okay, thank you.
yeah. Develop.
So, thank you, chairpersons. It's the time we felicitate our speakers, chairpersons, everyone from the beginning. We didn't have any. So, may I invite first Dr. John sir to felicitate uh, Dr. Prabhat Prakash sir. Is he? Haan, sir, please. Sir, Dr. Rakesh Chaudhary sir. Dr. Sudeep and Dr. Bhushan sir. Dr. Bhushan sir. Thank you, John sir. May I next call upon Dr. V.K. Sinha sir to facilitate our next chairperson speaker sir. Dr. Ravi Yadav sir. Dr. Manish Kumar sir. Dr. V.K. Pandey sir. Dr. V.K. Pandey sir. Thank you, Sinha sir. May I next call upon Dr. S.P. Gupta sir. Please felicitate Dr. Asutosh Agarwal sir, please. Dr. Ravi. Dr. Ravi is here. Dr. Rajiv Raman sir. Dr. Ashish Kumar. Sir, please. Thank you, sir. Thank you. May I next call upon Dr. Pawan? Dr. Rajiv Bhatt? Dr. Rajiv Ranjan? Dr. Bharat Bhore? Thank you, sir. Dr. N.K. Singh, sir? Sir, please come. Dr. Avinash? Dr. Gurdev? Is Dr. Rajiv Raman around? Big clap, everyone, please. Dr. Rajiv Rao. So, will Dr. Manish Ranjan is here. So the surgery is going on, and in the meantime, we will break for lunch now, and we'll gather again after half an hour. Thank you. We'll be starting in next 5 minutes. There are some speakers who have not uploaded their presentations for the next session yet. Requesting everyone to do that, please, whoever is the next speaker. So another next 5 minutes, we are starting with the next PCL session. Dr. Gurdev Kumar. Dr. Gurdev Kumar. Dr. Vidyasagar, are you ready with you?
Enjoyed your lunch. So PCL injury is, this is PCL session, so I'm going to talk about the PCL case, about the PCL injury. PCL is not much common, isolated PCL injury is not much common. It is basically 1/20th of the ACL injuries. Okay, yeah, I can see it. Usually PCL is associated with MCL injury or ACL injuries. So coming to the case, here is a gentleman of 49-year-old male presented from Northeast having a BMI of 17.4. He met an injury in last May. Actually, he was working in sawmill and hit by a wooden log. When he came to us with the pain and the difficulty in working for 26 days. Meanwhile, from the accident of the, he consulted locally, their X-ray was done, but X-ray shows no bony injuries. Then again, he consulted another doctor, their MRI was done, and he was advised for, on the basis of MRI, he was advised for some surgical procedure. So he came to us. So on local examination, there was swelling, there was wasting of the thigh, there was posterior sagging of tibia, that is Godfrey sign was positive, and there was tenderness over the medial joint line. Posterior drawer test was positive, it was 2+, and the valgus test was positive. Range of motion at that time was 0 to 90 degree of flexion. So, sir is here. Bhushan sir, what is your take on range of motion? Do you think, in all of your cases you want full of range of motion in before going to PCL reconstruction? At least 90. So we waited for 2 weeks. We have our physiotherapist there. So when the patient got full range of motion, then we planned for the operation. At that time, the Tegner lysom score was 47. So it was initial X-ray, and this was the X-ray after 25 days when the patient presented to us. And this was nil stress X-ray view. Sir, in all of cases, Bhushan sir, in all of cases you used to do nil stress X-ray view. Is it necessary? Okay, we have done that. And here is the MRI. You can see here the PCL injury and ACL is found to be intact. So after consent, the patient was taken to OT, epidural anesthesia was given, and you can see the posterior drawer test was positive. So arthroscopic inspection of the knee joint was done, and PCL was found to be torn. Then graft harvesting was done. So another question, sir, regarding that, the graft harvesting, what is your take on graft, sir? Do you take always semi-tendinous, or you can also prefer peroneous grafts? Sir, in our case, we have taken peroneus graft and semi-T also, and graft thickness was 10 mm and length was around 14 mm. So then debridement of PCL and this was done. Then tibial tunnel preparation was done. We kept our PCL jig at 15 centimeter from the joint line, so that we have sufficient amount of bone there. Then femoral tunnel preparation was done. That was, you can see here the guide wire passing through the PCL remnants, and then passing of the graft and fixation was done. Uh, Sir, another question regarding this, sir. What is your take on killer turn? How do you prevent the graft passing through the killer turn? Ashish sir, would you like to comment like killer turn, how to prevent this graft passage, graft passing through killer turn, how to prevent it?
You can pass from above to downwards. That's the easiest way of avoiding killer turn. If you are passing from down up, then you cannot avoid, but you can manage by putting a Bissinger rod or something like that from the posterior medial side and directing your pull of thread accordingly, posteriorly. So that you can do. These are the two ways of doing that I know.
Okay, sir. So, sir, we have taken SS wire and to and from motion of SS wire was sometimes smoothen this. So, after graft passing and fixation was done, so here is the final video of the fixation. So, regarding post-op rehabilitation, we applied knee brace with bump below the calf muscle, and here's the post-op X-ray. During inter-op, when the fixation was done, we found there was some laxity, so we have used this screws. Here is the post-op. Here is the post-op X-ray and 8-month follow-up. The patient was walking comfortably. So, coming to operative management of PCL injuries, here few literatures we have taken. This literature was published by Water and all last two years back. Actually, this was meta-analysis, and there was 6,000 of arthroscopic knee was included in this particular study, and he found both the treatment conservative versus operative, both yielded satisfying functional outcome, but the osteoarthritis has occurred less frequently following PCL reconstruction. Another study was done by Zemi et al., that is isolated posterior crystal ligament injury, and he concluded that majority of isolated PCL injuries can be treated non-operatively with rehabilitation. So the take-home message is, if there is grade 1 and grade 2 injury, less than 10 mm of injury, less than 10 mm of laxity, then we can go for conservative treatment. And if it is grade 3, more than 10 mm of posterior laxity, may go for conservative, but instability, then we should reconstruct. Thank you, sir.
Any questions?
So, with this conclusion, do we feel that it is okay? For me, PCL is very, very disabling. It is not like that it can be treated conservatively because cordyceps is taking care of your PCL. That we think. But somebody who is having a real posterior sag or anything that posterior laxity is there, I don't believe that PCL, of course it needs more strong reconstruction and more slow rehabilitation, that's okay. But just saying that even grade 3 can be treated isolated with only your conservative means, I'm not believer of that. What about others?
Okay, if there is instability, high level of instability, then go for surgery.
What
Okay,
is
sir.
high level of instability? Some patient is having a lot of trouble once he is having a PCL injury. Maybe it is isolated, but if it is a significant PCL injury, there is a reasonable trouble they walk with. They can better live with the ACL. It is just when they are having that pivoting or once they have uneven surface and then they have problem. But with PCL, it's every step is difficult for them. If there is this grade 3 is a big thing. And what about grade 1, grade 2? Even if you reconstruct, you may at the end you can land up with grade 1 and grade 2. So that is why for grade 1 and grade 2, one should not go for it. But if it is grade 3, then definitely one has to do. There's no need to go for any paper or something like that, or anybody who has said that you can do conservative. It's not like that.
Agreed, sir.
Yeah, fully agree, sir. Great, you need to reconstruct.
Dr. Vidyasagar, what was your rehabilitation protocol?
Sir, it was your patient was kept in range of ROM brace, and there was bump in the below the calf muscle, and quadriceps exercise was initiated after next day. And
One more thing, there had been associated other ligament injury like ACL. What graft you would have preferred for the PCL?
Sir, I used to take peroneus graft and semitendinous.
Peroneus as such one you will say, or something else which peroneus?
Peroneus longus and semitendinous, yes. Yes, sir, in prone position.
Exactly. Right.
Sir.
Patient will have lateral laxity. So that is very important. You should start range of motion in prone position, not in supine position, as we routinely do in our ACL cases, other ligament reconstruction. So PCL, PLC always try to gain the whole range of motion in prone position.
Exactly.
Thank you, sir.
Thank you, Dr. Vidyas. Next speaker is Dr. Gurudev Kumar.
Respected Chairperson, my topic of presentation is arthroscopic PCL avulsion fixation. So the posterior cruciate ligament, it is the main static stabilizer of the knee joint. It prevents the posterior translation of the tibia. It acts as a secondary restraint to the external rotation of the knee joint. Commonly, it is a part of multi-ligament knee injury due to road traffic accident, mostly in our country and in the entire Asia, because the main mode of transportation here is the two-wheeler vehicle. Then the second common mode of injury is the sports activity. The incidence varies between 1 to 44% among all the knee ligament injury. So the diagnosis is most important. Take the proper history from the patient, clinical examination like joint line tenderness, anterior drawer, posterior drawer, varus and valgus stress test at 0 and 30 degree of flexion, and dial test. Here there is the posterior sag sign seen in this picture. It indicates there is the PCL injury. And of course the radiological examination, X-ray, 3D CT and the MRI to see the status, know the status of the ligament, cartilage, OCD, like that. The studies show that if there is partial tear, then there is less than 8 millimeter increased posterior tibial translation. Isolated complete PCL tear, there is 8 to 12 millimeter of the posterior tibial translation, and combined posterior cruciate along with PLC injury, there is more than 12 millimeter of the posterior translation of the tibia. This is the classification of the PCL avulsion. The type 1, it is minimally displaced or undisplaced. Type 2 is the minimally displaced, and it is visible in the X-ray also. And that type 3, it's the complete displacement of the tibial spine. There is debate whether to conservative treatment or the operative treatment. So the many studies shows that if there is a tibial spine avulsion, it should be fixed. There is no any role of conservative treatment for the tibial spine avulsion. So this is the X-ray of the 32 years old male following road traffic accident, left knee injury. In the X-ray, we can see there is a classical PCL avulsion from the tibial side. And this is the posterior drawer. The tibia is translating posteriorly, and the varus and valgus stress test, it's okay, it's negative. This is the 3D CT, we can see here there is a big chunk of the posterior tibial spine avulsion. There is minimal comminution or no comminution, and in the MRI it can confirm there is the posterior tibial spine avulsion. The rest of the structural cartilage, ACL, meniscus, everything is normal other than the PCL avulsion. So coming to the treatment of this avulsion, there are various methods of the treatment. Once the diagnosis is confirmed, initially in our beginning part of the career, we are going to fix it with the Lowenhofer approach, posterior reverse L-shaped incision, and fix it with either 1 screw, 2 screw, or maybe 3 screw. We can see here there is a big fragment, and we have operated with a 3 screw, then a screw with the washer, and a small DCP, then manipulated or the molded 1/3 tubular plate, and lastly there is the tightrope fixation of this PCL avulse fragment. So coming to the quick procedure, we can see here how to fix it. So mark all the bony prominence or the mark with the marker pen, lateral fibular head, lateral joint line, medial joint line, patella, tibial tuberosity, and medial, standard medial and lateral portal, and the posteromedial portal. So this is the case of the PCL avulsion. Put the scope through the standard anterolateral portal, and then evacuate the hematoma with the thorough joint lavage. We can see here, this is the slopy ACL, lax ACL. ACL is intact, but it is lax because of the PCL avulsion. Then create the space between ACL and the PCL by removing the fat pad and the synovium. Then introduce the scope through this in the posterior joint. Then create the posteromedial portal with the help of 18 gauge needle. By switching the light inside the theater, we can help to introduce the needle. Then use the 11 number knife. The knife is tied with the thread over the PP handle so that we cannot miss the blade in. Then a straight artery to dilate it, then pass the 8.5 mm cannula with the trocar, then pass the saber through this posteromedial portal and debride all the hematoma, fat pad, bone debris, and create the proper space between the PCL and the posterior joint line so that we can do the better instrumentation. Then quantify and identify the size of the fragment of the avulse piece, whether it is single comminuted, it is a little bit comminuted here, and try to reduce with the help of examination probe. It is nicely reduced here. Then with the help of suture lasso to pass through the enteromedial portal, pass it at the junction of bony fragment and the PCL, and loaded with the PDS suture. Then the suture is loaded with the fiber tape, and you do the clinch suture stitch over that avulse fragment. Then took the another bite through the encircling the PCL and the bony fragment at the junction. Then pass the PCL jig, which is exactly 15 to 20 meter below from the joint line. We can see here between the medial and the lateral side of the gutter. Then pass the bead pin. Then drill over the bead pin with the 4 mm of the cannulated reamer. Then pass the bead pin loaded with the suture thread. Then retrieve it through the enteromedial portal. Then loaded all the thread over this lip and pass it through the anterior aspect of the tibia with the help of this probe. Try to reduce by pulling and the pushing. It is a good to see here. It is perfectly reduced and with the proper tension. Now, the slope P sign is wind off. The ACL looks stable now, and the PCL is stable. This is the immediate intraoperative examination, which can show that the knee is quite stable, and fix it over the anterior aspect of the tibia with the help of suture disc in 90 degree of flexion. And this is the post-operative picture. Immediately from the theater we can check whether the fragment is nicely reduced or not, and this is the post-op X-ray. We can see here this is a perfectly beautiful reduction of the fracture fragment. And this is the post-operative picture. He is a sportsman, and this is after 10 months of this of surgery, and he is happy. He is a big businessman son from Patna. Thank you.
Hello. Any question to Dr. Gurudev? Please.
Arthroscopic PCL reconstruction is always a technique which has to be learned. The fixation can be done, the avulsion, by means of a small incision by Buck-Schaeffer's approach, and that takes around 15 to 20 minutes of time. This of course takes around 1.5 hours time. So how many of us would like to do it by open method, and how many would like to do it by a arthroscopic method?
Suppose a surgeon, orthopedic surgeon is not an orthopedic surgeon, arthroscopic surgeon. He is a general orthopedic surgeon who does without arthroscopy, or he has not got the facility of arthroscope. So, do you recommend by the open method?
Sir, we have already.
One more thing.
Sir, we have already shown here in the various method of fixation. There is one X-ray we can shown here. There is a very large piece of the avulse fragment. After confirming with the MRI examination, we did the fixation with the open method by applying 3 CCA screw.
That's why I'm asking. Even by the open method, the results are quite good. And your topic was basically avulsion PCL. Okay?
Sir, the ultimate result after 2 years is the equivalent. There is no any difference. Right. But there is certain indication whether we have to go for arthroscopic method or for open method. Yes. If the fragment is too much comminuted, then in that situation it is better to go for arthroscopic method.
Exactly, yes. So that is the criteria. Otherwise you can go by the open. If this is not an orthopedic.
Again, if this is a learning curve, there is always chance of the vessel. It's very horrible and terrific surgery. I have faced certain times inside the theater. I think I have already injured the artery, but luck, it doesn't happen till now.
We have done few cases. I have done personally. I have done few cases, 3 to 4 cases. I have done by open method. That's why I'm asking. Anyway,
There
good
are some
presentation.
specific indication for open method. If you are doing a tibial plateau fracture with PCL avulsion, try to do it open, because anyhow you have to open the posterior joint line. If you are planning for tibial plateau fixation with PCL avulsion, if you have a very large fragment, it's very difficult to negotiate that fragment arthroscopically. Sometimes the chunk is very big. If you have a very big fragment which is taking a part of the posterior tibial articular part cartilage also, try to fix it open. And arthroscopic open reconstruction results are equally good. The only good thing with arthroscopic fixation is that you can rehab this patient early, because minimum soft tissue trauma is there.
See, Malab, it's not a fair question to him. Okay, if when the nailing started, people were taking 2-3 hours to nail. It's not that we stopped nailing. We kept on learning and we improvised. So it's not a fair question to say that something can be done in 15 minutes while you're taking 1 hour. There are a lot of things. Buck-Schaeffer approach, there is a huge amount of skin problem. Okay, it's not easy. Those who have done 50, they will understand that the skin necrosis happens, the skin giveaway happens. Arthroscopically, these things will not happen. Okay, so of course it's a learning curve, and if you do it, you should do it this way. There is no doubt in that. Okay.
And the another thing, we can address the other pathology also. So the meniscus injury, OCD lesion, and other intra-articular, at the same time we can address all these things also.
Yeah, and I think I agree with what Rajiv says. It sometimes depends on the size of the fragment, and but I don't see major skin problems with the Birch-Cave approach. Yeah, but no.
Now, may I call upon
Even
the
for
expert?
screws, you don't need to remove them.
Okay.
Thank you, sir.
Yes, Dr. Gurudev, thank you very much for your nice presentation. Now, may I call upon the expert for his lecture on the PCL reconstruction arthroscopically.
Thank you. So very nice talk about Gurudev, and I think PCL, it was a PCL repair technique, avulsion. So I will be talking on PCL reconstruction. So it's a small video technique. So whenever your patient comes with a PCL injury, what we were discussing in the morning as Ashish sir told, if it's a grade 3 PCL injury, if you have posterior translation of the tibia more than 10 millimeter in the lateral view in 90-degree of flexion, don't go for conservative treatment. Why? Most of these patients don't come with instability. They will come with patellofemoral arthritis in due course of time. It is the patellofemoral joint which gets burned out when you don't repair or reconstruct this PCL. So nowadays, if the patient has grade 3 instability, try to repair or reconstruct it. Don't leave it like as we were doing 15-20 years back. The PCL heals very well. It's vascular, it heals very well, but it heals with lengthening, and that causes the laxity of the posterior joint line. So this is a small video technique of arthroscopic PCL reconstruction, and as you know, once you put your scope inside, there is a telltale sign, that is a slopy ACL, or which we call S-shaped ACL or SAG ACL, and this lax ACL sign is a telltale sign of PCL injury, because classically you will not see a empty fossa sign as we see in our ACL reconstruction. You see a empty fossa sign. You see that the whole of the medial part of the lateral femoral condyle, the ligament is not there. But PCL injury, what happens, because it has a very good vascular sleeve, it heals very well. It's the laxity which causes the problem. So slopy ACL sign with positive posterior Doherty's test is a clean-cut indication for arthroscopic PCL reconstruction. So once you have seen this slopy ACL, the next important part is you should make your way for the posterior medial compartment, and this is very important. Sometimes you have to debride part of the PCL to make your way to the posterior medial compartment. Here you can see, once you have debrided it on the medial aspect of the lateral femoral condyle, lateral aspect of medial femoral condyle, you are in the posterior medial compartment, and this is very important step, making of your posterior medial portal, because that is the way through which you will see the posterior compartment and avoid neurovascular injury. The best instrument is your needle. Put your spinal needle in, over that guide your 11 number blade so that you can make a good posterior medial portal. In PCL avulsion, normally we make 2 portal. In PCL reconstruction, single portal is good enough. Once you made your posterior portal, the second important part is pass the switching rod over that. And once you have passed your switching rod, try to pass your cannula. Normally we use 8 millimeter cannula. You can see the plastic cannula is coming in. And once it has been done, you can visualize whole of the posterior part of the tibia. Now start saving the posterior aspect of the tibia, the PCL footprint, and this is very important. Don't use your save suction system, and try to keep your blade toward the tibial plateau, because posteriorly you have neurovascular bundle, and try to save down till you see the red bundle of fibers of the popliteus. That is the end point of your saving. You can see your shaver blade should be towards the tibial side. Once you have saved it, the next important part is putting your PCL jig. So how much down? And there is a question and debate for that. Normally you should go 15 to 20 millimeter below the joint line. This is the standard practice because PCL is not attached over the posterior border of the tibia. It has an attachment at least 15 to 20 centimeter below the joint line. And if you go down 15 to 20 millimeter, sorry, not centimeter, so it will give a good posterior support to the tibia. So try to be at least 15 to 20 millimeter down the posterior tibial joint line. So here you can see when you put your PCL jig, there is a marking there of the PCL jig, 5, 10, 15. So try to keep the 15 millimeter mark over the posterior tibial joint line, and you can see here, this is the PCL jig, and just when I will rotate, you will see the 15 millimeter mark is there over the joint line, and now my tibial tunnel will be 15 millimeter below the joint line. Once you have put your PCL jig there, fire your breath pin with direct visualization, and at this time I am visualizing to the posteromedial portal. In this creation of the TBL tunnel, always do it under direct visualization, because you are very close, 15 to 20 millimeter close to the neurovascular bundle. Once you have fired your breath pin over that, put your reamer on. Suppose your graft is 9, try to put your 9 millimeter reamer. You can go for sequential reaming or reaming also. Here you can see through the posteromedial portal, I am viewing it. I have fired my breath pin 15 millimeter below the joint line. Over that, I am making my TBL tunnel. It's around 9 millimeter TBL tunnel. So once you have made the TBL tunnel, you can see once you are close to the posterior cortex, gradually your breath pin will go inside. So be slow there. Sometimes ask your assistant to ream with the hand only at the posterior cortex. And once you make your posterior tibial tunnel, try to pass your suture lasso in the posterior part. Here you can see, now we have passed the suture lasso from the tibia in the posterior parts of the tunnel. You can see here. So over the breath pin, you have passed the suture to the tibial tunnel. Now take the suture either with a suture manipulator or a probe and park it in the posteromedial portal. Now you can see with the grasper, you hold this one and park in the posteromedial portal. And now your posterior tibial tunnel preparation is complete. Once you have completed your tibial tunnel preparation, you have passed the suture loop, now you make your femoral tunnel. And this is also very important to be anatomical. Try to be 8 to 9 millimeter away from the subchondral bone, and it's towards the roof. So if you draw a vertical line through the central part of the trochlear notch, and it's between 11 to 1 o'clock position. This is the position for the PCL. So for ACL, you are posterior and down, and for the PCL, you are anterior and up. And this is important. So, and you should be at least 8 to 9 millimeter away from the subchondral. Here you can see the marking is there 5, 6, 7, 8. So I am 8 millimeter away from the articular cartilage. So now put your femoral jig and try to fire a breath pin from outside in technique. Here you can see I am firing my breath pin by the outside in technique, and that will come to the center of your femoral jig. So once you have fired your breath pin, now you make your tunnel again by outside in technique. You can see, and try to protect it with the curate so that you are not damaging your ACL or the subchondral bone. And this is the most important part of making of your femoral tunnel. So you have made your tibial tunnel, now you have made your femoral tunnel, and you can see when you are close to the medial cortex, be very gentle, and now this suture lasso which is there through the tibial tunnel, try to pass it to the femoral tunnel. So you can see the suture lasso is crossing the tibial tunnel, now it's coming towards the femoral tunnel, and take it through the femoral tunnel, and over the suture lasso you will pass your graft. So one question someone asked at that time, how to prevent the killer tunnel? This is, sorry. So how to prevent this killer tunnel? The best way is that if you want to pass the graft through the tibia then femur, pass your switching rod. You can see this is the switching rod, and try to pass the suture lasso so that your graft will go posteriorly and that will go up. So you can avoid the extra force which you have to put when you are pulling it directly. And now gradually try to pull the graft towards the femoral tunnel. Before your graft enters the femoral tunnel, pass your breath pin or guide wire in, and try to put it anteriorly and superiorly so that you can hold it with an artery forceps in that position. And this time you should be patient enough, because what happens, your graft is coming from the posterior aspect of the tibia, it's going up, so it takes some time to pull the graft toward the femoral tunnel. Normally we put 15 to 20 millimeter of the 20 to 25 millimeter of the graft inside the femoral tunnel. Your tibial tunnel is around 40 to 45 millimeter, and try to hold the guide wire with the mosquito forceps over the anterior and the superior part, and gradually as you pass it, you can see your graft is going inside the femoral tunnel. So it's coming from the tibial tunnel and going toward the femoral tunnel, and gradually you can see the mark is there. You can mark it at the 20 millimeter and your graft is inside. At this time, now first in PCL normally we go for a femoral fixation first. So you can see the guide wire is there. Over that, through outside in technique, I will put my screw, aperture fixation. For femur, the standard rule is 8 millimeter graft, 8 screw, 9 millimeter graft, 9 screw. Sometimes you have to use an under screw also, because the femoral bone is cortical thickness, or cortex is more dense than your tibial cortex. So in tibia normally we go one size up or two size up. For femur it's the same size or the under size. And the most important part is that when you were going for fixation of this, try to palpate the tip of the screw through the your probe, because that is very important. It should be a bicortical fixation. It should be the inner part of the thread you should be visualized. And now you can see your femoral fixation is done, and once you pull your graft anteriorly, you can see when you are pulling your graft anteriorly, the laxity in the ACL is going away, and that proves that yes, your fixation is, your tensioning in the PCL is good. Now try to fix your graft in the tibial tunnel, in the tibial side, to the aperture fixation in 90 degree of flexion. Your assistant giving an anterior draw, because your tibia is subluxed posteriorly, so try to give the anterior. And this is very important, visualization of the graft through the posterior medial portal. You can see your graft should go at least 15 to 20 millimeter down the posterior tibial joint line, and that gives your posterior support. That is very important. So if it is 5 or 10 millimeter, your posterior support will be 5 or 10 millimeter only. So try to be at least 2 centimeter below the joint line, so that you have good posterior tibial support. And once you have seen it, visualize the graft from the posterior medial portal, and you switch over the scope to the anterolateral portal, you will see that laxity in the ACL has gone, and this is very important. Regarding rehab, two things is important. First, try to rehab this patient in prone position. Second important point is that try to keep them non-weight bearing for 6 weeks. And the third important point is that always try to use the posterior tibial support brace. Normally PTS brace is very costly, so what we do, we use indigenous extension knee brace. We try to put a small spongy cotton over the calf, and you tighten the femoral belt and the central tibial knee strap, but keep the tibial or strap loose, so that your pressure is not coming over the anterior aspect of the tibia, and that the whole of the tibia is not sagging posteriorly. And that is the indigenous method by which a normal extension knee brace can be used as a posterior tibial support brace. Thank you.
So,
see, if you are passing your graft from tibia to the femur, you are concerned about the killer tunnel. If nowadays lots of people are passing their graft first from the femur, then to the tibia, then you don't have to take concern of the killer tunnel. Anytime. If you are comfortable, you can do it. It's not a big deal. But the problem is that when you are making your femoral tunnel to inside out, you have to drill it through the anteromedial portal. And chances of, if you are not doing it in adequate flexion, chances of denuding of the cartilage from the anterior aspect of the femoral condyle, the lateral femoral condyle, is always there. So always do it under direct visualization.
It's regarding your question, Avinash. I usually do the PCL probe inside out all the time. In that situation, we have to be conscious before proceeding your procedure whether we are going to doing inside out or outside in, because there are two portals on the lateral side. So in that situation, we have to make lateral portal a little bit higher up, and another portal goes through with the help of needle where you are going to hit on that side, the lowermost, that is the inside portal for the PCL.
So one is problem is inside out, the tunnel goes slightly more posteriorly outside.
Yes.
Oblique.
Oblique.
That's the problem with inside.
Suppose, see, now people are shifted the femoral fixation from aperture to loop fixation. So if you are planning for loop fixation, I think inside out technique is good, because you will drill, you will fire your bit pit, over that you fire your 4 mm cannulated drill bit, you measure your tunnel and you can use your desired loop. But if you are planning for aperture fixation, I think outside in is good.
Sir, what is your take on loop button versus screw fixation?
So, see, button, the only thing is that for ACL, button has been standardized. It's a standard, because lateral femoral cortex is thicker. If you see the X-ray of the femur, lateral femoral cortex is thicker. Medial femoral cortex is thin. So you should be at least have 10 to 12 millimeter of medial femoral cortex there. Otherwise, if you are having 6 or 7 millimeter of the medial femoral cortex, like you accept in ACL, there is always chances of breakage of the cortex.
And so there is a lot of patients who come with impingement on the medial side with the button. Is that also an issue?
Yes, and because see, the lateral side you have a iliotibial band, you have the thick iliotibial band, you have vastus. Medial side you don't have, you have just below the vastus medialis, your button is there. So that causes impingement also and pain.
What is your take on both these methods?
So normally I prefer aperture fixation on the femoral side and aperture fixation on the tibial side. But for PCL, I always prefer a supplementary fixation with a post over the tibial side.
Dr. Rajiv,
Nice paper. Till this time we have covered meniscal injury, ACL injury and PCL injury. So in multi-ligament complex, what is your protocol of doing the different ligament injuries?
So normally multi-ligament, I think this session will be there. So PCL, PLC, MCL, ACL. So always try to centralize your knee first. Go for a PCL reconstruction, either it's a PCL repair or a reconstruction, go for PCL. Then plan your collateral, posterolateral, medial collateral, and in most of the cases I leave the ACL like that, because what happens when you rehab this patient, because of the multi-ligament injury, sometimes there is a stiffness and then you don't need ACL, you will not need ACL reconstruction near future. So if you have 4 ligament injury and try to repair 3, you can leave the ACL for second stage.
Okay.
So we'll close this session now because Dr. Arvind will take another 15 to 20 minutes to start the next surgery. So we'll move to the next session, that is knee collateral session. So the moderator for the session is Dr. Avinash, and the chairpersons, please come upon dais, Dr. Rajiv Anand sir, Dr. Madhu Sudan sir, Dr. Ashish and Dr. Ramakant.
Start our knee collateral session, and first case presentation is by Dr. Abhishek Das. He will be talking on MCL tier. Dr. Abhishek.
So just an announcement in between. So if when Dr. Arvind starts the surgery, we might break for the in between the sessions.
Okay.
Good afternoon. Hope everybody had a nice lunch, and my case presentations will not let people snooze over. I cannot guarantee that though. I have got two cases because MCL there is a bit of a debate as to what to do when it is isolated, what to do when it is as a part of multiligamentous complex. So while the audio visuals are working.
Audiovisual guys, please see this.
In the meantime, can we move on to the next presentation, Dr. Abhishek, and we'll sort out the things with this. So,
Okay. Okay, so can I call Dr. Sodip Datta for posterolateral corner injury, PLC?
So thank you, chairpersons, this opportunity. So I will talking on the posterolateral corner of the knee injury. So it was called as a dark side of the knee because the anatomy and the pathophysiology of this side is always a debate, and there are a lot of surgeries, what to do, when to do, or not to do. So I'll give a just brief discussion about the understanding so that we get a clear idea as of now. So the two most common cause of failure in ACL or PCL is, one is malalignment, which will be taken care by the next session. And another is missed posterolateral corner injury. So whenever we go for surgery for a cruciate ACL or PCL, so we must take care of these two. That is, your alignment, knee alignment is maintained. Another, you are not missing any corner injuries. That is your medial collateral or most commonly the posterolateral injuries. So what is posterolateral corner? It consists of mainly three ligaments. One is fibular collateral ligament, another popliteus, and the popliteofibular ligament. So the clinical examination, the two tests you have to do whether you are going for a cruciate reconstruction. One is dial test in the prone position. See if the rotation is more than 15 to 20 degree compared to the normal side, that you are dealing with a collateral, posterolateral corner injury. Another is the Vera stress test that indicates the lateral collateral injury. So the another sign, when you put your scope in, if you see your lateral meniscus very easily, which we call it's a drive through shine, that indicates that there is a posterolateral corner injury there. So there are two type of repair as we do. One is Larson repair, that is if you have a positive Vera stress test and your dial test is negative, then you have to only reconstruct your lateral collateral ligament. That is a small video of this. There is it's always an open surgery. That is, you just put your scope in, you diagnose it and then open it. So you give a incision over the lateral aspect of your knee and you raise the posterior breast flap. The most important structure there is your common peroneal nerve. You always have to identify and protect the nerve throughout your procedure. Then you just go and identify your nerve, and that is your common peroneal nerve. You have to protect and identify this nerve. And now we identify the fibular head. So this is your fibular head. You just make sure you have to make a drill through your fibula from anteromedial to posterolateral, and that is you are confirming the movement of the tibiofibular joint. And now you are going for a drill. And the graft, most commonly you can use your semi-T graft, or you can use peroneus longus graft, or you can use opposite side semitendinous as graft there. First, this Larson repair. So that is your drill going in, and you have to always protect on the posterior side, and then you put your suture lasso through your fibula. But always be very careful, because in a small fibula you are not fractured your fibula. Now you go for the femoral tunnel. You have to identify your lateral femoral epicondyle, and just taking your 4 mm drill bit or a sleeve like, identify that point, and over the drill bit you just make a drill, making a tunnel there. If you have done a ACL reconstruction, you have to be careful that your two tunnels should not diverge. And at that time, if you have any confusion, go and put your scope in, see that it is not hitting your ACL tunnel. Then you pass your suture lasso in. Now that it's very simple, you have to pass your graft from the fibula to the femur under the soft tissue coverage. And now that is passed over into the fibula, and now you draw your graft through the femur. And before passing the graft, you always put your guide wire, because after graft goes in, it's difficult to find the tunnel for your screw. Now your graft goes in. And next step is very simple. You just, in extension, you just tighten your graft and fix it with a standard bias screw or whatever screw implant you are comfortable with. So then you can always check the stability by putting the stress test operatively. The next is if you have a positive dial test and a Vera stress test, then this procedure is not enough. There are different ways of doing it. Laprade has described it. So this is an example of a positive dial test. See, this is a patient having a positive dial test, and also the significant positive rotation and the Vera stress test. He has a failed ACL reconstruction. He has ACL reconstruction done, was failed because of missed collateral injury. So incision is very much same. We have used the quadriceps tendon graft in this case and split it into two parts. First is the posterior base flap is raised as in the previous case, and this is the incision. Then you once again, then you have to, first thing you have to identify your common peroneal nerve. You have to protect this nerve throughout your procedure so that you can not injure this nerve. Sorry. Then you incise above in the level of the femoral condyle, and then identify the epicondyle there. This case I have used only one tunnel. The Laprade has classically described using two tunnels because I have to do ACL reconstruction. So 3 tunnel in a lateral femoral condyle is very difficult to manage. So we are planning for a 1 tunnel in the tibia, 1 tunnel in the fibula, and 1 tunnel in the femur. So this is the fibular tunnel. So we are going from anteromedial to the posterolateral, protecting the nerve there, and keeping a suture lasso in the tunnel of the fibular tunnel. Next, the tibial tunnel. Tibial tunnel is just lateral to the Gardis tubercle from anteromedial to posterolateral, and during drilling you have to always protect in the posterior side to avoid the injury to your vessels. And then you pass a suture lasso in the tunnel. Next thing, you have to identify your lateral epicondyle. So there are different description there. This case I have used only 1 tunnel, that is just posterior and proximal to the lateral epicondyle. I have drilled the femoral tunnel from slightly posterior to anterior to prevent convergence of the tunnel with the ACL tunnel, and passed a suture lasso. This is your graft, goes in. The central quadriceps tendon has been split into 2 parts. Then you have 20 mm, we have marked 20 mm graft that goes into the femoral tunnel and split the graft into 2 parts. Then we fix the femoral tunnel with a screw. And then first we pass the graft to the fibula from anterior to posterior, and then pass both the limbs of the graft from posterior to anterior into the tibia. So now we fix the graft with a screw in a 60 degrees of knee flexion, and that will complete our reconstruction of the lateral collateral popliteus, and then this is the power of stability of the. So this is the closure of the window. And that's, so at this junction I like to invite you all to knee, shoulder, not only knee, the shoulder course in Kolkata in June 3rd. So thank you all.
Nice illustration, Dr. Soumyadeep. So, any questions before we start the live surgery?
Yes, Dr. Datta, I think in both the techniques, the Larson's as well as the modified laparate which you have shown, the tunnel in the fibular head is from anterolateral to posteromedial. But in both the cases, you have shown from anteromedial to posterolateral.
Antero?
Anterolateral to posteromedial. The tunnel should be in the fibular head. But in both the cases, your
टोकार
tunnel has
इसका
been.
बेटा इसका टोकार
But you need to be fibular head, you anterolateral to
Posteromedial.
But you have to go from. I'm like this. I'm going from anterolateral to posteromedial.
Posteromedial, it
Yeah,
should
yeah.
be.
So sorry. I'm sorry. Yeah, yeah.
Okay, yeah.
It should be because you have to see the tunnel. Otherwise, you will injure the nerve.
One question, is there any place for modified Larson technique, put a screw in the fibula head?
Fibula head?
Yes.
So I think in an Indian scenario, putting a fibula head screw, I think it's very difficult until you have get a patient like my stature regularly.
No, I think it is
That
better
the
to
only
put a screw.
limitation. I mean, the head size is small, so.
I don't think, I have never put a screw in the fibula. I think anybody in the hall have any
Yes, yes.
experience?
I think it's better to put a screw because when you don't put up a screw, there's always a play in the tunnel. So if the play in the tunnel is there, that can lead to a disturbance of the graft.
So
You can do some stitches there. If you are.
I think the best thing is kind of avoid
Sir.
is put some soft tissue stitches,
can do
graft
some stitches
over
on
there,
the-
so that will avoid playing in the tunnel. There will be fibrosis there, and the graft playing will be less. The only issue we have with this fibula screw fixation, minimum screw size is 6 millimeter or 7 millimeter. So that is too much for our Indian fibula. Chances of fractures are always there.
No. So femoral tunnel.
I request the chairpersons to be seated here only, and at the same time, the moderators for the last surgery, Dr. Anup and Dr. Sudeep, please join us. And over to Dr. Arvind. Can you listen to me?
Yeah, your voice is very clear. Am I audible there?
Yes, sir.
So this is a case of 36-year male having injury to the right knee, 3 weeks back only.
Can we see the MRI, please, for a second?
Yeah, first I'll demonstrate the clinical, then
Okay.
we'll go to the MRI side. Range of motion at 3 weeks, and if you can appreciate, particularly for the PGs and the senior residents, you can see the TBI is subluxated posteriorly. At the same time, साइड से ले सकते हो, साइड से ले लो. The posterior sag test is positive in this case.
Yes, it's clearly visible, Arvind.
Yeah. And the posterior door test, you can see almost more than a centimeter of translation is there.
Yes.
Anteriorly, it's not coming more than this, but little bit anterior excursion is there. At the same time, valgus test at 30 degree, there is opening. Can you see it? There is opening on the medial side. Is it visible?
Yes, there is some soft
Perfect.
tissue. It's,
But
the
at
glare
0
is
degree,
too much. If the
but at 0 degree, valgus stress is not much positive. Hardly 5 millimeter of opening is there. This is at 0 degree, and this is at 30 degree. Okay?
Yes.
Now we will see the MRI. MRI to focus.
What is Dial's test in this?
Yeah, dial test at 30 degree. Ideally, it should be compared to the opposite side. You can see 30 degree, hardly 20 degree of movement is there.
The foot
External
is not
rotation.
visible. The foot is
And
not.
at 90 degree, you can see this external rotation is quite high. This is at 30 degree, and this is at 90 degree.
Foot
is not
visible. Okay.
The cameraman can zoom out a little bit, so it will be more.
थोड़ा यहाँ कर लो बेटा.
Foot with.
So this is the dial test at 30 degree of knee flexion. You can see the, ideally it should be compared to the opposite side. And this is at the 90 degree. 90 degree, this external rotation get increased.
Cameraman, please zoom out. Zoom out. You have zoomed in. Yeah. The knee and ankle both should be visible. That's better.
This is at 90 degree, this much of external rotation, and this is at 30 degree. At 30 degree, hardly 20 degree of the external rotation is there, but at 90 degree, it is high.
Okay.
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 So next on the MRI, section. So this is the sagittal section. एक artery दे दो कोई. If you appreciate the PCL here, the intensity is increased, at the same time diameter is also increased. So femoral side, it looks torn, but at the same time there is increased intensity on the ACL also.
ACL side also, yes.
Yeah, on the coronal section you can see very thick origin of the MCL is evolved from the femoral epicondyle. Can see?
Yes.
Can you appreciate?
Yes, yes. It's
So it is the MCL avulsion, at the same time PCL complete tear with increased signal intensity in the ACL. So
how old is
our
how old is the injury?
3 weeks.
3 weeks.
So our diagnosis, primary diagnosis is
Age of
PCL
the
tear,
patient?
36.
36 years.
36.
Okay. थोड़ा
So
glare.
our primary diagnosis is complete PCL tear with MCL avulsion.
The
from
cameraman, Arvind, just the glare is too much. If the cameraman can decrease the glare, otherwise the visibility is okay.
थोड़ा लाइट भी कम कर
नहीं
दो.
नहीं
कैमरा इधर
उनके
से लेके
सिस्टम
आओ
में
बेटा.
होता है ग्लेयर कम करने का.
Yeah.
हाँ.
थोड़ा साइड कर दो बेटा, इतना लाइट नहीं है. तुम कैमरा लेके इधर आ जाओ. And some SRs asked me to demonstrate the graft harvesting also. So I am starting with the graft harvesting.
What graft you have chosen?
Yes.
It looks
Plan is to reconstruct the PCL with the semi-T and gracilis.
Okay.
And the MCL will be repaired because it's 3 weeks with very thick avulsion, almost complete from the medial side. I have kept foot free also in case I need peroneus longus, then I can harvest the peroneus longus also.
Okay. And how old is the MRI?
It's 3 week old injury it is.
No,
Injury
MRI.
take-
MRI was taken when?
MRI date is?
That's nearer to the injury or nearer to the surgery?
2 week or
2
1
weeks
week
plus.
hardly.
Okay.
1 week hardly. फाइल में देखो ना MRI का रिपोर्ट डेट क्या है बेटा. So first plan of MCL about the repair. If there will be any dot, I'll reconstruct at the same time with the peroneus longus. So MRI is of 11 March.
Okay.
So this is
Please
the
go
tibial
ahead.
tuberosity, just 1 centimeter below. I am putting the almost oblique incision here, not vertical. Plan is to take both semi-T and gracilis. Since it's the PCL, so I need little bit longer graft. Otherwise, in ACL, in most of the time, I do with quadruple semi-T only.
And the knees in extension, with knees in 20 degrees of flexion, Arvind?
Yeah,
Is
knee
it
is in 30 degree of flexion.
flexion. And straight knee, there no figure of
Yeah, it's a straight.
straight.
ये अंदर
Arvind,
फोकस हो रहा है
can
बेटा.
cameraman come from behind?
इधर से आओगे तो बेहतर दिखेगा.
Yeah.
अंदर देखना है बेटा. इधर से ये लोग आएगा नरेश. यहाँ से दिख पाएगा बेटा. ठीक है. So just after separation of the fat pad, there is thick fascia is there, that is sartorial fascia, and you can see there is a bump starting here.
Yes,
So
okay.
it must be the part of gracilis, and below that there will be semi-T. Now you can appreciate better. This is the plane, and there just down that there is a elevation. So this bump is of gracilis, and below that there will be semi-T. So first I'll cut the sartorial fascia in the line of semi-T and gracilis, and I'll use the scissor. टेबल थोड़ा डाउन कर दो बेटा. बस ठीक है. So this sartorial fascia get cut, and I'll take from below and above. Since I have to take both the graft, gracilis and semity both. So this sartorial fascia gets separated. Now you can appreciate this is the first elevation, and below that there is second elevation. So you can see it.
Yes.
This is the gracilis part,
Camera.
and below that the semity part. If I would have been taken only semity, then this is the only semity part. लगा के रखो बेटा. And above that, this is the gracilis part. Okay?
Okay.
So I am just demonstrating the semity harvesting first. So till this much it is tendon only, and beyond that, most of the time it's the periosteum that almost 1 to 2 centimeter give you the extra length. So you just strip the tendon with all periosteum. You can see this much of length I gained by stripping the tendon from the bone. So this much of the length I can gain this much of the length. You can see the stripped part of the periosteum here. So this help in biological healing also. Experts say because of the periosteum part, this remain on the bony side. And this is the veniculi usually associated with the semity, that is 2 or 3. Just I am cutting that. And after that, just pass the finger to look there is no any further veniculi is there.
So have you
And
flexed
once
the
all
knee?
the veniculi is released, if you left your graft, this will remain as such it is here.
Have you
This
flexed
means
the knee?
you have removed all the veniculi. Grasp पर. नरेश तुम इधर आ
Arvind,
जाओ
have you
बेटा.
flexed the knee?
Yeah, knee is flexed, almost 90 degree. This is just for checking the graft veniculi. At the time of harvesting, I'll make it 30 degree. So this is here. At 90 degree only, I'll pass my tendon harvester in. Then I bring it to the 90 degree, 30 degree. Then slowly, I just pass the tendon harvester. So this much of the length I have. So just I am checking whether it's 30. If it is 30, then I make it triple. And maybe if graft is more than 9 or 10, then I can go. This is, idhar focus karo beta. This is almost 32 here. But still I'll say prepare beta. But this is still 32, so maybe I need 10. So it will be triple only. So I'll take this gracilis also. इधर फोकस कर लो बेटा. हाँ, ये गरम है, देखो ग्राफ खराब, ये गरम है अभी भी तुम्हारा. उसको वेट करो. And this is the gracilis part. Again, along with the periosteum, complete periosteum. उधर छोड़ दो बेटा. ये ले लो. Again the same, the palpation of the tendon till deep so that there is no any veniculi. It is not there. Again at 30 to 40 degree of the knee flexion, I'll pass the tendon harvester. So this is this much of length of this, the gracilis also here. चलो बना लो. टेबल अप कर लो बेटा.
तो ये टॉल क्लिप
So I do my all arthroscopy most of the time, leg hanging the side of the table. For PCL, usually I do high anterolateral portal. So this is the patella marking below. This is the patella, this is tibial tuberosity.
Can the light focus on,
This
yes,
is the
and
patella tendon, okay?
zoom
So
in,
my
please?
portal will be somewhere high, just as possible at the highest junction of patella tendon with the patella. Yeah, this is going without touching to anything. And this is the trocar, this will be in. So at 90 degree, this is in. Then I flex to the 30 degree, then I'll go in the suprapatellar fold. अब वहाँ का चाहिए होगा बेटा कनेक्शन वहाँ पे जा रहा है परफेक्ट पानी ऑन कर दो परफेक्ट ठीक so this is the suprapatellar area under surface of patella cochlear part कैमरा क्लीन नहीं किया बेटा ये पकड़ो गॉज पीस दोनों को Yeah. So this is the medial compartment. Needle देना. So this again the anteromedial portal will be also high. Like that. Maybe दोनों की जरूरत पड़ सकती है. So retropatellar fat little bit has to be saved off. Now this is the picture. So that increased signal intensity in the ACL because the ACL is partial rupture here. You can see.
Yeah, okay.
ACL is partially rupture. At the same time, the PCL from the almost it's
It looks lax. Madam.
yeah,
You
it's
you can probe
lot
it
of
and
this fiber
probe
has
it and
been
show
lost.
it to us. How is it?
Yeah, you can see the partial PCL tear also, ACL tear. So I'll just augment, I'll keep this ACL as it is, and maybe I just augment with that graceless part here. So on the medial side, you can appreciate the opening on the medial side. I can see the medial meniscus posterior horn without any pike rusting. So this much of opening is here. This is at 30 degree, and again this is at 0 degree.
Yeah,
So at 30 degree, it's get open more. So I'll just do the repair of MCL part, and I'll do this PCL, complete PCL reconstruction with partial ACL reconstruction also. And this is the lateral compartment, meniscus looks fine, and this lateral compartment having little bit of the chondral lesion. So here I start debridement of the PCL. अब इसका एक बार डायमीटर चेक कर लो बेटा कितना हो रहा है, पेरिनियस लॉन्गस लेना है कि नहीं लेना है. So just in between the ACL and PCL, I'm just debriding the PCL remaining fiber because in PCL remnant, you can do that also as ACL remnant, but the passing of graft and other thing is very sometimes tricky. So just for the demonstration part, I am taking all the remaining PCL from here. Has to be very careful about the damaging the ACL. So your saber blade always should be opposite to the ACL all the time. $70 scope और स्मिथ नेफी वाला टोकार कैनुला रेडी कर लेना बेटा. So I most of the time do this PCL reconstruction at tibial side with the help of 70-degree scope. Most of the time. I'll demonstrate that here also. So this is the part of the PCL, remaining PCL. And you can see the tibial attachment of this PCL part.
ACL also looks quite thin actually.
Yeah, it's a partial. You can see the part of attached on the femoral side that you have seen on the MRI also. That the increased signal
It seems that
intensity, particularly on the femoral side.
broken part has gone up and attached to the notch band. It
Yeah,
just
so we have
looking
in our mind that this may be a part of partial ACL tear. So here you can see the posterior horn of medial meniscus, and below that you can see the Sarpe fiber. I'll demonstrate that also. So Laprade say just follow that and go just medial lateral to that, around 10 to 14 millimeter down. Right? So diameter is 8 of the PCL. So I'll ask from the house, is everybody is okay with PCL diameter 8? Or should I increase? Because graceless I'll use for the partial ACL augmentation.
I think minimum 9 we should accept, 9, not less than 9 for PCL.
Okay, perfect. That is my view also. Let others say, Bhutan boss.
so Bhushan says, yeah, 9, I think. Not less than 9.
I think
So
you need
maybe
one more graft, Arvind.
Yeah, peroneus longus.
Yeah, take a peroneus longus or
Yeah, perfect. That's
contralateral
perfect.
semity, whatever you are comfortable.
Yeah.
Or you can even take the quads if you want. You have exposed the knee anyway.
So my foot is already ready, so I'll take the peroneus longus. Just I'll demonstrate in couple of minutes that harvesting of peroneus longus also. Then I'll back to the, so that meanwhile my assistant will prepare this, pakdo beta isko, prepare the graph. So, ruk jao beta abhi.
And what will be your sequence, Arvind?
So first tunnel for the PCL and tunnel for the ACL, then the graph, PCL on the femur and the ACL on the femur, then followed by tibial PCL fixation in 90 degrees with the anterior door, complete anterior shifting of the tibia, and then ACL and the MCL in the last.
Okay.
एक टॉबल दे दे बेटा, यहाँ फोकस कर लो कैमरा. थोड़ा टेबल डाउन कर दे बेटा. टेबल डाउन. बस ठीक है बेटा, ठीक. थोड़ा ऊपर करो, डाउन हो गया. थोड़ा ऊपर. So this is marker दे दो बेटा.
Sorry.
So this is the fibula.
You already have gracilis as
And
well.
this is the peroneus longus. This is peroneus brevis. You can appreciate the bulge just below the fibula.
Arvind, are you taking the whole full thickness peroneus longus or partial only?
Yeah, it's full thickness, sir. Okay. What do you advise?
No, it's fine. So I think full thickness is a good idea. So you're going to use peroneus longus to beef up your PCL.
Yeah, peroneus longus or maybe sartorius, both.
And gracilis is going to be for your ACL.
Semity for now I have changed the plan.
Okay.
The peroneus, since I am taking so peroneus and sartorius, gracilis for the PCL.
Okay.
And the quadruple semi-T for ACL.
Excellent. That's exactly what I was going to suggest. Well done.
So just from the tip, 1 centimeter just above the tip, a centimeter incision. लाइट थोड़ा यहाँ दे दो बेटा, हमको लाइट नहीं दिख रहा, थोड़ा सा दे दो, ग्लेयरिंग उतना नहीं बन. Now you can see the sheath of this peroneus. So I'm just cutting the sheath of peroneus. So this sheath you can appreciate. Can see this sheath? Is it there? It is visible there.
He has to come from behind. He's coming from the side actually. The
बेटा तुम
vision
लोग
is
ग्राफ
coming
उधर
from
कर
the
लो ना,
foot
तभी
end.
तो बार बार बोल
It
रहा हूँ
has to
कैमरा
come
वाले. तुम
from
इधर आओ बेटा,
behind your
यहाँ आ
right
जाओ,
shoulder or
from
left
this side.
shoulder.
हाँ चलो और उधर चलो, और उधर जाओ थोड़ा, तुम अपना यहाँ रखो, बार बार बोल रहा हूँ, अब वहाँ बना ले. So this is the sheath possible.
Yes, now it's visible. Yes.
Yeah, this is the skin, this is the fascia, deep fascia, and this is the sheath that I was talking about. And the sheath is divided 90° R2. You can see the tendon just below the sheath here, signing
Yes.
structure.
Yes.
Okay. So the superficial is the peroneus longus. And you can see the deeper one also, that is the peroneus brevis, this deeper structure. Can see it?
Yes.
This is the deeper one, that is peroneus brevis. You can appreciate it?
Yes, we can. Yeah,
Okay.
very clearly see.
So just confirm you have taken peroneus longus only, needle do beta, needle holder. Perfect. ये कैसा है, खुल नहीं रहेगा. सेमिटी को तब तक क्वाड्रपल कर लो. नरेश. Two, three web stitch here. Nice.
So Arvind, you don't stitch the distal end of the cut tendon back to the peroneus brevis?
Usually I used to do that, but once I met with Dr. Bancha, he said there is no need to stitch that part with the peroneus brevis. So this is the length that I got with this. So triple peroneus longus and triple gracilis will be for PCL, and the quadruple semity will be for ACL.
So for PCL, what's the average length that you eye for that?
Usually I ask for 10 to 11 most of the time.
10 to 11. Okay.
इसका margin थोड़ा पतला कर देना बेटा, नहीं तो diameter. अच्छा ठीक है. So again back to the joint. How much time left for my surgery?
That depends how fast you carry it out. We are all
Thank
enjoying
you for
Arvind.
that liberty.
We are all enjoying your work. Don't worry,
We
carry
are all
on.
enjoying, yes.
नीचे लगाओ, नीचे टेबल के उसके थाई के नीचे लगाओ. So I'll make just for the demonstration. this posteromedial portal also. बेटा एक वो दे देना हमको, IV cannula दे देना. IV cannula. टूनिकेट प्रॉपर है ना बेटा, जस्ट चेक कर लेना एक बार, है ना.
पंप वाला सिस्टम लेके आना.
नहीं पंप नहीं चाहिए, नहीं 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 पंप नहीं. जस्ट गणेश को बोले एक बार टूनिकेट चेक कर लेगा, दैट्स इट एंड नथिंग एल्स. So again this is the PCL बनवा लो राजीव को, नहीं तो इन्वर्सन नहीं समझ में आएगा. सक्शन देख लो, सक्शन नहीं काम कर रहा. ओके. Since it's 3 weeks only, so maybe this increased vascularity is because of that only. Now again in the, I am in the posteromedial corner. Yeah. ज्योति, मोटा कपड़ा लो थाई के नीचे रखने के लिए. So this is in the posteromedial gutter. थोड़ा ऊपर करो, और ऊपर करो, कितना कर सकते हो. So this is the compromise when you do surgery in leg hanging position in the side of the body. For posteromedial side, you have little bit of difficulty, so you just put a thick sheet below the thigh, quite above, at the level of tourniquet. So then you will have enough space for the working. So you can make low posteromedial, high posteromedial portal. So just I am making little bit high so that my saver will come in a better angle. So this is the needle that I have passed. Give me the knife, please. Knife. नहीं निकालो नहीं बेटा, बोलूंगा तो निकलेगा नहीं, उसी के डायरेक्शन में जाना है ना. So this is at the same level where our needle is. Perfect. $70 scope अब चाहिए होगा, तो कार cannula ready रखो. So this is the 30-degree scope that I am seeing right now, and this is the PCL stump, remaining PCL stump. trocar cannula ready है Smith nephew का. So this scope is of arthrex. So we have 30-degree scope only of arthrex. We have 70-degree scope of this Smith nephew. For that you have to change that trocar cannula also. कहाँ है trocar cannula? आ गया है arthrex का. Perfect. चलो लगा लो फटाक. एक बार ग्राफ तब तक दिखा दो इधर. ग्राफ पे फोकस कर दो इधर. ज्योति इसको लगाओ, कनेक्ट करो इसको. वो चाहिए होगा क्या इसमें? ये निकालना होगा ना. ये इसके साथ कहाँ लग रहा है? कहाँ है आर्थिक को लगाना?
So what are your final dimensions of the graft?
ग्राफ दिखा.
This was
ACL बस. So length is 8, tibial side is 9 and femoral side is 8.
Okay.
Okay. So Rajiv is saying its tibial side is 10 and femoral side is 9.
Okay. And diameter is 9.
Diameter is 10 on the tibial side, 9 on the femoral
Okay,
side.
sorry.
So we have
length.
almost complete ACL reconstruction.
Length?
Length is 8.
8. Okay.
So I have shifted from 30-degree to 70-degree. सक्शन देख लो बेटा, सक्शन नहीं काम कर रहा. सक्शन देखिए. पानी खत्म हो रहा है क्या बेटा? दूसरे में कनेक्ट कर दे और एक और बोतल लगा के रख लो बेटा. एयरवे डाल दे उसमें. पंप नहीं चाहिए बेटा, मैंने मना किया था. निकालो पंप उसमें से. पंप अपने मन से कभी मत यूज करो बेटा. So this is the posterior horn of medial meniscus and this is the PCL stump. Now you can see with the help of 70-degree.
Yes, it's visible.
Yeah, it's complete down. You can see the complete footprint here. PCL jig ready रखना बेटा. गॉज पीस एक फ्रेश गॉज पीस दे देना थोड़ा कॉर्निंग में.
So roughly how much you have gone
You
below
put
the
10 to 14 millimeter down the articular surface. पानी बंद रखो. बंद है. हाँ ठीक. खोल दी. यहाँ हाथ रखो.
Dr. Arvind, have you looked for popliteus?
Yes, I'll see also that at the same time. Yeah. आज इतना खराब से बता रहा है. सेक्शन काम कर रहा है ना.
may improve the scope vision. I mean, it's not very clear.
ये पकड़ो बेटा.
Is cleaning.
No, एक बार white.
That is foggy. Fog.
So again, this is the posterior horn of medial meniscus. And this is the PCL part, okay. There is blurring is there, but if you can appreciate, this is the main footprint of the PCL over the tibial attachment.
Okay.
You can appreciate this?
Yes, it's.
Yeah, perfect. So I am almost done from here to here, okay? In the posterior part, capsule is there.
How important it is to shave it completely? Is it really important to shave it completely? Because you
better
need really to go down, and it's a big chunk. If you don't, probably will it hinder?
Slightly different from what Arvind is showing. I go over the top of the PCL. So I dissect the interval between the PCL and the capsule. And then you put your PCL graft on top of the original PCL. That
So you use a posterolateral portal as well
No,
to
just
visualize? No,
posterolateral
you just go over the top.
So just dissect the capsule from the PCL remnant. It's never adherent. So there's a nice plane of fat there. So you can easily go there. And you don't need to dissect the PCL.
So you don't have to do anything then. You just go over
just
the
go
top.
over the PCL.
Over the top. Okay.
It just makes it very easy.
You don't need to shave it completely.
So,
So this is the tibial footprint, you can see.
Remnant preserving.
You can appreciate the capsule part.
Yeah.
Yes, now.
Separated the capsule from tibia completely. It is almost 15 millimeter down the articular surface.
Yeah.
Tibial jig de do beta.
For some reason, I could never get my head
Sure.
around 70-degree scope.
Right.
I'm more than happy with
Tibial
30-degree
jig
scope
को
for
बेटा.
everything. So
क्या है लगाया?
I appreciate
tibial
people who
jig
use
को बेटा.
70-degree scope like Arvind.
वो वाला होटल
It's
बंद
like
करो.
walking in front while looking at the left or right side. So can't do that.
And making a lateral, posterolateral.
So
Have you done that?
So
Tibia
I do-
PCL.
So I do posterolateral portal when I'm doing popliteus reconstructions.
Tibia PCL.
But
यहाँ सब
I
कटवा
think
के रख ले बेटा.
if you have a good anterolateral portal,
60 degree
which is
रखो.
slightly higher, an anteromedial portal, and one good piece posteromedial high portal, there's no need for a lateral portal.
Posteromedial portal also need to be slightly higher.
And you can do two posteromedial portals
You
if you are
can actually
worried.
do two.
So
Yeah,
one
that
you
was
can
my
put a
next
Steinman
question.
pin or a passing pin, so you can retract the
So
tissues.
this is the arthrex jig. The marking is here. And this is 14 millimeter. Curvature is here. You can see that almost at the PCL footprint. Sleeve लगा राजीव. तो वो लोग कर लेगा. हम नहीं. Sleeve दो उससे. ये रहा sleeve. Sleeve दो. चलो. Usually this should be just medial to the tibial tuberosity. Usually just below the level of tibial tuberosity on the tibia. Go in. इसको क्लोज कर दिया. चलो perfect. एक मिनट रुक जाओ. Just for the visualization purpose, बेटा अब उसमें पंप लगा लो. ये थोड़ा अच्छा नहीं दिखा रहे. क्या दिया है? उसमें बेटा इसमें तो है ऑलरेडी. इसमें मारो. हाँ, और उसको उसमें कनेक्ट कर लो बेटा. चलो तुम इंगेज कर लियो. स्लीप पकड़ो विवेक. स्लीप नहीं है बेटा. स्लीप पकड़ो बेटा. चलो एक दो पंप मार दो बस. रुक जा एक मिनट थोड़ा मार. लिटिल बेटा. ये छोटा थोड़ा शिफ्ट हुआ है मीडियल साइड में. उनका स्लीप ये छोड़ दो बेटा, चलो उधर बंद रखो, चलो गो, प्रेशर रिलीज,
Dr.
प्रेशर
Arvind,
रिलीज,
Dr. Arvind,
यस सर.
Jaswinder this side. The clarity of this 70-degree scope is not as much clear as that 30-degree
Yeah,
one.
30
So there
degree,
is
I
some
know.
problem.
Just for
There's a lot of blurring actually.
So just in the at the center of the footprint of PCL, नाप लेना, अभी नाप को सकते हो ना, तब तक रीमिंग पास हो जाएगा ना. So diameter of PCL you can appreciate here. Tape डालना था ना.
How much did you get? That's
So it
tripled,
is-
no? The peroneus?
Erroneous and semi-to, this is 12, 11. So it is 11.
11.
On each side. यहाँ टेप डालो ना, टेप क्यों डालो? हाँ, इस पे रेल लोड कर लो, तुम ड्रिल करो. 11 का रीमर लोड करो. So tape just at the end of the graph, यहाँ दिखा, just for the pulling from the tibial side. Tape will be used here only, not in the graph.
Could you repeat that, Arvind, please? Further?
पकड़ो इसको. So many a time when you take the graft from the tibial side to the femoral side,
Yes.
there is lot of soft tissue in the posterior part of the tibia.
Hmm.
So you have ET bond here. At the same time, I'll put just a tape here that will give a much stronger thing to pull from the tibia to the femoral side.
Okay.
Because if this is weak, some soft tissue get stuck. Very high chances of breakage of this.
Okay.
ET bond. इस पे रेल लोड कर लो. रीमा
बीमारी 11.
So meanwhile I am just making the femoral tunnel also. Femoral ये है, ये femur आ गया. बस दे दो. Meanwhile 11 mm graph this femur is the, so tibia it should be high as possible and the close to the articular surface because I am doing single bundle.
Mm-hmm.
Arvind, aren't you worried with that sharp bead pin end in the back of the tibia just like that? Instead of you, I'm worried here that that sharp tip is on the back and you're doing femoral without doing anything on the back.
I'm not flexing the knee, just it is added here.
Okay. Yeah.
You can see we have enough space also.
Okay.
Reamer मिल गया. Just for the sake of saving the time, I am going to that side. मिल गया reamer 11 mm. तो लोड करके दो ना उसको. तुम ही लोग के चलते मैं 20 पिन ले रहा था. 12 का 35 चेक कर लेना बेटा. रीमर लो ना 11. ये कितना है? 11 रीमर रहता है ना सेट में.
अरे I am always worried sir. 2 बार आखिरी फोड़ी है मुझे पता है.
दिल दो. चलो पकड़ो इसको. तो
Old
पतला कर लेता जब
सियाम
इस शेप में नहीं
की
होता.
बात है. सियाम में थोड़ा रोटेटेड था तो इसलिए पता नहीं.
Just I am taking little bit back as advised by Bhutan sir. पकड़ो.
Thanks for doing that.
And going back to the femur side because I am still waiting for the reamer. Between load करो इसको.
Now Dr. Bhushan is breathing. He was holding it.
Yeah. So this is the femoral footprint of PCL. Sleeve ले लो बेटा. Brightness थोड़ा कम कर दो. Brightness बहुत है. Sleeve है ना? चलो sleeve लगा. यहाँ है मेरे हाथ में. इसको close कर लो. So are you happy with this position, Bhushan sir? Or you want to modify this?
No, no, perfect, perfect. That's fine. You're replicating the AL bundle, which is near between 12 and 1 o'clock position, which is fine.
That's perfect.
What
It's
is the
come
angle of
at
femoral
the
jig?
same- Pardon?
Angle of femoral jig?
Angle of femoral jig is 60 degree. This is again orthorex jig having curvature of the femoral condyle. तब तक 8 से कर लो बेटा क्या 11 यहाँ हमारे सेट का क्या हुआ हमारा सेट का
So you're planning aperture fixation for femur?
या aperture for the both tibia and femur चलो तब तक 10 से करो बेटा 10 mm दो जो है वो दो ग्यारह mm यूज हो गया तो देखो ना तब तक यदि ऑटोक्लेव अब तो 2 घंटे हो गए बेटा वो खत्म हो चलो चलो this is 10 mm remove meanwhile my jig is there only to protect
So you are roughly 10 millimeter from the articular surface.
yeah I'll just रुक जा बेटा धीरे धीरे बस बस ठीक So cleaning of the margin is very important, particularly for the PCL, for the passage of graph.
Yeah, otherwise it may get stuck sometimes, and then the soft tissue will act like a valve.
चलो 10 mm TVA के लिए ले लो पहले इसको हैमर कर दो थोड़ा So this is the tunnel.
Yes, it's looks clear.
एक मिनट पहले देखने दो And now back to the TVL tunnel एक मिनट देखने दो बेटा रुको चल जाओ धीरे 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 वो प्रोटेक्ट टीवीए पीसीएल देना तो प्रोटेक्ट करने के लिए तो देखो ग्राफ को यदि पतला कर सकते हो तो so this thing also has to be kept in mind because your graph should not be more than your reamer what available you have usually we have till 11 till 12 reamer we have available here but that was used in the last case the set was open चेंज कर दो बेटा पानी खत्म हो गया ना चेंज कर दो कमलेश को बोलो रहेगा उसमें लगा दो चलो चलो हाँ सर ठीक है बेटा वो आप पानी वाले सिस्टम पे तुम तो हो ना Usually it's very easy with 70-degree scope. लो पास करो राजीव, पास इट, हैमर करो करो, good. बस बस दैट्स इट। 10 mm है कि 11, जो है मैक्सिमम साइज वही दो। नहीं नहीं ठीक है दिख रहा, चल खोल क्यों दिए हो बेटा, टाइम क्यों बर्बाद कर रहे हो? So we are drilling with the 10 mm that we have available. So we'll decrease the diameter of the graph. चलो रुक जाओ अंदर चला जाओ, चलो धीरे धीरे जाओ, कोई बात नहीं, हैमर कर दो।
So decreasing the diameter, you had to redo the whole thing?
No, just trim the graph from the side. I'll show you. चलो चलो drill करो।
And what about the whip stitches?
I'll show how to decrease the graph diameter. Meanwhile, may be possible that they will give me 11 mm. क्या हो रहा है 11 का? धीरे धीरे जाओ, चलो, धीरे धीरे। एक बार बता दो कितना देर में मिलेगा तो धीरे धीरे। धीरे धीरे। फ्लिप कटर है ना, फ्लिप कटर बस में ठीक। So this is the trivial tunnel that we have. एसएस वायर दे दो। कोई पीसीएल स्टेप का कोई स्टाफ कर रहा है कोऑर्डिनेट, कि सब एक ही चीज में एक ही जगह खड़ा है? फ्लिप कटर आ गया है, फ्लिप कटर को कर लो 11 पे। So we have flip cutter. This will give us the diameter of 11. ठीक है, 11 कर लो बेटा उसमें। हाँ चलो जाओ, धीरे 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 धीरे, रुक जा पहले देखने। हाँ नहीं आ रहा ना अभी, फ्लूइड एक्स्ट्रा वेसेट करेगा तो देखने में दिक्कत होगा। एक काम करो, बाहर से ही थ्रू एंड थ्रू करना है ना, बाहर से। तो दिस इज द फ्लिप कटर, यू कैन सी द डायमीटर हियर। 11 कर लो बेटा।
अरविंद पुट द बुलेट इन फर्स्ट, उसके बाद में फ्लिप कर डालो उसमें।
Before flipping,
if you put the bullet in the tunnel, you won't have
first.
the toggle in the because already done 10 millimeter ना।
वो 11 mm का क्या हो रहा है, कुछ बता रहे हो? एक मिनट, 11 mm बीमर है कहाँ हम लोगों का? हम लोग का 11 mm रीमर जो है डायरेक्ट में डाल देता है इसमें। हाउ यू नो कि कितना गया छोड़ जाता है? इसको 11 कर लो, एक मिनट रुक, धीरे धीरे मुझे दे दो। 11 कर लो बेटा। कितना है? 11 हो गया। So this is 11 meter open here.
Okay.
Little bit in this direction. Already हो ही गया। So it's coming very easily. So almost चलो ठीक। इस वाले में कर ले, यहाँ हाथ रख के बैठो। चलो यहाँ बंद कर ले, बाहर से कर। बस बस आराम से। कितना है? 9, 10, 10.5, 11. So almost this is 11 mm. So almost it is 11 mm only. So okay, let's see. I will decrease little bit graph
initially
diameter.
it was
हमको
drilled
SS wire दे
with
दो।
Arvind, it was drilled with initially with 10.
10 millimeter, I don't know what diameter they have given
Yeah.
to me. Now I have passed this SS wire from the TBL side, hold it.
Okay.
And I'll retrieve, अपनी ओर ले लो, बस सही. Till the tunnel here, पानी बंद कर दो बेटा, यहाँ हाथ रख लो, हाँ, perfect, चलो. So, and then on the femoral side. यहाँ focus कर दो जरा. So this is on the femoral side. I'll put another SS wire here.
And
Just
railroaded.
do little bit of passage of this SS wire. दो वो लगा लो. बेटा यहाँ तुम हाथ रखो, यहाँ से हाथ रखो. हाँ, एक पकड़ यहाँ लगा लो. ज़्यादा मत करो. आने दो. तो यहाँ पे फोकस करना जरा आउटर पिक्चर अपनी ओर ले लो. So this is usually done for the better passage of graft because high chances of getting stuck with the soft tissue. By this maneuver, your tunnel will be free of the soft tissue. In between the tunnel passage will be free of the soft tissue, but that's it.
And this maneuver will increase the diameter also of the
Usually
tunnel.
not if it is very
some
thin SS
bit
wire.
of osteoporotic bone or penic bone.
This I learned at a sports injury center. So Joshi sir is here. He may say better about the increased diameter with this technique. Joshi sir?
He's not in the
He's
room
not
right
here
now.
in the hall.
ग्रुप में ग्राफ में ये पकड़ो. तो यहाँ दिखा दो जरा. ये पकड़ो. ये पकड़ो. जरा साइजर दो हमको फिर से एक बार.
11 कौन सा है बताओ, दिखता नहीं.
ये कैसा साइजर लेके आया? चलो दूर रखो बेटा. दिस इज 11 है ना. चलो 10 पे जाओ. हम लोग 10 से किए ना. बट 11 से फ्लिप कटर से तो हो गया था, बट यू नेवर नो द 10:30 में देख लो.
The graft is now, after trimming, how much?
It's 10:30.
10.5.
10.5.
Okay.
So we can take the risk whether this is passing or not, because with flip cutter it was 11. Let's see.
Yeah, that was also passing very freely.
Yeah.
The flip.
So this was the fiber tape that was given there for the pulling purpose only. एक मिनट यहाँ वो लगा ले, क्या नाम है, कॉपर लगा लो. बस ठीक. चलो पास करो इसमें. और पास करो. ये पकड़ो बेटा, इसको यहाँ रखो. चलो खींचो. So this is on the femoral side. चलो पकड़ ले. चलो चलो So it's not coming very smooth. So we'll wait for the 12 diameter. That will come in couple of minutes. ये पकड़ो. Meanwhile, I'll do the ACL part. So you can continue with the lecture. When 12 diameter come, then I'll demonstrate the remaining part. Okay?
Okay, we'll do that.
Yeah.
So Dr. Abhishek, are you ready with the lecture? OT का ट्रांसमिशन अभी रोक दीजिएगा.
So may I call upon Dr. Abhishek Das, who will be talking on MCL tier.
Good afternoon, everybody. I think it will be difficult to engage everybody after such an engrossing and beautiful surgery by Dr. Arvind. My talk is on MCL tears, and I'll show a couple of cases because there has been or there is a persistent debate as to whether we should treat them conservatively or operatively. So, first case is a 29-year-old male, came to me 2 days after a twisting injury to the knee with a complaint of knee pain. There was no history of knee giving way or locking, and the patient came walking full weight bearing. So on examination, there was tenderness over the femoral epicondyle region, no tendon or proximal tibia, no bruising and minimal swelling, and there was full range of knee movement. So probably so this is the MRI image. So what's going in our mind? Just the chairpersons or anybody, especially the PG students or the trainees. I think this is pretty clear-cut, straightforward case where there is no laxity in the full extension, no valgus laxity. In 30 degrees flexion, there is a touch bit of laxity, but with a very firm endpoint. MRI, probably there is a bit of edema, you can say, but it looks pretty much normal. The MCL, the X-rays are normal. So this is not exactly how I treat these cases, but this is more so for the grade 2 laxity ones where I treat them with range of motion brace. If it is a grade 1 with no appreciable laxity, just tenderness, then I send them straight for rehab. I do not brace them at all. With grade 2, and even for the grade 3 ones with no kind of, with a firm end point, I treat them with range of motion brace. There is a bit of debate as to where you should keep it for 4 weeks or 6 weeks. But to keep things simple, this is the protocol we used to do in UK, 0 to 30 degrees, 2 weeks, 2 to 4 weeks, 0 to 60 degrees, 4 to 6 weeks, 0 to 90 degrees. Any difference of opinion as to whether you would fully weight bear them or keep them non-weight bearing? Okay.
No harm in getting them full weight bear, isn't it?
Yeah.
With
In
the
this
brace you
case,
can give.
definitely. But if there is a grade 3 laxity, I would keep them non-weight bearing to avoid the pivoting. And but you know, there's no kind of hard and fast rule. So next case, 35-year-old male with a history of fall and knee injury about 5 weeks ago. Initially treated in a brace for 4 weeks. So when the patient came, it was about 5 weeks with a history of knee giving way but no locking. So on examination, there was, at 5 weeks, there was no tenderness over the femoral epicondyle, no tenderness over the joint line or proximal tibia, no appreciable bruising and minimal swelling, knee range of movement around up to 100 degrees, valgus laxity at 30 degrees with a soft end point, Lachman's and anterior drawer test positive with a soft end point. Positive draw negative, dials test negative. These are the X-rays. This is the MRI, the coronal view. So on this, what do we think it's going on? I think there's something going on with the MCL. These are the sagittal views, and there, the ACL, there seems to be a tear. So these are the multiligamentous injury cases, and we have had a bit of discussion on this. The chairpersons or Bhushan sir, what do you think we should do in this case?
It's a normal ACL MCL combination that we tend to see. I forgot if you mentioned, is the knee opening in extension also?
The knee is not opening in extension.
So you can safely call it grade 2 MCL injury?
Yeah.
So POL is not gone yet?
Yeah.
Okay, so so there's significant bony edema. There is no discernible major medial meniscus tear seen, at least not from here. So you would wait for 2 to 3 weeks normally for these patients with knee immobilized in about 10 degrees of flexion to allow the MCL to tension a bit or heal a bit. But you said this is already 5 weeks old and is already
Patient was already treated for 4 weeks in the brace.
So it's a failed ACL MCL rehab. So
I think when the patient came, he was just treated in the brace with no appreciable rehab or you would say, quadriceps or hamstring, any kind of rehab done to him. So 1 week he was out of brace, and I can't remember whether he was sent to any physio or not.
Is the knee bending or is stiff now?
Yeah, so knee is bending from 0 to 100, almost past 90, but not fully.
So, okay for surgery then, good.
Yeah. So first thing we have discussed that it is a case for surgery. We have already tried non-operative measures. So timing of surgery? Now.
6 weeks already.
Yeah,
So
I think
there's
it's
no need to
already,
wait now.
I won't wait to get his full knee range of movement. Up to 100 degrees is acceptable to me. We can pass the scope and we can do an arthroscopic as well as whatever we need to do for the collateral. What surgery? Pretty much, how would you sequence it? Whether you do everything together or you just...
It's just 2 ligaments, so both can be done at the same time. The question will be whether you should take hamstring grafts because of the MCL injury, because that will lead to a bit more laxity, or should you take something else? I think Deepak or someone just showed taking semity, leaving it attached to the tibia and using it as a graft for MCL, and using a quadriceps, BTB, peroneus longus, contralateral semity, allograft, whatever else you want for ACL is a good option.
Yeah. Previously, like I worked with one of the consultants in UK who used to leave the hamstring, used to take BTB if it was a male patient. For female, obviously we never used to take the BTB graft. So BTB and peroneus longus or something else. There were options of allografts as well available. But he said that we should not defunction the knee even more by using the hamstring. But, again, no strong feelings for or against it. MCL repair or reconstruction?
I'm going to say something slightly controversial. This will be a good candidate for a POL advancement. Now, those of you who are young ones may not remember a POL advancement as a surgery. I think senior guys will know zone-specific POL advancement. Posterior oblique ligament is separate ligament just behind the MCL, and there are 5 zones of the POL, and you can advance it based on which part of the MCL is gone. So if the femoral is gone, you can advance zone 1, zone 2. If the central part is gone, you can do zone 3, and 4, 5 are for the tibia. People almost have given up on it for some reason, but that's one of the best surgeries you could ever do for a grade 1 or for a grade 2 MCL. So that might be something you should think about.
Obviously, I didn't think about that option, but in the next case, definitely that would be one thing. MCL repair with augmentation maybe, or MCL reconstruction, which would which is what I thought about it. Obviously, I didn't think about MCL repair at 5 weeks. Now, ACL plus MCL reconstruction, we have already discussed it. One thing, would you, in this case, do an ACL reconstruction and reassess it, or just do an EUA beforehand and then just proceed with the plan?
Well, you can always EUA and decide whether the MCL is stable or healed in any way. But if he's had a recent history of giving way and you felt the ACL, you felt the knees opening in 30 degrees of flexion, I think it's gone.
So this is the drive-through sign. It's quite opening. And that was the reconstruction done along with the ACL. So again, what we have already discussed, isolated MCL tear heal well with good rehab protocols. Grade 3 isolated MCL tears may be managed conservatively, but if it is a part of multiligamentous injuries, there's a low threshold for surgical intervention, and we have seen the protocols. These are some studies which kind of show that what we have discussed, like isolated MCLs, you can treat them in a brace, but as part of multiligamentous protocol, you can leave the ACL, do the rest in one stage, so overall a two-stage procedure. Thank you.
So, Dr. Abhishek, so I mean, how long you can wait for, I mean, before reconstructing ACL, MCL? If it's ACL plus MCL injury, grade 3 MCL.
Yeah.
So deadline is what, 4 weeks, or we have to wait more than that?
Yeah, normally ACL and MCL injuries, if it is only these two, then I would rehab them in a brace, and that would for me be 6 weeks.
6 weeks. So you will reassess at 6 weeks.
Reassess at 6
then
weeks.
You will, if it's not healed, then you will do ACL and MCL.
Yeah, I'll do the ACL and MCL.
So what technique did you use in this case?
Sorry?
For MCL reconstruction, what technique did you use in this case?
So it was one of the standard technique where we used the kind of we took the semi-T graft around the screw with the washer, just round them up and stitch them together. So the washer acts as a hinge on which the MCL. So it's extra ligamentous, but you can use swivel locks and other options as an interference screw.
Yeah, any role for internal bracing for MCL? That works wonderfully in these kinds of injuries.
Yeah, so that was one of the things I wanted to put it in, but then it quite becomes like one company specific, so I didn't put it in my slide. There is definitely a role for them in these cases where you can do an ACL, do an internal bracing, and leave the MCL.
If it works, company doesn't matter. If it
Yeah,
works
sure,
fine
sure.
in your hands, I think you shouldn't worry too much about those things.
Yeah, I entirely agree.
So you said this patient came to you at 5 weeks and had no rehab.
He was treated in a brace, but he wasn't sent to a physio. I don't know if he was instructed to, take it out of brace and do some kind of hamstring or quadriceps exercises.
So would you think of doing that first before going to surgery?
Yeah, definitely. I think there's a role for it, but he was kind of giving history of knee giving way. It was already 5 weeks down the line.
Yeah,
so.
okay. So if it gave way while he was walking itself?
Sorry?
Did it give way while he was just walking?
Yeah. So
then you need to do something anyway.
Yeah.
Any landmark where you would put the screw on the tibial side for the fixation of MCL?
Good question. Avoid the tibial tunnel. It is about, well, to be honest, I can't exactly remember. I'd like your opinion on that.
It's at least 6 centimeter down the joint line.
Yeah.
Just in front of the posteromedial cortex, I suppose.
Yeah, definitely.
Just anterior to posterior cortex.
Yeah.
Down.
Yeah.
Right.
Yeah.
Right.
Okay, sure.
Call Dr. Raj Kumar.
No.
No.
Rajkumar is not here.
Achha, he's Dr. Bhushan, yeah.
That's me.
He'll be talking on the expert lecture on LCL injury.
Let's hope this works. Yeah, okay. Give me a second. So, I need to shift the view. They are getting the presenter's view, I am getting the view on the screen. I'll try and not bore you too much and be a bit quick about it. So a typical patient, unfortunately my own, 3 years back did a ACL reconstruction. This is about 10 years back. So you can see the result of that ACL. She's got a significantly bad varus thrust, the so-called triple varus deformity, and that's due to a missed lateral collateral PLC injury of the knee joint. That's very important not to miss these injuries, because these are very important. Houston, as he was a god of a lot of ligamentous surgeries in the knee, in 1976 actually named this as the dark side of the knee. Since then we have found a lot of darker sides of the knee, but this was the OG dark side of the knee joint. So ACL, PCL and PLC injuries quite a few times go hand in hand, especially the PCL injury. So if you ever have a PCL, quite a few times the PCL and PLC go hand in hand. Pretty complex in terms of structure. So if you remember your anatomy dissections, this is exactly how your posterolateral corner is in 3 layers. The top layer is the IT band along with the common peroneal nerve, with a deeper layer of corticeps retinaculum and the 2 lateral patellofemoral ligaments. Is a deeper layer, the layer 3, which is very important. Again divided into 2 parts, the superficial and deep. This is where the main structures of your PLC are. So the LCL and fabulofibular ligament, the lateral genicular artery running between the 2 layers, and the popliteus tendon, the arcuate coronary ligament complex, and the popliteofibular ligament, which is supposed to be the most important part of the whole thing. I don't want you to remember any of this. I just want to show you the key parts. That's the popliteofibular ligament as such. Anybody interested in learning about anatomy a bit better can of course read Laprad's paper. But before that, these 2 papers are also equally good, which talk a lot about the actual anatomical structure which are important. This is me playing with Microsoft Paint, and you can see the basic anatomy of your posterolateral corner. You can see the ITB, the biceps and the common peroneal nerve, and on the other side you can see the other structures which are important. From the fibula comes the lateral collateral ligament. Just behind that is the popliteofibular ligament. The popliteus coming up there, and the blue dot there is the fibula, which forms the fabulofibular ligament. So these are all the structures. Any of you who have access to cadaveric dissections, just go anytime you want and open the knee from the backside. Take all the both the gastrocs out. Take the neurovascular structures out, and you get a brilliant view of the posterior capsule of the joint, and funnily enough it looks exactly the same. So that's where the arcuate ligament is. It's a Y-shaped structure which attaches laterally to the fibula, and this is an important part of the posterolateral complex as well. And as you would see in quite a few cases, you will see an arcuate avulsion. That's what the avulsion of that fibular limb is. Now biomechanically it's a very important stabilizer for varus, and it's also important for anterior and posterior stability of the knee joint, and it also gives a minor role for your internal rotation restraint. So this is me doing some cadaveric dissection. The front is the ALL, the back is the popliteofibular ligament. There is a LCL seen in the middle, and you can see how rotation changes and the ligaments get tight with external internal rotation. It's very important to understand this, that there's a primary stability to external rotation for these. I won't go into details of how it happens, we all know about it. We also heard about how a dial test is important to diagnose these lesions. In 30 degrees of flexion, if you get opening excessive external rotation, that's very classical for a PLC injury. And if you are getting excessive external rotation in 30 as well as 90 degrees, it's PLC plus PCL, or maybe just isolated PCL. So important to remember these things. This is very commonly seen, and this is a knee dislocation, and you can see the big fibular avulsion pattern. So don't miss these injuries, because they can lead to devastating complications in future. So you can either get an isolated PLC injury, which is pretty rare, or it can be part of a multi-ligament injury along with your ACL or PCL injury. Anytime you have ACL, PCL along with PLC, it's always a good idea to do a Doppler scan, because there are sometimes intimal injuries to the artery which are missed, and then you wake up the second or third day with a patient having a white leg or a white foot. It's a pretty frustrating thing to have that. Common peroneal nerve injury is pretty common with PLC injuries, so always examine your patient, make sure they're getting dorsiflexion in the foot and toes, and it depends on how severe the force was. On simple X-ray, you can see a Sigon fracture, but you can also see an arcuate avulsion, which is distinctly separate from a Sigon fracture. It's called arcuate sign. And you can see abnormal opening of the lateral compartment. That's pretty classical. And on the MRI, it looks as if a bomb exploded in the top surface of the fibula, where everything is just damaged significantly. We are orthopedic surgeons, we always like classifications for everything. So the posterolateral rotary instability, that means PLC along with ACL injury or a PCL injury, would lead to various types of findings. So the key test is external rotation and varus laxity in 30 degrees of flexion. And depending on the main components which are affected, the popliteofibular ligament, popliteus or LCL, and the capsule, the severity increases from A to C. Now, coming to management, there's a variable pattern seen, so you need to make sure you don't miss it. And if neglected, you can have serious problems with early OA changes in these patients, which might need a HTO in future. So we want to stabilize this as early as possible. Sorry for the very heavy slide, but essentially you can easily do a direct primary repair for something like this, where your ITB is avulsed, your biceps is avulsed, your nerve is slightly bruised or damaged, your gastroc is injured. That's a severe kind of injury. You can just do repair of everything, works quite well. For a chronic injury, you can either do a Larson kind of procedure using a free graft, or you can do a good old-fashioned biceps tenodesis, Clancy tenodesis as it was called. I haven't seen one since I started practice, but it always is an option for temporary stabilization of PLC, but no longer an important procedure for us to know. Larson sling works really well. It recreates most of the components of your PLC except for the popliteofibular ligament, and that's why the Laprade technique came in, which includes recreation of all of the three components, the popliteus, the lateral collateral ligament, as well as the popliteofibular ligament. I modify this technique very slightly, where I take one more stitch between the posterior part of the graft along with popliteus to recreate the popliteofibular ligament slightly better. Coming back to the same patient that we saw in the first part, the ACL implants were removed, a formal HTO was done, and immediately her alignment changed and her thrust went, but she still had significant amount of laxity on the lateral side. So next is to do a lateral reconstruction using either Laprade technique or any technique you are comfortable with. So the landmarks are lateral collateral ligament insertion on the lateral epicondyle, the midway area between the fibular collateral ligament, so between the fibula head and Gerdy's tubercle, that's for the ALL. We are not talking of ALL, that's just a landmark I've shown. But your incision is between these 2 points for exposing the lateral compartment. A lot of times people make the mistake of getting their incision too far posterior, and then they struggle to reach the anterior part of the incision. Let me see if I can show you. The first and the most important part is to find the nerve, and that's the most time consuming during this surgery. Quite a few times the nerve is very bruised. All you need is a good incision and finding the nerve really carefully, and always do a neurolysis. So always release the nerve all the way to the hiatus posteriorly in the popliteal hiatus to make sure the nerve is clearly seen and is completely decompressed before you go any further with your reconstruction. Now once you have done that, you can easily palpate the area superior to the nerve and back of the fibula head, and you can easily put your finger in to find where your fibula tunnel is going to be. Now the fibula tunnel can, so that's how your finger can be there. Now some people are brave enough to drill on top of the finger, very good, but you have really good jigs now. So these jigs are fantastic for saving your finger when you're drilling, unless you are super confident of not hurting yourself. So this is a set for a Laprade PLC reconstruction that is available through various companies, and it works really well in most people.
So there is actual jig which goes behind the fibula head, and you can make a tunnel like that in the fibula head. There is also a flexible or moldable retractor which can be placed behind the tibia or behind the fibula to create your anteroposterior tunnels comfortably. So once you have done that, let me see if it works. Yeah. So once you have done that, you have created a nice tunnel. It's a standard fibular tunnel from anterior to posterior, slightly more anterolateral to posterior medial if possible, because you're trying to replicate your LCL insertion, which is more to the lateral side, and your popliteal fibular ligament, which is more posterior medial. Hope I'm making sense and not confusing you more. This is followed by making a cut to find the insertion of your lateral collateral ligament. As you can see, it's a bruised area in the center. That's the lateral collateral ligament insertion, the lateral epicondyle. So find that area. Now you need to make 2 tunnels to replicate the anatomy. So this is how your popliteus and your LCL are going to come. The distance between the two has to be about 18 millimeters. When I say 18 millimeters, that's for a male. For a female, it can be smaller, where smaller tunnels can be used. So all that you need to do is drill a tunnel from lateral to, give me a second. From lateral to medial, aiming slightly proximally and superiorly so that you won't encounter any other tunnels. And there is a brilliant jig after that to make sure you are getting 2 tunnels which are wires which are perfectly parallel without them converging or diverging, because quite a few times if you do freehand, your screws hit each other and then you get a graft which is loose. So this is what you're aiming for. You've got 2 tunnels. The anterior one is for popliteus, the posterior one is for your LCL. And the main advantage of using an all-inside technique or outside in drilling technique is now that you know where your tunnels are, you can create a ACL tunnel without tunnel coalition between these 3 tunnels. So it works really well when you know where your landmarks are. And then they just followed by passing the graft. So we have passed the graft in here. So that's your graft in the fibula. Those who are keen-eyed will see I've reinforced that with fiber tape. You can or may not do it. But I like to fix it to the fibula with a screw if possible. This is a this is 6 millimeter fibula head peak screw, which is being attached to the fibula head. I agree, especially in petite females or thin males, you may not have sufficient space, and in such patients I do periosteal stitches to hold the graft to the fibula periosteum, and that works really well. But securing the graft to the fibula avoids any movement of the graft from front to back and makes your fixation really secure. Now that you have done that, you pass your one limb, that's the LCL limb, up under the ITB, and the popliteofibular limb comes behind the biceps. So that's a key part that you must remember, that the posterior limb has to go under the biceps as well as under the ITB. So that way you are replicating the anatomy now. I know I'm rushing a bit fast, but I have much more to talk. And this is followed by fixation with 2 screws proximally as well. Indeed, sometimes you can just do 1 screw and without any issues you can make a central big tunnel. But if you're trying to be anatomic, it's better to do everything properly. Then the grafts are pulled anteriorly in the tibia and fixed with a screw from front to back, and that's the result of the final reconstruction. And you can see a endo button with an extendo button on the back where the ACL has been fixed. So this is roughly how a Laprade is done. For conditions in which you just want to do a Larsen, there is a different way we have described. It's called percutaneous Larsen, and this is just a 2 centimeter incision behind the fibula head. Rather than opening the whole lateral side, you can just make a tiny hole on the back, go very slow with the dissection, find the nerve, then make your fibula tunnel. Pass a plastic tube which allows easy passage for the thread. Same thing on the top, you find the LCL insertion and you make a single tunnel. Pass your graft in. और 5 मिनट है, 3-4 मिनट है. And then you pass the graft, fix it proximally and distally, and that's your Larsen done through 2 centimeter incisions both proximally and distally.
So it's a good technique to do for most patients. There are some weird patterns that you'll see. This was a professional football player who felt a snap in the knee when he was running, and you can see it's an isolated LCL rupture. That's the LCL. If you can see, it's completely ruptured from the fibula head. Everything else was intact. So all he needed was an LCL repair, and he went back to become the, I think, ISL player of year the next year. Sometimes you only get a biceps injury. So this is a patient whose LCL is completely intact, as you can see, but the biceps on top is completely gone. So the biceps envelops the LCL insertion. So the biceps is completely gone, and all it needs is a bicipital repair along with reinforcement using some implants. There are times when you wish you hadn't opened that knee, but this is one of the cases where everything was torn, but surprisingly the nerve was intact, and everything had to be repaired completely. Another case, everything was completely gone except for the nerve, which was still intact, and you had to repair everything very slowly and very securely. But sometimes you face with this. The central strand that you see is actually the common peroneal nerve, which is completely torn. And in such cases, you then have to do a tendon transfer. So this patient had a big arcuate avulsion and needed a screw along with a figure of eight tension band wiring to get the fibular arcuate complex reattached, fibular head reattached, along with his ligament reconstructions. Later he had a tendon transfer and did really well. So to conclude, it's important to diagnose and manage these injuries. The key components are your popliteus, popliteofibular ligament, and LCL. But don't forget the biceps, the ITB and CPN. There is a pretty variable injury pattern. So be prepared, and so you won't have any surprises when you open the knee after doing a cursory EUA. Thank you.
Thank you, sir. So we'll connect back to the OT. Dr. Arvind is waiting there. Dr. Arvind?
Hello. Hello.
Yeah, we can listen to
you,
sir.
So can you see the picture, intra-articular picture?
Yes, Dr. Arvind.
So I have passed the PCL graft here till the margin of the tunnel.
Yes.
And this is the ACL graft that I have passed with whatever the remnant I kept there untouched. And this is your guide wire for your screw. That should be the posterior to the graft, so that graft should be anterior as much as possible.
Fine.
And pull kar isko. एक minute. And I'll take the graft around 2.5 centimeter into the slow, little bit more.
So you removed it 11 when we are off?
Yeah, till 11. Yeah, leave there only. Now, isko pakro. Isko halka, tibial, give the graft. Since it is tunnel of 11 remorque, so I'm taking the screw of 12.28, okay?
The femur side, okay.
On the femur side, with, इसका direction याद रखना बेटा, हाँ, ऐसे. मुझे दे दो. So just screw in on the femoral side. With little bit of tension both sides of the graft, femoral side and tibial side. You can the screwing sound. This gives the sense of relief that the purchase of a screw is good. And this is coming, the tip is coming. Can you see the tip of the screw?
Yes. Yeah.
So this part is done.
What was the length of the screw?
12.28.
Okay.
Now I'll fix on the tibial side at 90 degree of the knee flexion. तुम हट जाओ बेटा. आगे ट्रांसलेट कर लो टिबिया को. इसको पकड़ लो रवि. हमको 11 का 35 दे देना. Since graft was very tight, even with the 11 on the tibial side, and the bone is very strong, so I am taking the same size screw on the tibial side also.
Graft is 10.5, no?
No,
TBS
it
side?
was on the tibial side 11. On the
Okay.
femur side, it was 10.5.
Okay.
Perfect. ये लो यहाँ पे. So you can see the position of the knee. It is 90-degree flex with one assistant. इसके direction में रखो. Complete anterior translation of the tibia. Here, if bone is very hard, then sometime you have to take the same size of the screw, because many a chances if a screw is bigger, this may cut the ET bond. That happened to us one or twice. So whenever the bone is very strong, we used to take the same size of the screw for the PCL on tibial side, or maybe extra supplementation with ये पकड़ो जान. और नीचे रिट्रैक्टर लगा लो, सॉफ्ट टिश्यू आ रहा है बेटा, नीचे नीचे रिट्रैक्टर. थोड़ा स्ट्रेट वाला दोगे? हाँ नीचे, परफेक्ट. ये स्ट्रेट गाइड वायर मिलेगा? हाँ ये ठीक है, ये दो. Yeah. Now you can hear that sound again. Yeah, that's perfect. Yeah. Hamado. So it's jammed. Yeah. Picture. हम बाद में कर लेंगे. So give me the probe. Now you can see the position of PCL.
Yes, perfect.
Very close to the articular surface, and it is high as possible. At the same time, it's very tight. Whole knee is moving. I'm putting lot of force here. Okay. Now I'll fix the ACL also, but I want to come on the medial side. Just यहाँ focus कर दो बेटा. As we have seen in the MRI, it was complete avulsion from the femoral side. So many a time with MRI, it looks only soft tissue, but the MRI was depicting that it's the complete separation. So it's the bony piece here. That feeling was with me from very early. That's why I don't save any graph for MCL recall. You can see this is the bony piece. Table throw down kar do beta.
Yes.
Can you see it?
Yes, yes.
So it is the complete bony piece here that I was discussing on MRI also. So though I have taken a stitch, I have the bone and tendon junction also, I'll supplement with the swivel lock, but this I'll fix with a spike washer and a screw. Just for the anatomical demonstration part, here is the adductor tubercle. You can see just below that there is depression, and here is the elevation. Femoral condyle is getting up.
Can camera
And
be slightly
here,
up?
Adductor tubercle is here.
Can camera be slightly up? Your hand is coming in between.
Beta दिखा दो जरा. So on the medial side, this anatomy should be kept in mind all the time for MCL or MPFL. So this is the adductor tubercle.
Yes.
Here you can see the depression, and this elevation is adductor tubercle.
Yes, yes. Much visible.
Here the MPFL groove is there, and this is the MCL completely with the epicondyle part. So this is distal to the adductor tubercle and little bit anterior to the adductor tubercle. So this is the medial epicondyle. Now give me the beat pin दो बेटा. Beat pin load करके. Spike washer ready है. Beat pin इस पे load करके दो. चेक कहाँ है के वायर वाला गेट वायर पे डेप्थ गेज रेडी है मुझे दे दो So on the lateral side there is ACL tunnel also. So I'll usually I direct little bit proximal. खोलो इसको बेटा चाबी दो 4.5 का रिमर चाहिए होगा डेप्थ गेज रेडी रखना डेप्थ गेज चाहिए होगा डेप्थ गेज दे दो इसको निकाल लो निकाल लो फोर पॉइंट फाइव का कैंसिलर से स्क्रू रेडी रख लेना बेटा तो दिस डेप्थ इज 80 आ रहा है 80 दे दो विथ स्पाइक वॉशर So this is the cancellous screw, partially threaded,
Not
with
visible.
a spike washer. इसको
Camera
प्रेस
is
करके रखो आरटी से
not,
आरटी से प्रेस करके रखो रोटेटिंग के बाद and I have done the curettage of the margin also with the curette.
okay.
Meanwhile, in between the time I have. So this is going very strongly. You can hear the sound also of a screw purchase. So knee is in little bit of varus and 30 degree of flexion around. So this is strongly compressing. यहाँ focus करो जरा. So this is just strongly compressing over the femoral epicondyle. Now you can see it has compressed very well.
Yes.
There is hardly any movement. Now I will supplement with this swab lock also. Okay. Now you can see, छोड़ो. You can see hardly any opening is there. And the ACL भी fix करना है ना. ACL का screw दे दो बेटा.
Is there need to for supplement fixation for that MCL?
Pardon?
Is there any need to supplement that fixation for MCL?
Just for the security in the back of mind of surgeon only. The screw hold is very good. It compressing.
Yes.
It compresses the fragment very well. ये इधर आओ एक आदमी पकड़ो इसको. ये पैर हटाओ सेवर पर से. ये पकड़ो. ये छोड़ दो कुछ नहीं करो. Since PCL reconstruction was here, so that's why I'm not giving any posterior door test for the ACL. टेबल ऑफ कर दो बेटा. डाल दो इसको. छोड़ दो. Let's see the intra-articular picture. रोप दे दो मुझे. So this is PCL that is quite tight. ACL pull kar lo beta final. So it's adjustable loop, so we have advantage of
Pulling it
making
further.
tighten the graft from the femoral side also.
Mm-hmm.
Now it's completely tight, you can see also. So PCL, ACL, and on the medial side hardly there is opening. You can see I cannot insulate this probe in between tibia and femur.
Yes.
So ACL, PCL reconstruction with MCL repair. Now let's see the clinical also. There is hardly any, whole body is moving, but tibia is not moving at all. And this valgus testis is also negative. Any question, please?
Fine, fine. Any questions? Well done job, Dr. Arvind. A big round of applause for Dr. Arvind.
Thank you, sir. Light on kar do beta.
So, Dr. Arvind, we'll move to the next session because you had a lecture. What
Yeah, I
would you
can
like?
give my lecture also. No problem. I am free now. Rajiv will put the swivel lock of that.
So
Binay can put my lecture there on this screen, and I can give the lecture from here. Binay?
Okay, yeah, we'll take another
Okay, we are doing
2
that.
minutes. We're doing that.
Bhushan sir, for PLR posterolateral rotatory instability B and C, you prefer modified Larson, that is two femoral tunnels, or modified Laprade?
I prefer Laprade for type C. Type B depends on the patient. If it's a low demand patient, then simple Larson is enough.
With two femoral tunnels?
Again, depends on the size of the patient. So the problem with us is that we don't have smaller screws than 6 millimeters or 7 millimeters. So the minimum size of the tunnel is 6 or 7 millimeters. If you don't have space on the lateral femoral condyle lateral wall to have two 7 millimeters which are at least 1.5 centimeters apart, a central tunnel works fine for a low demand patient. But for a high demand patient, I would try and replicate the anatomy as much as possible.
I had come across an article which says that even for type C, modified Larson with two femoral tunnels is equal to Laprade.
So if you read the papers done by Laprade group, they vehemently deny it. But there are other people who say it doesn't make much difference. But it makes sense to replicate the anatomy as much as possible. So in Larson, the popliteal ligament is not replicated at all. So it's better to do a Laprade. Laprade works really well in most patients.
So, Dr. Arvind, we are ready. Are you there?
Yeah, I'm ready.
OT. Dr. Arvind?
Yeah, I'm ready. Can you hear me?
Yeah.
Yes, we can hear you.
Next slide, please.
Next slide.
Next slide.
Yeah, start.
Next slide, please. This is the test for this. So this was the case that came to me in the August 2015 with this X-ray with severe difficulty in walking. He was walking with the help of brace. He was 28-year male guy. He was from Patna only, working at Bangalore as an engineer. Next, please. So his story has started. Next slide, please. Yeah. So his story has started almost 2 years back in Feb when he sustained bicondylar fracture of the tibia that was fixed. This was the post X-ray immediately after some time. Next slide, please. Yeah, but even after the back. So even after the end of 1 year, he has instability. Though he don't have any pain, he has instability. So this was the post-op X-ray, the dawn first, second level first X-ray. So this was the final post-op X-ray. After 1 year, he has instability. So doctor suggested him for removal of the implant and the ACL reconstruction. So removal of the implant and the ACL reconstruction was done with the hamstring tendon with bioscrew both the sides. So this was the X-ray, final check X-ray after the surgery. Next, please. But his instability persisted. So after couple of months again he went to another surgeon. He advised for your slope correction osteotomy of the tibia. So this was done in, I think, July 2014. Uh, there is some problem with viewing of this slide here. You can see the date written there. So this surgery was done, and after that patient again continued with the instability problem. So he went to another surgeon. This was the third surgeon that he visited. Next slide, please. And this was the X-ray after revision ACL reconstruction and the posterolateral corner reconstruction. Doctor said him that your ACL is not working, at the same time you need posterolateral reconstruction also. So this was the X-ray of February 2015. Next please. And this is the August 2015. Patient is still walking with walker with the knee brace on. 28-year male guy, engineer, having all these problems for almost 2.5 years. So this is the X-ray. You can see the tibiofibular subluxation is there, particularly on the posterolateral side. So Bhushan sir, what should be done now?
How is his alignment, Arvind? Do we have a scanogram or something to see his
A
alignment?
scanogram is missing. Truly speaking, in 2015, I was not much aware of this virus or something like that for this. Just after that case, I started getting this scanogram for failed ACL.
Okay. So I would get some stress views to see if it's reducible.
It is still unstable.
Yeah.
First slide was anterior door is positive, grade 3, pivot shift is positive, dial test is positive. Varus stress test is positive, valgus is fine, posterior door is fine.
So it's a failed ACL plus PLC.
It's also got a translational this thing, no? It's
Yes sir, there is
tibias-
translation of the tibia and femur.
Okay.
28-year male boy, both the side hamstring was used, one side BPTB was used. You can see the broken guide wire in that femoral tunnel that was used for the BPTB with bioscrew. So, what is the problem with the posterolateral corner in this case, Bhushan sir? Suppose dial test is positive, it means the posterolateral corner is not working.
Yeah, if the dial test is positive, then it's not working. Was he fixed in internal rotation or, was he fixed in external rotation?
No, its rotation was fine. So, by seeing the X-ray, the femoral tunnel is almost non-anatomical.
Yeah.
You must be agree, Bhushan sir.
Yes, I agree.
Yeah. So, non-anatomical reconstruction of posterolateral corner is very high chances of failure. At that same time, the femoral tunnel of the ACL is also non-anatomical. So, two ligament non-anatomical, very high chances of the failure. So, whenever revision is there, try to keep the reconstructed ligament at its anatomical position. So, this was planned further for third time ACL reconstruction with revision of the posterolateral corner. Here was the problem with the graft, because both the side hamstring were bone patella tendon, one opposite side was used, and not very much aware of quadriceps tendon that time in 2015. Now it again back with this. So that time the concept of peroneus longus was arising. Next slide please. This was the CT scan of this patient. You can see the two screw in the femoral side, lateral femoral condyle, with non-anatomically placed screw for the posterolateral tunnel. Next slide please. And you can see the tibial back please. You can see the tibial tunnel that was quite enlarged in this case. So next please. Next please. So revision was planned. The thing was with the staging. we planned for the single stage in spite of the TVL tunnel that was almost 12 to 13 millimeter was there. So we used bilateral peroneus longus. So peroneus longus gave us the diameter also, at the same time length also. One peroneus longus, quadruple peroneus longus for the revision of the ACL. The diameter was 12 for the ACL that time. So at that time we asked for the 12 millimeter diameter screws from the Arthrex guy. And from that time we have facility of that. The reamer was also called that time only. And another peroneus longus for the posterolateral corner. Next slide please. And this is the post-op X-ray operated in September 2015. On the tibial side, ACL graft along with the screw, it was augmented with the screw also. And on the tibial side, along with the screw fixation for the posterolateral corner, that is the modified lap rod, I use single screw on the femur side, and on the tibial side, rest remain the same. Bhutan sir, comment on the check X-ray please.
No, looks good now. It makes sense how anterior the original tunnel was on the femur for the PLC. It was way too anterior. It's as if someone tried to replicate only the popliteus and not the LCL, and that's why it all failed. So now you got a fairly good position. The knee doesn't look that bad now. How was the articular surface on the lateral side when you went in?
Little bit compromised it was.
Okay, but that looks good now.
Yeah. So next slide please. So this is the modification that I was talking about. So on the femoral side, single screw with a spike washer instead of the two screw that was demonstrated by the lap rod, and the graft get rolled in the same fashion that is there. So along with the bio screw in the tibial tunnel, the remaining graft were fixed with the spike, staple also in this case. That's why a staple was there. So double fixation on the tibial side for the ACL also and for the posterolateral corner also. So next slide please. So this was the X-ray almost after 1 year. The subluxation of the tibia femur was almost obliterated. It's now absolutely normal. And lateral view also looks fine. Knee is reduced. Lateral compartment looks better. And this time patient came for the screw removal on the tibial side that was there. And at the same time patient got married also for last 3 years. Now that time he was 31, back to job, doing everything. Next slide please. This was after removal of the screw. Next slide please. And this is 2021, the morning time at the Bangalore. Next, can this video can run? This guy was from my village area. Initially I used to refuse the surgery for him, but somehow I operated in with very much fear in the back of mind. But you can see the result of this patient. And next please. And rehabilitation in this re-revision type of cases, particularly for the posterolateral, it should be slow. So we started range of motion after 1 month only and weight bearing after two months only. Next slide. Thank you.
Thank you, Dr. Arvind.
Dr. Arvind, what were the challenges faced in the tunnel placement, considering this was a re-revision case with all the implants in situ?
In fact, truly speaking, it was very easy because tibial tunnel was almost here. There was no problem with the tibial tunnel. Only I have to take the plate from the tibia that was there. And I made as the straightforward all the tunnel for posterolateral corner. On the femoral side, posterolateral screw side was virgin. There was nothing, previous surgery part was there, because previous surgery was quite interior and little bit proximal. So really operating part was completely virgin. So I don't have any problem with the femoral side. Tibial ACL part, I use 12-way screw with graph diameter of the 12 with extra fixation on the tibial side. So that's why I keep the rehab slow, range of motion after 1 month and the weight bearing after 2 months only.
So it was a good thing that the previous tunnel on the femur was way away from where the actual tunnel had to be.
Thank you, Dr. Arvind.
So we'll close this session now. Thanks, chairpersons, and we'll move to the next session. May I invite the chairpersons, Dr. V.K. Sinha, sir, is here.
Dr. Jasminder, just a second.
Yeah.
Am I audible there?
Yeah, please.
For John sir it is. Sir has to come at Paras only after the lecture because this case is of ACL with varus deformity medial compartment. Meanwhile, I am doing ACL reconstruction. Then sir will do the high tibial osteotomy in this case. Okay, so it's a case, next case of ACL with HTO.
The chairpersons for the next session, Dr. V.K. Sinha, sir, Dr. Ranjit Singh, sir, Dr. Praveen, sir, Dr. Rajiv Raman, sir, and the next talk is by Dr. John, sir. It is on evaluation of HTO. Evolution of HTO, sorry.
So, I welcome Dr. John for his wonderful lecture on HTO. Few years back or some time back, there was TKR, and TKR. Now there is another wave of HTO, and he is one of the best person to say final words on this subject. So I invite Dr. John. Dr. John, please.
Thank you, Dr. Sinha and Dr. Praveen. I'm just going to talk very briefly about the evolution of HTO. Later. I think when we look at malalignment, until recently or until the turn of the millennium, there's very little evidence to show that malalignment caused problems. There were a couple of Swedish papers which showed that if you had early osteoarthritis with varus, there was a chance that it progressed a little quicker. But it was really around 2001 that the first paper directly correlating malalignment with osteoarthritis and progress of the disease was written by Sharma et al. When they looked at 237 patients, and they found that if you had a varus alignment, the odds for radiological progression increased fourfold. There was another paper from the Japanese authors, Miyazaki et al., which looked at varus with dynamic loading. That means there was a varus thrust when they walked, and they found that increased the risk of progression. And another paper in 2013, more recent paper by Felsen et al., which showed that a frontal plane deformity of more than 3 degrees leads to osteoarthritis and should be corrected. And they found that if you had 4 degrees of deformity, there was a 3 times risk of osteoarthritis. Now, high tibial osteotomy has a long history dating back to the time of Folkman, but it was really in the 1950s and 60s there were a few papers which came out on it, and this one by Coventry in 1965, which made this procedure quite popular. And this was the paper in JBJS by Coventry based on the osteotomy titled Osteotomy of the Upper Portion of the Tibia for Degenerative Arthritis of the Knee. Now, unfortunately, subsequently, a number of people who were doing osteotomies started looking at their results more sort of carefully in terms of how long it lasted. And when you looked at Coventry's results, which were very good at 5 years, by 10 years, this successful result came down from 87% to 69%. Ritter and Fechtman, who at 2 years had a 95% good result, was down to 58% at 10 years. And Hernigu et al. In France, who did open wedge osteotomies, Their 5-year results were 90%, but by 10 years, it was down to 45%. This was the subsequent paper by Coventry et al., where they looked at a number of cases over a long-term period, 87 cases, which they looked at long-term and found that the results deteriorated with time. Similarly, Hernigu in 87 published his results and found that the 5-year results were pretty good, but by 10 years, the results were poor. Similarly, there were open wedge osteotomies described by Pudu with an interpositional plate, which is still used. And also you have the gradual correction using the distraction techniques of Ilizarov. So this was the paper by Hernigu, which again came out in 87. The Mackay dome osteotomy was the other method of osteotomy. Mackay never published it himself, but the technique was published by other authors, and basically it was a curved osteotomy in the upper tibia just above the tibial tubercle, and this could give you more correction, and the use of the external fixator allowed a certain amount of adjustment to your corrections. Okay, so there were some advantages of the Mackay dome, which gave you better and more correction and the adjustability with the external fixator. And you had the ability to tighten the MCL without affecting the patellar tendon. However, you had the problem of the external fixator, which is something which people don't like sticking out of their bodies. And another thing was that if you looked at the dome, it was pointed distally, so your cora was actually further away from the knee joint than it would be if the dome was the other way. Now, looking at these bad results, people kind of tried to analyze which patients had bad results and why. And this study by Berman et al. Looked at 39 osteotomies, out of which 10 had poor results. And they found that really the indication for many of these was not correct. So 4 of them were for diffuse degenerative arthritis. That means the opposite compartment, the lateral compartment, was already involved. 2 had inflammatory arthritis, that's rheumatoid, etc., which it didn't do well for. 1 had a prior septic arthritis, and 1 had severe post-traumatic deformity. This other study by Chilag et al. Looked at the quality of surgical technique. So they looked at 30 osteotomies with a 51-month follow-up. 43% were satisfactory, 57% were unsatisfactory. And out of the 17 poor results, 10 had major technical errors of either over, under correction, or joint penetration. But they found that all the 13 that had good results really were done technically correct. So therefore, for the HTO to be successful, you have to have the right indication in the right patient. You need to do the correct amount of correction. And of course, the technique and soft tissue consideration must all be taken into consideration before you do your surgery. And now we all talk about the ideal candidate, which is more mythological than actually exists. Very rarely do you get the ideal patient to do it. But we do extend the indications to a lot of things. But remember the things I talked about, like rheumatoid arthritis, or where the lateral compartment is already involved, those would really be contraindications. A bit of patellofemoral arthritis is not really a contraindication. Now, Drew Pelly in 1994 looked more closely at osteotomy, and he did a lot for the way we plan our osteotomies in terms of the level of deformity, whether the joint line was involved or not, the sagittal plane also, which is something we didn't look at all, and also ligamentous laxity. So he devised this reverse dome osteotomy, which we will talk about a little later. The questions that were there in everyone's mind was 5 to 7 years really the endpoint. What are the inherent limitations? And is TKR after HTO really a problem? And I think when we look at osteotomies done with better techniques and better indications, the results are much better. And Naudi et al. In a 10 to 22 year follow-up had 80% survivalship at 10 years, so much better survivalship. And they found that patients who were younger or who did not have or had a good range of motion were the ones that did better. Sprenger et al. Similarly, 76 osteotomies. These were closing wedge with internal fixation, 90% survivorship at 10 years. And similarly, you have a number of papers from Asia which have results going as far as 20 years, doing pretty well. Although one of the more prime things were most of them had precise restoration of the valgus angle. What about TKR after HTO? I think this paper by Pavesi et al. In 86 really put the cat among the pigeons, and they showed a high rate of radiological loosening and high revision rates with TKR done after an HTO. So again, that became an issue for people, so they said you shouldn't do an HTO because after that a TKR would be difficult. However, there have been papers, this was by Ritter et al., which looked at 39 bilateral TKRs where one side the patient had an HTO and the other side they had not, and they found no difference in knee scores, functional scores, or the x-rays in the patients who either had a HTO or not. Okay, similarly, there were other papers by Karat Botsos et al., which showed that really after an HTO, you were still able to do a satisfactory total knee replacement. Now, what was the problems with the lateral closing wedge osteotomy for a TKR? One was the loss of bone stock because you were excising a bit of bone. The second was scars and adhesions because your incision was slightly lateral and in the opposite direction of where you were going to do your total hip replacement incision. And also there was an alteration in the mechanical axis because if you're doing your osteotomy away from the cora, you need to translate. So this led to the lateralization of the tibial peg. So here's an example. This is not one of my own cases, but from the internet, where they showed that when you do a TKR after an HTO, you end up with the peg being more laterally. Okay, so if you want to get the axis right, the peg has to be much more laterally. Okay, now the other problem with the closed wedge osteotomy was the lesions of the peroneal nerve. Now these were not all frank foot drops, but if you did EMG studies, there was a fairly high incidence of abnormalities in the common peroneal nerve after a lateral closing wedge osteotomy. The other thing was the assessment of your correction because this 1 millimeter equals to 10 degrees was based on an average size of the tibia, proximal tibia being 56 millimeters in width. Okay, it's only then that 1 degree will be equal to 1 millimeter when you're doing your correction. Okay, now the dome osteotomy, which was popularized by Dropelli, was this smiling dome where the dome was in the opposite direction, and what it did was it brought the cora closer because you had a dome like this and the cora was closer to the joint line, so the amount of translation you needed to have was less, and it was very simple to do because we did a few of these earlier where we just draw this kind of arc with the center at the knee joint, and then you did your osteotomy through that region, use the Elizarov to correct it, and you could adjust your corrections if you needed to. And these did quite well. So this patient who did very well, and this was him in about a year and a half after the osteotomy, and then he came back 10 years later, and his knee, which was, we did the osteotomy, was still doing well, while the opposite side, which was okay at that time, had developed quite frank osteoarthritis, had varus, and even had a fixed flexion deformity. And I felt it was too late for an HTO, but he really insisted on us doing the same thing, even though, as you can see, he had a significant fixed flexion deformity by then. So we ended up doing an osteotomy for him with a ring extending above the knee to correct his flexion deformity, and that's what we ended up with. He still hasn't come back to us now, so I don't know if he's still okay or not, which is now more than 10 years. Rapid healing of the osteotomy. So I think I'm not going to go into details of the technique, but just to say that we all know arthroplasty has good results, but when you look at younger active patients, we have to think about the next 30 to 40 years. We also have newer techniques in the treatment of early osteoarthritis like chondroprotective substances, microfractures, which we talked about earlier, reimplantation of cultured chondrocytes, meniscal grafts, and cartilage transposition. So all of these techniques to succeed need a good alignment. So I think the HTO will continue to have a role. The take-home message is that I think HTO works, and you're going to see it in subsequent lectures. I think there's a resurgence of interest worldwide. Okay, so now if you look at Europe, you look at Korea, a lot of people who are having total knee replacements earlier are now having the HTO, or they really have to show that an HTO will not work for them to be allowed to have a total knee replacement. You have a number of techniques and implants. I think the Tomofix is one way, but there are other methods and techniques which work. And the other thing is that you can combine it with other procedures. So like the one we are going to do today is a combination of an ACL reconstruction with an HTO. So you can actually do ligamentous reconstruction, your meniscal problems, etc., along with the osteotomy and to give the knee a longer survival. Thank you.
Thank you, John sir, for your excellent presentation, and we have very good message inside this. Thank you, sir. Our next speaker is Dr. Ratnesh Singh.
Okay, so,
Please.
yeah, so I'm going to carry on to the hospital for the life support.
Yes, sir. Hello.
Thanks, sir, for my introduction. I'm presenting here two interesting case of high tibial osteotomy. The case one, 77-year-old female patient presented to us with the knee pain for the last 5 years in January 2017. X-ray was done and it was osteoarthritis, both knee. Left more than right. This is the X-ray. Pre-op X-rays done in January 2017. So, treatment options, what do you think here? This is the pre-op 77-year-old female, bilateral knee. Treatment options, what we think first? TKR obviously. But what we think the patient may not. So what if the patient says no? Conservative, she was already on conservative treatment for the last 5 years. So she opted for high tibial osteotomy. This was the immediate post-op X-rays. First left side was done in the January 17. 2 weeks time. This is 6 weeks. You can see good healing of the osteotomy side. This is a 6-month follow-up. These are clinical pictures at 6 months. At this time, she was so happy with the HTO that she actually opted for the other side also. So she came for the surgery for the other side, and again she opted for the HTO rather than TKR. Another side was done in August. This is the 4-month follow-up time. Clinical pictures. This is a video of the same lady after 4 months of the opposite side. She was quite happy and she was doing well. 77-year-old lady, she can manage to walk pain-free. Now this is 5-year follow-up. She came last year. This is her clinical picture. And now she is 82 and she can walk pain-free, but now she is using this cane for the support also. But she is still happy with the surgery, and this is just a message we can do the HTO in the older patients also, rather than the usual indication in 5th or 6th decade of the life. Now coming to case 2, she was 50-year-old lady, came to us in January 2019, bilateral knee pain, again left more than right for the last 2 years. This was the X-ray. So first the left side was planned. You can see the varus, gross varus, and mainly the medial compartment osteoarthritis in scanogram. So we opted for the high tibial osteotomy, left side first. This was our clinical picture. In this case, we have done something different. So we opened the joint, removed the osteophytes, and then proceed for the HTO. Usual manner, cut in one plane, another plane. It is spreaded and check it on the C-arm. Laminized spreader is applied and the plate was fixed. In this case, what we did, we just put all the osteophytes in the osteotomy site, and we have seen the healing was quite faster and much better than the usually what we do. These are intra-op assessments we done under the C-arm. This is the final picture, immediate post-op. This is a 10 weeks time. You can see there is good consolidation and hardly you can see any scar in the osteotomy site. Healing was very good. This is 6-month follow-up. This is a 3-year follow-up. After 3 years, patient came for the another side, but this time you can see it's a tri-compartment syndrome. So we opted for TKR in this side. TKR was done now in February 2023, last month, sorry. She came for the follow-up, almost 4 years has gone. This is her clinical. She is walking pain-free and she is satisfied on the both sides. Means she is even happy with the STO and TKR both. Thank you.
Thanks, Dr. Ratnesh Singh, for your excellent presentation, and really it was very good to know that in 77-year-old lady also we can give good result if
This is a problem in
cases
our
are
society
well
that,
selected.
yeah.
Yes, because she does not accept arthroplasty, so STO is a better option in those cases.
Yeah, if the other compartments are not involved so much, then STO can be done even in 70 years.
Do you think STO is beneficial when there is patellofemoral osteoarthritis mainly, predominantly?
Some patellofemoral osteoarthritis can be acceptable. Even in this case, it was present.
Okay, that's nice.
Ideal candidate is very tough to get.
Yes, that's. Thank you once again. Our next speaker is Dr. Manish Kumar from IGIMS, and he is frequently doing all the arthroscopic procedures, and he will present his cases for HTO with ACL reconstruction. HTO with ACL reconstruction.
Once again, before I begin, PGs, SRs? None? Okay. So I'll give you a scenario and let's see what we can do. Now here's a case of 40 years male, height 177 centimeters, weight 88, BMI 28.08. Instability for 22 years. History of twist injury when he was 18 years old. He underwent a ACL reconstruction about 14 years after the injury. Somewhere in Nepal, okay. Now he had an injury again after 1 month of ACL reconstruction. And there was a recurrence of instability. The patient presented to us 7 years after the previous ACL. So I am saying instability of 22 years because he had an interval of only 1 month when he underwent a ACL reconstruction which failed because of the re-injury. So from here, my question to the house, how do we proceed? Any feedback? Anyone? Dr. Ratnesh? Any feedback from your side? Okay, you need an X-ray. So here's an X-ray. Now I had not seen an implant of this type earlier. Maybe I'm new to this field. So this was the implant. You can see a medial side osteoarthritis because the patient was 40 years when he presented to us, and he had an injury when he was only 18 years old. So this is the X-ray of the patient,
Anything else you want? MRI. Before MRI, I'll give you an alignment view. So the alignment view clearly suggests that is a medial compartment osteoarthritis. You can see a varus deformity of the knee. Now from here. Sir?
It's obvious is significantly varus, is loading the medial compartment, is already got medial compartment arthritis and is ACL deficient.
Right, sir.
So is either for a slope changing osteotomy if the lateral view suggests that, or for a ACL plus HTO.
Right, sir.
40.
He's only 40 years.
हम तो कर सकते हैं, but patient का क्या? 40 में he will only survive for 10 years.
सर 15 साल तक यूजफुल लाइफ रहेगा, फिर देखा जाएगा, बार सर्जरी हो रही. Okay, okay.
The MRI picture. Next MRI, the axial view. Now we calculated the mechanical axis and the different angles. The LDFA was 90 degrees, MPTA was 83, and the posterior tibial slope was 12 degrees. Now from here, what do we do now? ACL plus HTO? Okay. So first of all, the problem was the implants which were inside. Removal of these things were done, the foreign bodies, all the non-absorbed metals, they were removed. And the patient underwent an HTO procedure. This was the HTO which was done on 19th of August 21. And as you can see the alignment, it is quite good now. Now I differed in this case. I did not go for an ACL reconstruction at the same setting because I saw the history of the patient. He was suffering for last 22 years or somewhere the luck was not with him. So I thought if the soft tissue was also not good, the wound or the skin condition on the medial side was also not good. So I just tried a HTO first and then thought what to do next time. So this was the alignment. I think it's a good one. And then the patient was planned for ACL reconstruction. We saw on examination the different findings. The LET, we did an ACL reconstruction along the LET because the pivot shift was almost grade 2-3. So on examination and anesthesia, what we found, so this is the audio बंद कर देंगे. Hello, audio. So this was the pivot shift. So the intra-op status after the ACL reconstruction, a good ACL reconstruction was performed. With the stump sparing. At the same time, we performed an LET. The graft was passed, the IT band graft. And what we are doing at our center, we are fixing this LET with a staple, not a screw. So that, immediately after the surgery, you can see a good stable knee was achieved. So what I want to convey is, this is the POD5, peroneus graft was taken. Post-operatively, the status of the patient, a nice squat. The patient is able to squat nicely. And if you can see, very good and stable knee, very good alignment. So my take-home message, you should not be afraid of doing something. You should always try to conserve the knee first and only then think of a arthroplasty. Thank you.
Thank you, Dr. Manish. Our next speaker is Dr. Bhushan Sabnis, sir. His topic is planning and technique of HTO.
Dr. Manish planned LET because it was pivot grade 3 with laxity, or reason was different? LET.
This is a slightly longish talk. I'll try and go as quick as I can. So we're talking about preoperative planning of osteotomies, mainly HTO, and the surgical steps of the high tibial osteotomy. You're going to see Dr. John in action in a few minutes. So it will all make sense, hopefully, whatever you're seeing just now. So your aim is to get the alignment perfect so that the weight bearing axis passes through the center of the joint, and that's what you're going to do. The osteotomy as a surgery is a very powerful procedure. It's a very versatile tool. You can change in various planes. You can change the coronal plane, the sagittal plane, or rotational plane alignment of a patient. You can alter the slope of the tibia to compensate for ACL, PCL deficiency. You can unload the damaged area of the knee joint. You can retension some of the ligaments. You can improve range of motion, and you can even use it as an adjunct for other procedures, even when there is no arthritis. So there are a lot of things you can do. But what's important to understand is which bone and what correction you're going to do. So this has been a problem for almost more than 200 years for the world about what to do with this Leaning Tower of Pisa, and an osteotomy is the ideal solution for that if it works for this. So it's important to understand the deformity, that means analyze the deformity and then what correction can be done or what is required for this. A couple of books which are essential if you are interested in osteotomies and realignment procedures is the Kenneth Krakow book on analysis of axial deformity of the knee, the Drawer Perez textbook on principles of deformity correction, and the AO Foundation book on osteotomies around the knee. And all of these make a wonderful reading if you're interested in the axis. So the first step before you do anything is to get a good scanogram. So scanogram is a standing X-ray of a patient all the way down from the waist to the feet. And if it's done properly with patella facing forward without any rotation, which is calibrated and with adjusted pelvic obliquity, then you can decide what you want to do. TraumaCAD planning was a fantastic device, but suddenly they raised the prices by about 100%. So most of us have stopped using it. Now I use a Bone Ninja or another device called as OsteoMaster, which are software planning techniques for your osteotomies. So this is how a scanogram looks. So you can easily see the weight bearing axis of the joint of the body from center of the hip to center of the ankles, and then quantify the deformity. So the point at which that axis divides the tibial plateau is called as Mikulicz point and is graded from 0 to 100 from medial to lateral side. Obviously in this patient it's in negative 100 or negative 85. So that's a pretty severe deformity as such. The one on the other side is a pretty straightforward, about Mikulicz point about 20 or 30. Those of you who know me will know my desktop looks something like this all the time. So it's riddled with all scanograms of all HTOs that I tend to do. So you need to understand the basic axis of the knee joint. So you have the anatomical axis of the femur, which is essentially the diaphyseal axis. You have the mechanical axis, which goes from the center of the hip to center of the knee joint. And you have the mechanical or anatomical axis of the tibia, which is for all practical purposes the same. Now you measure the angle between the femoral axis, now we're talking mechanical axis, and the tibial axis, and that forms the HKA axis or the HKA angle, which is the actual varus deformity in the knee joint. Now this is one image that you need to remember if you ever want to do HTO, and the two angles which are important for you are the MPTA and LDFA, which are these two. So MPTA is medial proximal tibial angle, and the LDFA is the MLDFA, that means the mechanical axis of femur is considered here, and the lateral distal femoral angle, and both are around 87 degrees. Those are the values which are important. Now let's forget about sagittal plane today. We're talking more about the anatomical plane. So if you look at the weight bearing axis bisecting the tibial plateau on that image, I don't know whether you can see it properly, it's going just in the valgus side as compared to what it was before. Now this is the only photograph I could find of Fujisawa anywhere. So Funny enough, I've seen a lot of old Japanese people being projected as Fujisawa, but this is the real Fujisawa. And his definition of Fujisawa point has, I won't say bothered, but has confused everyone for quite some time. We no longer follow the Fujisawa point of 62.5 or 67.5 or whatever you want to define it as. We like to go in the valgus area of the joint, normally the lateral tibial spine or the downsloping part of the lateral tibial spine, which is corresponding to about 57 to 60%, and that is the right axis for correction. Now, important to know that you spend your time on your planning of osteotomy based on your knowledge. So the simplest way you can do it based on scanogram is a Miniachi technique, where you draw the weight bearing axis of the body, which is from center of the hip to center of the ankle. Now let's take a pathological case. So center of the hip to center of the ankle, that's the mechanical axis drawn. Now you want the axis to pass through the center of the knee joint, slightly more on the valgus side. So I've bisected the tibia to about 60%, so we're going in the 60% zone now. Now you draw another line joining these 2 points, exactly where the osteotomy, I don't know whether you can see it properly or not. So where your osteotomy hinge point is going to be, and that angle is called as the angle alpha, theta or x, whatever you want to call it. And the same angle is now subtended or drawn on the tibial side, and that's the amount of opening one must do at the proximal level of tibia. The dictate that 1 millimeter opening corresponds to 1 degree doesn't hold true. There is something called as law of cosines, and that only applies when the width of the osteotomy is 57 millimeters. So you should not be using that law regularly, but it can be a rough estimate of how much you are going to do. So this is how a deformity analysis is performed. So you find out the angles around the knee joint. So if there is a varus deformity, you find out where the varus lies. If it's a valgus deformity, you find where the valgus lies, and based on that you decide correction. You do not say that femoral deformity always causes valgus and tibial deformity always causes varus. So you need to find out exactly where your deformity lies. You can do correction for early disease or for severe disease. So for grade 2 or grade 4 arthritis, you can do correction. And when you're doing it for a more severe disease, your correction is much more significant as compared to when you're doing it for a less severe disease. You can play with the slope. So when you are playing with the slope, you want to flatten the slope or reduce the slope for ACL deficient knees, and you want to increase the slope for PCL deficient knees. That's all you need to remember. So based on what you're dealing with, you can play with the slope. I won't go into details of that. That's slightly more complicated. So this patient had a PCL deficiency. So in this patient, we increase the slope purposely rather than flattening the slope. So in such patients, it works quite well. There's another plane called transverse plane or the rotational plane for patellar instability. I have a lecture tomorrow on that. I'll talk to you about that. But this is what is required. This is called as a distal femoral derotation osteotomy of, along with varization. So it's slightly more complex field. Now, 90 out of 100 times your varus deformity will be in the tibia. So when you measure the angles, I know you can't see it that clearly, but that MPTA is 82, normal is 87. So your deformity correction is going to be in the tibia. Again, 90 out of 100 times the valgus deformity lies in femur. So that MLDFA value is 85, which is slightly less. So that needs to be corrected to a normal value. So it's a distal femoral osteotomy is required. But sometimes there is a valgus deformity coming from tibia as well. So this patient required a closing wedge proximal tibial osteotomy. And sometimes a varus deformity comes from the femur as well. So this patient required a closing wedge lateral distal femoral osteotomy to get the deformity corrected. So you need to understand that deformity can be contributed both from the femur and the tibia or isolated from the femur or tibia. So this is another patient with a very severe valgus, as you can see. And if you correct everything in one bone, you are going to get a very oblique joint line. There's a good paper by Babis which is quoted multiple times, which talks about the joint line obliquity. So if your joint line obliquity is more than 7 degrees, you're essentially screwed. The joint line is so oblique that the patient will never be comfortable. Every time the patient walks, the femur will be slipping on the tibia, and you will get a significant problem in these patients. So in such patients, you can do a double osteotomy. So you can do a femoral osteotomy as well as tibial osteotomy to correct the deformity, but to keep the joint line flat. It's a very important thing to understand. Another example, you can see the values, your MPT and LDFA both are slightly deranged. So you do both femoral as well as tibial osteotomy to correct the deformity as such. You can also do it for patients who have a medial meniscus bucket handle tear without any arthritis but with varus alignment, because it will never heal in varus alignment. You can also do it for transplants. You can do it when you do a microfracture AC or MACI on the medial femoral condyle. You can do it for SPONG conditions. You can do it for ligament reconstructions. So it's important to know that rather than doing a complex knee replacement, you might be able to get away with an osteotomy in most patients who are not having bicompartmental or tricompartmental arthritis. Dr. John talked about an ideal candidate. The only important part here I would consider is a non-smoker and a well-motivated patient. Everything else can be managed by osteotomy, in my opinion. This is generally how a standard osteotomy gives you a picture. So you can have an early disease or a severe disease, but not with subluxation. So there's something completely wrong about sublux knees, where you need a different kind of operation to correct the deformity and get the alignment sorted. So just a quick case, someone, a typical 45-year-old lady with a typical varus MCOA, that's the planned correction, and that's her 6 weeks from surgery, walking independently without any issues, with almost full range of motion in the knee, no swelling, and able to march. This is a very important test that I do in clinic. If someone is able to march on spot, that means they don't have much problem in the knee, and the core and the quads both are working fine. So that's generally how I would plan my osteotomies as such. So a quick go through surgical steps for the process. This is now the Bone Ninja software, which allows you to plan the surgery on screen before you even go in theater. So that's the planned correction that you're going to do. Now, before you start the surgery, on table you mark your landmarks. But before that, you clinically assess whether the deformity is correctable or not. The reason you do that is because this will decide how much release you're going to do for your MCL, because MCL release is a must for correcting the deformity. So let's go through a quick video. So a standard medial longitudinal incision, nothing fancy about it. You need about 4 centimeter incision on the medial side of the knee, midway between anterior and posterior side of the tibia. Again, everybody has a different preference. People do oblique incisions, which are absolutely fine. It depends on what you're comfortable with. Now the key part of the operation is releasing the medial side and creating a window for your surgery. So what I do, again this is what I do, everyone has a different way, is I make a L-shaped cut, as you can see, on the proximal medial tibia. So you can see the vertical limb, which is just next to the medial end of the patellar tendon, and a horizontal limb of the L, which is about 1.5 centimeters from the joint line. So I'm trying to avoid damaging the deep MCL, but I'm releasing everything on the medial side. So almost this is the subperiosteal dissection. We are all have done trauma, so we know what subperiosteal dissection is. So I'm just using my cautery and peeling off the whole of the pes fascia. And after a few minutes, you start seeing the MCL. You have to release the MCL pretty bravely. And believe me, even if you release the MCL completely, I'm talking of superficial MCL, the knee doesn't become unstable. It gives you a perfect view of your surgical site without any issues as such. So that's your MCL. You see how lax it is? Now I'm releasing the remaining MCL as well. So that's completely gone now. So that MCL is completely cleared. So that's what is required to achieve your medial release. Now the key part of the surgery is the posterior dissection, or putting a blunt humor on the back. This is an important component. It's a curved osteotome. It's a curved periosteum elevator which goes behind the tibia, and you should go all the way and hit the proximal fibula when you do this. So if you go all the way and hit the proximal fibula, then you are more or less certain that you are not going to damage anything on the back of the knee joint. That's a radiolucent curved homen, which is blunt, and that goes and protects everything on the back. Now you make sure your position is fine for the plate that you're putting. Next is a pretty straightforward thing. Once you're done the dissection, all you need to do is pass two guide wires, as you can see here. So your guide wires have to be starting about 3.5 to 4 centimeters from the medial end of the tibia, aiming for the fibula head, as you can see. Now sometimes the fibula head is quite high. So fibula head as a landmark is not a good point. So you should be at least 1.5 centimeters from the lateral tibial plateau to get a sufficient purchase. So those are the guide wires passed. As you can see, you have confirmed your position is quite good. And that's your osteotomy done. So you always go distal to the guide wires because you don't want to veer into the joint, and you are skirting the guide wire, kissing the guide wires as you go in all the way to the lateral side, and you take an X-ray to make sure that your blade is perfectly parallel to the guide wires and you're stopping well short of the lateral cortex by about 1 centimeter or so. So once you've done that, you do what is called as proximal biplanar osteotomy. This is about 110 degrees to the original osteotomy, and this is going under the patellar tendon. So there is a small homen which is protecting the patellar tendon, and that's the plane of the transverse osteotomy, and that's the plane of the biplanar osteotomy. It's important to do biplanar osteotomy so you can get sufficient purchase area for the plate to fix. So once you've done all of that, that's how your osteotomy will look. Now, and of course, this one different patient because you can see it's the other side. But once you're done this osteotomy, you will be able to stack in what is called a stacking of osteotomes. So you can pack in osteotomes very gradually so that you are able to open the osteotomy gradually. So you put two osteotomes, then third in the middle, then fourth between the second and third, and gradually tap it with while someone is protecting the hinge. Once you have done that, you will be able to see something like this, where you have created a nice wedge of area, and when you try and open and close it with a laminar spreader, your hinge is intact. So I do this for every patient that I do H2 on. Sometimes I'm not very sure of my hinge and I put a K wire on the side. That's called as a hinge protecting wire, and that works really well because then you can put a screw on as well on that wire. Now this is a good video. So the first one. Once you're done the osteotomy, you won't see the osteotomy cut because it's done very well. But then just moving the leg, you can see the osteotomy opening and closing. I hope that's making sense to most of you. This is followed by opening the osteotomy to the predetermined cut. So in this patient, it was 8 millimeters. So that's 8 millimeters in the posterior cortex and 5 millimeters in the proximal cortex. It's never a rectangle. It's always a trapezoid. So the posterior opening is always more as compared to the medial opening. Otherwise, the slope will change drastically. And then you assess the alignment of the patient using a long metal rod. I don't like to use a cautery wire because that's not a very rigid structure. So I like to use a stout metal rod going from center of hip to center of your ankle and find where I've got the deformity correction to. So this is slightly less than what I wanted. So I've increased the correction very slightly, and once I'm happy that I'm perfectly in the middle of the, on the tip of the lateral tibial spine, which is corresponding to about 57 to 60%, I'm more than happy now to accept this as the correction that I want to do. All that is left now is fixing the plate onto the bone. Now the plate is a T plate, it's a Tomofix variant from Indian company. Now fixation of the 3 proximal screws is done first, followed by fixation of a cortical screw in the first hole distally to get the plate molded onto the bone, and then fixation with remaining screws. So it's just like a normal plating technique that is done. So when you do that, you get a nicely fixed osteotomy, fixed with 4 screws proximally, 4 screws distally. All of them are locking screws, so you got a very stable construct where you can start weight bearing the next day of surgery without any issues. You can put bone graft in if you want, but it's important to understand that your fixation has to be very strong if you're weight bearing early. I think since last 7 years, I've been allowing patients to weight bear almost immediately now without any issues as such. So that's the same lady I talked about. That's how the X-ray looks, and that's her walking. I know she looks similar to the one that I showed before, but it's a different patient. Again, 6 weeks is sort of a standard thing. I make them walk from out to in. I make them sit, move the knee up and down, and then ask them to sit cross-legged if they can. So this is a standard thing at 6 weeks. So in 6 weeks, you should get patients walking independently, comfortably with complete quads activation and being able to do most of their normal activities regularly. For a working person, I tell them 6 weeks you can go back to work and driving also. So finally, this is how the osteotomy goes. 2 K-wires which are going from medial to lateral, aiming for the fibula head tip or 1.5 centimeters from the lateral joint line. You make your cuts, you stack your osteotomes to open the cut, make sure the alignment is perfect where you want it to be. Then you put a plate in and you fix it proximally and distally to get your osteotomy fixed. However, it's very easy to overcorrect this. Now, this is a patient referred by someone to me. If you look at the overcorrection that's happened, and if you look at the joint line is massively oblique. The weight bearing axis is around 90%. It should have been at 60%. So this patient required a revision, whether I had to undo everything. So I did a closing wedge osteotomy of the open wedge done before and fixed it with a screw laterally along with a plate on the medial side to give an acceptable correction, and she did really well. So it's very easy to overcorrect. That's why you need to assess on table despite doing everything that you have done in preoperative planning. So ultimately it's a very, very good option for joint preservation of the knee joint. Not everyone with osteoarthritis is for TKR, since not every TKR is happy, but HTO is a good option, will give easily 10, 15, maybe 20 years to young patients who want to stay active. I allow my patients to run after HTO. There is no restriction on them. I allow them to do hard labor also. I think there is no change in the results of TKR after a well-performed medial opening wedge osteotomy. The modern fixation techniques, the Tomofix or variants of Tomofix work really well with excellent results that can be achieved. Thank you.
Thank you, Dr. Saab. Thank you very much for your very good and excellent paper, giving all the details of the HTO. Our next speaker is Dr. Arvind Gupta, and he will be speaking online from the Paras Hospital. Dr. Arvind Gupta, are you ready?
Need that.
That's very clever. So essentially there is no way of replicating a standing position when the patient is lying down. So what you do is push the knee from the lateral side when you have corrected the varus. So there is a paper by a Korean group which talks about giving 55 newtons of force from the lateral side to emulate or simulate a weight bearing status. I don't think that's a very right way of doing it, because body weight is different for everyone. But if you get a correction in the valgus zone, even if that changes by 5% or 10%, it won't make any difference. As long as the weight bearing axis is in valgus with good medial opening, you should be happy.
What would be your indication for bone grafting?
So anything about 10 millimeters of opening, I bone graft normally. I use allograft, I don't use autologous graft, but it works quite well in my hands.
Do you repair MCL which you erased?
No, leave the MCL like that. So MCL falls back and scars exactly where it is, in a lengthened position. If you start repairing the MCL, then you are going to have severe pain on the medial side. If you don't release the MCL, you will surely get a hinge fracture or a Takeuchi type 3 fracture, which is going in the joint. So MCL has to be released, otherwise it doesn't work.
Excuse me, sir. So you have talked about the flattening of the slope in case of ACL. So how to calculate that one, sir? How much to flatten?
So there is a formula for that, but roughly speaking, every 2 millimeter opening corresponds to 1 degree. So if you change the slope, the difference between the posterior opening and the anterior opening, if it's more than 2 millimeters, you are changing the slope by 1 degree.
No, sir. Like if that is ACL deficient knee, and we are doing the HTO that time, how much to correct the slope? Means how much to flatten that one, sir?
So you want to go in the zone of normalcy. The normal slope is between 3 to 7 degrees. Acceptable slope is up to 10 degrees. If you use the PTA axis, the proximal tibial anatomical axis way of measurement of slope, if you use that technique, I'm sorry if I'm not making sense to you, but there are various ways of measuring slope. The standardized technique is called PTA. So if you use the proximal tibial anatomical axis technique, then you have the slope between 3 to 7 degrees on the lateral side,
sorry, 3 to 7 degrees on the medial side and 3 to 9 degrees on the lateral side. So depending on what slope you have, suppose a patient has a slope of 12 degrees or 13 degrees, then you can flatten the slope. But if you're doing a revision ACL and the slope is about 8 degrees, you can still do a slight correction of slope toward 5 degrees. Now this 2-3 degrees depends on the variation of correction in the posterior and anterior plane. So I told you have to do a trapezoidal cut. So if you make a trapezoidal cut like that, that's anterior, that's posterior, then you are flattening the slope more. If you have a rectangular, you are increasing the slope by about 1 or 2 degrees.
His question was mainly as for my case. He had a problem. So could we manage only by slope correction?
Yes, yes, you can. For a low demand patient, you don't need a revision ACL or
Dr.
PCL.
Manish, we will switch to next, please.
Okay, thank you.
Dr.
Thank you,
Arvind,
sir.
are you ready in OT? Dr. Arvind?
Yeah, I am ready.
Yeah, okay. So we are running a presentation.
Yeah, I am ready here.
Okay.
Vinay,
Yeah, it's displayed here. Is it displaying there in the OT also? The presentation is on here. Dr. Arvind, are you with us?
yeah, I am ready here.
Okay, so can you see your presentation?
Yeah, it's a little bit blurred, but it's fine for me.
Yeah,
No
please,
problem.
please start it. Thank you.
So this is 58-year female having history of pain in the knee for last 1 year. And this pain get aggravated 3 months back. And it is so much severe that she cannot walk without help of walker or any stick. Next, please. So this was the scoliogram of this patient. So varus is very obvious. So Bhushan sir, any medial side pain that get aggravated without any very strong history of significant trauma, and patient is having so much difficulty that she or he cannot walk. And on examination, flexion more than 90 degrees, painful with medial side joint line tenderness is there. So what's come into your mind?
So this patient is having medial discomfort. And
Bhushan sir?
Yeah, can you hear me?
Yeah.
So this patient is having medial knee pain along with pain in deep flexion, you said.
Yeah.
Okay, so I'm looking at the scanogram, I'm looking at moderate varus, so I would be thinking of a medial overload along with a possible medial meniscus tear and possibly a mucoid ACL degeneration or ACL tear in the patient.
So 58-year male with medial compartment osteoarthritis, that is very obvious in the X-ray.
Then the
Did you
root-
ask for MRI?
Yeah, of course. So it can be a root tear also from what you said.
Okay, perfect. So next slide, please. This is the osteometer that says there is varus deformity of 10 degree, 11 degree. Next slide, please. So MRI was asked, and this is the medial meniscus root tear was here. So along with the medial compartment osteoarthritis with varus deformity with medial meniscus root tear. So how many of you will go for medial meniscus root repair with HTO, or how many of you will do simple HTO only?
Arvind, how long is the history? When did he have, when did he start getting severe pain?
For 1 year.
1 year.
For 1 year he has history of medial side pain, and for last 3 months he has significant pain, and she has visited almost 5 doctors in the city.
Okay,
but
so
whenever she used to walk, she has severe pain.
So from what you're saying, the first 1 year pain that you're saying is because of medial compartment overload or arthritis. 3 months is gone worse because of the root tear. That would be logical in my
Yes,
opinion.
sir.
So I don't know about others, but I think it's a good candidate for HTO, plus minus root repair, looking at the quality of the tissue. Though nowadays most people or most surgeons are deviating away from a root repair with HTO because the latest Korean paper states that the root tends to heal even you do HTO. But if it's a good quality tissue, then why not restore the anatomy? So I would do an arthroscopy, see the knee. If it's repairable, I'll repair the root along with the HTO. I don't know if anyone else wants to say anything.
Yeah, that's perfect, sir. My thought matches with you also.
Dr.
So next
Rajiv
slide,
Raman
please.
is saying something.
Arvind,
Yeah, Rajiv boss.
so whenever you are planning for STO, how often do you do for routine and diagnostic arthroscopy? Go for.
For me, almost each and every cases, but with sir, almost in 30% of the cases we do
So
orthoscopy
I think
and
that is the
remaining
advantage
70
of,
to
yeah. So whenever I think we are planning for osteotomy, I think after routine arthroscopy, it's not only root tear, sometimes you have degenerative meniscus tear also. You can just debride that. And if you have a root avulsion, I think not repairing and coming out would not be a good option. So it's better to repair the root, and now we have good plates also where you can tie the knots with you can repair the root and go for HTO also.
yeah. Thank you. Next slide, please.
Arvind, just one more thing, Bhushan here. Uh, Unfortunately, I've been sued a couple of times in life, and one of the patient who sued me was a HTO patient, where I did not do an arthroscopy, and she sued me saying her pain was not because of arthritis, it was coming from a meniscal tear as was told to her by a surgeon, a friend of mine, unfortunately. So post HTO, she
Oh.
still had some pain, which miraculously recovered after arthroscopy and
Next slide,
meniscectomy
please.
in 6 months' time. So no. So since then I've started scoping every HTO.
Next slide, please. Next slide. So this was the osteometer. Next slide. And you can check how much correction and after correction how it looks. This was the planning pre-op. Next, please. And this was the intra-op picture.
And
So
that
you
is a
can
medical
see the
legal
cartilage
evidence also.
condition on the femoral side. Can somebody run the video, please?
So Arvind, this is very good. You have documentation also to what is the condition of cartilage. I think this is very important.
Yes,
So once
that's
you
the
put
main thing.
arthroscopy, you can document it. And you can see the root.
Yeah, you can see the here. Continue with the video, please. You can see the medial meniscus root is completely separated and tissue looks good. There is not much problem with the tissue. Only problem with the cartilage on the femur side. This is after the pie crusting. You can see how much this get opened.
So normally what happens, Arvind,
Pie
you get,
crusting of the MCL.
yeah, Arvind, you get two type of tear.
Yeah.
Sometimes there is a fibrosis between the root and your capsular tissue. Those tear with degenerative sometimes you can leave like that. It's like here it's a floating root. So I think you should repair it.
Yeah, it's floating root.
It's
You
a
can
floating
see
root,
the
you should
root is
repair
coming.
it.
Yeah, it's root coming in front of you and you put the suction there. So this is floating root.
So this
So,
might
next
have
slide,
been
please.
giving locking sensation sometimes also.
It's like meniscectomy, huh? Not more of a locking. Pain will be there, but patient will
Next
have
slide, next
severe
slide, please.
degeneration of the knee joint. It's like you have, there is no meniscus because with every stress, flexion, extension, meniscus will
Please
go
run the
outside.
video. This is after repair of the root. You can see the quality of tissue of the meniscus is good. There is no problem with that. And root has seated very accurately with 2 fiber tape there. Yeah, this looks perfect. This is the compartment, medial femoral condyle. ACL looks fine. Lateral compartment looks fine. There is no problem with the lateral. Next slide, please. Next slide. And this was the HTO done. So can see I have placed the 4 mm reamer in while doing HTO so that my screw should not collide with the tunnel. That was made for the medial meniscus root repair. Next slide, please. Next slide. So, next slide, please. This is the check X-ray. This is after maybe after 2-3 months. Next slide, please. Yeah, this is after 5 months of this patient. Now patient have relief of pain, but still she has little bit of the varus thrust. Next slide. Yes, done. Thank you. Any question, please?
It was nice presentation, Dr. Arvind. Even from Paras OT, you could do it. Thank you. Our next
So
speaker
we can
is
move to the live surgery.
No,
Yeah.
Dr. Arvind, there is a lecture which is
more
remaining
lecture
from
remaining.
Dr. Rajkumar. So you
We
can
will finish
You
it in
can
5 to 10 minutes.
surgery is going on, so uh, we can have that lecture after this live surgery. That is the STO by John sir.
Okay.
You can see on the
Okay.
screen.
Okay.
Okay, sure.
Please continue with live surgery.
Yeah. वहाँ खोलो निकल.
Dr. Arvind?
Hello. John sir? Hello. Hello, hello.
Okay, fine. And you can see, can you see what's happening here, OT?
Yes, sir. We can see the Siam images right now.
Okay, नाम दिख रहा है इधर में करो. Okay.
I think we can have two views, sir. One
Yeah,
camera on the
that's what
Siam and one outside picture.
दोनों व्यू दिखाओ ना. तुम यहाँ आ जाओ ना. कितना बार बोल रहा है तुमको? इधर से तुमको कुछ ऐसे आ जाओ इधर. बस थोड़ा दूर में रहो. इधर आओगे तुम. Okay, so basically what's happened, this patient has a 6-month-old injury.
Sir, can you show the pre-op X-ray?
He has a mild varus. Yeah, we'll just show you the X-rays. Okay, he's got a mild varus. Hello?
Hello, sir. Yes, you are audible.
Okay, so he has, he's going to have an AC construction. Arvind has started it, he's done the tunnel, but he hasn't put in the graft yet. Okay? And so he actually made a oblique incision. So we've extended the incision proximally and distally. Okay? So X-rays dikha dena mera.
Sir, we need to see
it's
the
not a very
Pre-op
bad
X-ray,
thing.
sir. Can we see the pre-op X-ray?
We are still seeing
Yeah, yeah,
only,
sure.
only the Siam picture is seen here, sir, not the other view.
ये वाला सियाम वी का दिखाओ यार.
The surgical picture is not seen yet.
Okay, we'll get it just in a minute. He's focusing on the X-ray. Okay, the MRI shows weight changes on the medial compartment. The lateral compartment is okay, and an ACL injury. Okay, so there's a very mild varus. Actually, it's I don't think we've operated done an osteotomy on a knee that is so straight but we're going.
Cameraman,
यहाँ
can
पे
you
ठीक से
focus on orthoscanogram? The X-rays? Hello? Hello? Hello?
Oh, yeah. Have you lost us again?
Hello?
Yes, I can hear you.
Yes, sir. We can hear you, sir.
Can you see the site?
Sir, we can see the operating site. If you can say a brief history and sir about the X-ray, because earlier it was not audible.
Pardon?
Brief history of the patient and the X-ray, pre-op X-ray.
Didn't he show you the X-ray earlier just now?
No, sir. He is showing the camera
X-ray
only.
नहीं दिखाया? एक्सरे दिखाने बोला था ना, वो नहीं देखे वो लोग. क्या कर रहे हो?
Just focus on X-ray, then sir will speak on that. Yes, sir. It's an MRI. हाँ, right side. वो जो X-ray है उसको हाँ zoom कर दो cameraman, just zoom it. Yes, yes
Zoom
sir.
कर दो.
No, MRI. Yes, yes, yeah, this. Yes, sir. Now we can see the X-ray, please, sir.
Okay.
So how
Is
much
that
was
okay?
how much was the MPTA, sir?
आवाज.
Sir, there is a question. What is MPTA? We have a orthoscanogram? We have measured the angle also.
I can't hear you.
Sir, what was
Rajiv.
the MPTA?
लंबा वाला करो.
Yes, sir. We can see the X-ray now.
Okay. So अरविंद को क्या बुलाना? Okay, so one of the tendons, the tendinosis has been taken. The gracilis is still here. That's the whole ACL tunnel. Okay. So we'll just put something there. नहीं रीमर there. इसका MPT क्या है चल? MPT and others angles. उसमें डाल दिया. Can't see the X-ray. So just tell them. What's the MPT? Check कर लो. Okay, so now the osteotomy basically is above the pes, okay, and it is an incomplete osteotomy. Okay, so I'm just going to mark out the osteotomy. It's going to be, this is the tibial tuberosity, so it's going to be oblique down here, and then transverse. I'll just show you what we did. And I'm going to take this off for the moment so that, and we are going to go transfer. There, okay? So the MCL has been released and we go right to the back of the knee so that we can get our Bowman's down there, okay? This is important because cutting the posterior cortex is important. Okay, so you get your Bowman's down here, okay? One sec.
So you are planning for a biplanar osteotomy, sir?
Yeah. So the HTO, open wedge osteotomy, the way we do it today is always biplanar. Okay, so I'm going to put one A wire just below the hole that Arvind has made, and this is aimed at the top of the fibular head, or about a centimeter and a bit below the knee joint. Okay, so
All right.
image please. So that's going too far up. So Dikao. Okay, that's where we want to be.
Can you show the CM image? I think you can show picture in picture, one CM image and one
दोनों
poroperative.
दिखाओ ना साथ में. दिखाओ.
Cameraman, show picture in picture. So. Oh, there is only one camera? All right.
Yeah, no, there are two. The one guy had gone for a walk.
Oh, all right. So yes, sir, we can see it. Yeah. So you are heading to,
Okay,
you are aiming towards the fibula head. Yeah, all right. Yes, sir. Now we
Okay,
can
so
see.
that's
Yes, now
the
it's good, sir.
first one.
Yes, sir. Now we can see
Okay,
picture in
next.
picture. Yes, sir.
Okay, इसको काटने के लिए. The second one I'm going to put more posteriorly. Show me that one. Okay, again parallel. Let's. You have to get out of my way. No, that's not the. ये दिखाओ ना मेरे को. Bob here. Okay. Listen, Zishan. Come here and help with the case instead of dreaming. Okay. Okay, so this has to be parallel to the other wire. Because. Okay. Because. Okay. Okay, so that's your two wires. Can we cut the wire? So we'll cut the wires short because otherwise they get in your way. One person holds the. Okay. So now we've got here. So the osteotomy is distal to the wires but proximal to the pes. Okay. Lever please for the back. So the MCL is out of our way here. One sec, just wait. Okay, so you have to make this space. This is very tight in patients. Okay. So we use a small saw blade for the anterior part of the osteotomy.
Medial cortex.
Thick one, so I'll do the back first. (180°). Yeah. Okay, so show me here. Bend the knee a bit. Keep the knee a bit flexed when you're cutting the back. So this has to be distal to the wires. Okay, so it's always you have to remember that. Because the wires are protecting you from the soft bone above. Huh?
And knee is in 20-30 degree of flexion, sir. You have kept a bolster also.
At this stage,
Yeah.
there's a bolster here. Plus
Yes, sir.
The okay, so you see the piece in the back.
Yes.
And you have to make sure that the posterior cortex is fit. Okay. Image, just take it. Okay, so the direction is okay. Tablet. So, and the anterior part of the osteotomy is a complete osteotomy. Okay, so just
So do you put any Homan just underneath the patellar tendon? No.
It's dissected out quite well, so I don't need to.
All right.
You can see that there. So I can actually visualize it. So you have to start the cut a little perpendicular, otherwise your saw tends to skive off. Then go horizontal. Okay, so you cut across, so you go right across. So this is a complete osteotomy, okay?
Yes, the oblique osteotomy is the complete one. Yes.
Yeah, so you're going right across there. You make sure your two are touching. Okay, so now once you've done that initial part, then you start with your osteotomes, okay? Start with a broad osteotome. So again, you have to make sure that your posterior cortex is being cut. दिखाओ. Okay?
All right, sir.
दिखाओ. Someone look at the markings here. How much have we gone? 30, okay, so this will go at least 40. दिखाओ. Okay, what's it that? दिखाओ. So a little more and we are done.
Up
Okay,
to
दिखाओ.
75 to 80% here.
Okay, so that's about as much as
Yes.
far as we go, okay? Next. So then we use the next one.
So still your posterior cortex is intact, sir. You have not, you are anterior to the.
You see that here, it's cut here.
All right.
Artery forceps. Hang on, I'll show it to you. So that's our posterior cortex. Can you see that?
Yes.
So I think it's as cut as it can be, okay? You happy with that?
Yes, sir. So.
Okay. So that's the first part you cut. Okay. And that's important because otherwise the slope will go haywire. Okay, so then next one is just parallel and ये दो बार आवाज क्यों आती? I keep hearing myself.
There is an echo, I think, inside.
Yeah, okay, can you see that?
Yes. So you have put in the broader one first and gradually you are just widening the osteotomy. Yes. Yes. You are not audible, I think, sir. Hello? Hello? Hello?
Hello, can you hear me?
Yeah, now we can hear you, sir.
Okay.
Yeah.
I think it looks like the second sound is the one that goes to you. If I can't hear it, you guys can't hear it. Okay, so can you see what I'm doing?
Yes.
So this is the fourth one. Okay, let's see that. So I think with one enough, now we take this out, okay? So they all come out. Okay, now you put in, so this device is
Spreader.
important thing. Okay, so we want to do a Bowie check now. We'll do a Bowie check. Show you guys this. Center of hip, please.
So you are using
Upar,
a
upar.
diathermy cord. Yes.
Yeah, it's not the best, but
Yes.
ucha karo.
And the assistant should lift the leg, I think, yes. So it should not be in flexion
Yeah.
here.
Yeah, we'll do that.
You lift the leg, then, yes. Sir.
Keep it internally. I mean, hip joint दिखाओ. थोड़ा नीचे होगा. हाँ बस हो गया थोड़ा ही सर. What shadow are we seeing there? Okay, I think that's about right. Come to the bottom. What's your thumb there? Listen, keep this in the correct rotation. Yeah? Okay, so we've got that. थोड़ा सा lateral जाए. यार एक हाथ से इसको दूसरे हाथ से वो करो ना.
So knee in extension and patella should face towards the ceiling. Yes, sir.
Yeah.
Yes.
I'm trying to get that to happen.
Yes. I think
Go
rods.
more lateral. Not that much time. Come back. Lift back lateral. Do little bit at a time now. Dikhao. Yeah, that's about right. Okay, so now come to the knee ke paas. So keep it medially. Let's see that. Okay, so it's just.
So what is your ideal point, sir? Lateral to the tibial spine, over the lateral spine?
Okay, so we are aiming for lateral to the medial spine. So we will be aiming for it to come close. Dikhao. About there, okay?
All right.
Okay, chalo. So, so I think different sort of situations. Yes, I think we'll get out of it. You can't stress the knee, okay? Is it okay? Just, have you assisted him? Oh. No. Mop. We need to cut these. We'll just cut the wire because it's getting in the way of the instrument. Okay, so this instrument is at 0 degrees when it's totally closed, and as you turn it down, it will open, as you can see there. Okay?
Yes.
And that gives you the angle of correction. Okay?
Cameraman, if you can zoom in, so sir can show where to put this spreader. What is the ideal?
This should be there at the posterior cortex, okay?
Yeah.
So you have to make sure that dikhao. So you want to go all the way till you made your cuts. Just move. Dikhao. A little bit more. Dikhao. Just a little bit more. You have to be very careful through these steps. Almost always when something goes wrong, it's because you lost your concentration for some time. Dikhao. Bit more. Ab dikhao.
John sir, do you prefer putting a prophylactic hinge wire on the lateral cortex?
I haven't done it yet.
Oh.
But if you want me to, I will. Okay, so who's going to do the correction? Okay. So just, huh? ये वाला देख लेंगे. Okay. So in this, we are probably looking at about 7 or 8 degrees only, but we'll check it. इसमें सीधा रखो. And when you're doing the correction, keep the knee straight because you don't want a flexion deformity. नीचे करो. Okay, चलो. How much is that? तुम लोग क्यों गुड्डू? Relax, relax. How much is that? 10. वापस जाओ. But that's okay. So let's see the. So at this time we check the axis again. So again, just osteotomy. See the front of the osteotomy at all, okay? Artery forceps. So you see this, the the oblique part of the osteotomy is still in contact with this part of the bone, okay? Can you watch that? Can you see that?
Actually, it's glistening over that area. Yeah, now we can see that part, sir. Cortical.
Light थोड़ा कम करो.
Yeah, now the contrast is good. Yes.
Okay, see this here and just to show. Of course.
So for the benefit of audience, where do you want to put this lamina spreader, osteotomy spreader?
So this, like I said, now
Yeah.
I want more posterior.
More posterior.
So that the posterior cortex is definitely opened, yeah. Okay, so that's about.
And sir, what are the tips to maintain the neutral slope? If you don't want to change the slope, what are the tips?
So if you don't want to change the slope, correcting it, you're not correcting over front or back, okay? आगे चलो नीचे. So in this case, we are not trying to change the slope, yeah. Okay. So they have not looked at it before.
Yeah, I think the bars are coming in, yes, sir.
Yeah. Okay, that looks okay.
Yes, sir, we can see it. Yes,
Now,
it's on
now
the
come to
center.
the okay,
Knee joint.
Okay, so that's
Yes,
corrected,
sir.
yeah?
Yes. Lateral.
Okay, so that's as much as we want. I'm going to, now, once you've done that, you put the head in here, okay?
Yes.
Hammer. So this is a way to keep your position when you remove. निकालने के लिए अब वापस करो. So now you take that off. Laminar spreader then. So the laminar spreader, you go right at the back. थोड़ा सीधा करो. Then click. Okay. So just when hyperextend. Okay. See it now?
Yes.
You should actually check your correction at. एक बार फिर दिखा दो. ये वायर निकालने के लिए. So now you have to take out the anterior wire because that will get in the way. Tomofix दे दो. So I'm going to see Tomofix if the tunnel, we'll go for the polyaxial plated. दिखाओ. So that's pretty good. So we can avoid the tunnel. Okay.
All right. So.
Okay, just check the alignment again. You need to go. ऊपर क्या जा रहे हो? Go laterally. थोड़ा lateral जाओ. Little more. Push a little more. थोड़ा सा. Okay, fine. Ankle, rotation. कितना बार बोलेंगे? थोड़ा सा lateral. Bit more. Okay, good. अब इधर देखो. Okay, so that's about what I wanted.
Yeah.
Okay. It's a, okay, so now the plate, ये वाला देना वो होल में डाल के लिए. So the
So you are using sir Tomofix, I think.
yeah, I'm going to use it because that's the one I like. Well, I'm used to it. Okay, so it's a little bit lower. Okay. Now, usually I put one of the top screws first, okay?
Yes.
Sir, इसको plate को रखो. ऊपर दिखाओ. Because you want to make sure your level is correct, huh?
So you do you prefer to put plate over the pace or under the pace, sir?
So it's over the best, but we're using a spacer, yeah?
All right.
So you're not compressing.
Mhm.
Little higher. ऊपर करो. ऊपर. हाँ, just hold it there, hold it. दिखाओ. That looks good.
Yes.
दिखाओ. दिखाओ. अब दिखाओ. कितना है? 70 हो गया. 70 देना. Hold everything in.
Over the pace. So once you're passing it over the pace, so when you want to harvest the graft in next time, that's a problem.
He's already harvested.
Already the graft has been harvested.
And it is still.
Suppose it doesn't. Suppose it doesn't
Okay,
need
so-
a ACL reconstruction.
Okay.
Later on, if he has.
I hope he's already measured that.
Yeah.
Drill. Good. Hmm? Measure.
Because I have a habit of putting it under the pace.
32. So once you put that screw, you can take out all the other things and check. तो डाल देते हैं. क्या हो गया? हाँ? Okay, so now you take out everything. एक सेकंड. Okay, ऐसे देखो. चलो अब दिखाओ. Okay. Lateral दिखाओ. Yeah, but you already. दिखाओ. सामने से हटो ना तो यार.
Yes, all these screws are yes. Under.
Okay, and the slope
Yeah,
is
yes.
okay.
Slope is okay.
Want to make it.
And there is no intra-articular penetration. Yes, sir. Perfect.
So it looks okay, yeah?
Hmm.
चलो, हट जाओ। अब हो गया ना? So now we put the rest of the screws, spacer निकाल। And your ACL tunnel is still okay. Last में ये जाएगा कि नहीं? या छोटा screw डाल देना। Drill. चलो। Measure. So that's what. Shock limiting.
Sir, AO came with the principles of golden screw. So for benefit of audience, what is this golden screw in HT?
Golden screw is this first conventional screw that you put in, because that's golden in color. So what it does is, okay, so two things it does. One is it tensions the plate, okay? So if you see the shape of the plate, it actually changes. And the lateral cortex gets compressed in a way. So if by chance you crack it, so you see this, in fact, and that's ideal because it shows a
Yes.
bit of, no, but it shows that it's, अभी दिखा देगा ना? एक बार अभी दिखाओ ना। So now you see that, yeah?
Yes.
Okay, so that little opening there, it's compressed it, yeah? Okay, so then you don't need to worry about that. You just mobilize the वो लगा दो तो स्लीव उसका ड्रिल और स्लीव दे देना इधर देखिए स्लीव तो नहीं ना इस तरह नहीं student it will go down. So it's not hitting that.
Yes.
And this goes, this is an important screw because it's oblique.
It's almost oblique and parallel to osteotomy also.
Measure दिखा दो फिर. Again, just check that you're not going out. So it's going out there. 65. Okay. And always check the direction because sometimes
it goes
because
intra-articularly.
if it's soft bone, it can change tracks without you realizing it. Yeah? Okay.
Yes.
So now there's one thing left here. If that's hitting that, you put a unicortical small screw. Not hitting it, hit it all the way. Locking here and we are done. Okay. Chalo. So I'll leave it to Arvind to finish off the rest. Thank you very much.
So what is your weight bearing protocol after osteotomy?
That's a good. So we actually mobilize them straight. I mean, that's after the first dressing or second day. We get them.
Thank you, sir.
Okay, bye.
Arvind, should we continue?
Yeah.
Next session.
There is one more talk. Rajkumar sir will give his talk tomorrow. There is one more talk left that Rajkumar sir, we have planned sir's talk for tomorrow as I told. And before closing this session, uh, may I request Rajiv Brahman sir to please felicitate. N.K. Singh sir is here or is not there? N.K. Singh sir is not there, okay. Then Pavan sir, okay sir. So may I request Rajiv sir, Vidya sir to please felicitate our respected Dr. Pavan Kumar sir. Yeah. Dr. Anil Ram sir. Dr. Anil Ram sir is here. Is not here. Okay, sir. So, may I request Dr. Bhushan sir to please felicitate Dr. Vidyasagar. Yeah. Now Anup Kumar sir is not here. Okay. Dr. Avinash Kumar sir. Yes, sir. May I request Ratnesh sir to please felicitate Dr. Avinash sir. हाँ तो क्या होगा उनको दूसरे दे देंगे. Okay. Then Rajiv Anand sir is not. And Dr. Ramakant sir is not here. Okay. Dr. Abhishek Das sir. Yeah. Please, may I request Pavan sir to please felicitate Dr. Abhishek Das sir. Dr. Shaumedeep Datta sir. May I request Manish sir to please felicitate Dr. Shaumedeep Datta sir. And sir, VK Sinha sir is not here. And Praveen Sahu sir is here. He is also not left. Okay. John sir is not here. किनको बोले? May I request Rajiv Raman sir to please felicitate Dr. Bhushan sir. Oh, sir is here only or? Okay. Then, okay, sir. So, sir, please for Dr. Rajkumar sir please. Yeah. May I request Rajiv sir? Yeah. To please felicitate Dr. Yeah. Yes, sir. Yeah, please, sir. Yeah. May I request Dr. Jivendu Bhushan sir to please felicitate Dr. Bhushan sir. Bhushan sir, please. अब है सर आपका उधार Please, sir. Yeah. May I request everyone to please join us for snacks followed by the dinner. So, yes, sir. सर 7 बजे तो लिखा हुआ है टाइमिंग तो स्नैक्स के बाद फिर जैसा हाँ हाँ ग्रुप फोटो सर लोग भी आ ही रहे होंगे मेरे ख्याल से सर प्लीज
Smile. Okay. Thank you.